Hi guys, hope I'm visible to all of you. So the last session that we had planned, there were some technical issues and we had to reschedule it. Nonetheless, we're connecting today and we will be revising the important areas of medicine. I'm going to keep it focused or concentrated on only the important topics. And definitely it's not a conceptual review of medicine. Of course, that demands a lot of time. It is about quickly taking Q points that will help you to solve plenty of questions from medicine, right? So let us start from cardiology. So when we talk about cardiology, what are the important areas from which questions are asked? Mostly the JVP, valvular heart diseases, heart failure, and MI or ischemic heart disease. These are the standard four important topics. Apart from that, the rheumatic fever and the pericardial diseases, that is cardiac tamponade and constrictive pericarditis, are repeatedly asked. Here and there may be integrated questions integrated with physiology, and JVP and pulse are those two topics which can have integrated questions, right? So let us start with the pulse. So first question may be from physio, asking you to, like, they may give you an image of a pulse waveform and then they mark something and then ask you what does that indicate. So how do I answer those questions? So to answer that, we need to know the pulse waveform. So what is this pulse? Pulse refers to a pressure wave. Pulse is a pressure wave triggered by ejection of blood by left ventricle into aorta. Means when left ventricle ejects the blood into aorta during systole, it increases the pressure in the aorta and that triggers a wave. That wave travels across the wall of the aorta to reach all the arteries. So it's a pressure wave triggered by left ventricular ejection of blood into aorta, right? Now, if it is a wave and if I am adding blood into the aorta, so of course the pressure increases, but as the blood moves forward, the pressure will decrease. So it will create a waveform, and that waveform is what we are studying. So when we look at the waveform, the first component of this waveform, you see the pressure going up, right? Why the pressure is going up? The pressure is going up because left ventricle has pushed the blood into aorta. It has caused the distension of the aorta. The pressure inside the aorta is increasing, right? So this wave, that is because of the left ventricular ejection of blood into the aorta, I'm going to call this wave as the percussion wave. We will call it as percussion wave. And they will ask you in the exam, what is the reason for this percussion wave? The percussion wave is because of due to left ventricular ejection of blood into aorta. Percussion wave is due to left ventricular ejection of blood into aorta. Fair. Okay. Now, once the blood got ejected into the aorta, it triggered a pressure wave. We saw the pressure going up. Okay. But then the blood will start going forward. So pressure here should start dropping. Whatever blood I had pushed, it increased the pressure, but blood moved forward, the pressure should drop. But in reality, what we see is this graph that we just saw will start showing another rise in the pressure. Now, why is this pressure rising? Because Newton had said every action will have equal and opposite reaction. So if I distended the aorta by pushing the blood into it, aorta will also cause recoil, right? If aorta recoils, what will happen to the volume of aorta? Simple. We have studied about something called as Boyle's law, right? What Boyle's law says? Boyle's law says volume and pressure have inverse relationship. That means any chamber, like if I'm holding this container, right? If I squeeze, the volume decreased. Inside pressure increases, right? If I stretch it and dilate it, the volume increases, the pressure inside it decreases. So if the aorta recoiled because of Newton's law, the volume of the aorta decreased, pressure inside increased. That's why we are getting this another spike in the pressure. So first spike was because blood got ejected. Second spike is because the aorta caused recoil. And this wave, we will call it as tidal wave. This wave, we are going to call it as tidal wave. And the tidal wave is due to recoil of the aorta. It is due to aortic recoil. Okay, so initially blood and then recoil both increase the pressure, and after that the pressure will start going down. So when the pressure starts going down, till I eject the blood again, the pressure should keep dropping because whatever blood that we had pushed is all going forward, right? The pressure should come down to zero in the aorta. But does that what happens? No. After the systole, right, this aortic valve closes and then we start the diastole where we transfer the blood from left atria to left ventricle. During that time, no blood is ejected into the aorta, but the pressure does not drop to zero. Why? because again Newton's law comes into picture. So when I ejected the blood, it distended the aorta. So aorta caused recoil. So distension gave me the first percussion wave, recoil gave me the tidal wave. Now everything is settling down, but when aorta got distended, a pressure wave was sent towards the periphery. And from the periphery, because peripheral tissues will also have the same reaction, because Newton's law nobody can violate. So from the periphery, there will be a reflected wave back. That reflected wave back will cause further recoil of the aorta and increase the pressure. So I will get one more wave now going up, which is because of the reflected wave from periphery. And this reflected wave, we will call that pressure buildup as peripheral vascular resistance. And this wave, I will call it as dicrotic wave. Dicrotic wave. It is due to reflected wave from periphery, and you can as well call this as peripheral vascular resistance. Peripheral vascular resistance. After that, the pressure will start going down. So this is how a pulse waveform looks like. So in this pulse waveform, we have two positive upstrokes. One is percussion wave due to ejection of blood into the aorta, tidal wave because of aortic recoil, and we have a dicrotic wave, which is because of the reflected waves coming from the periphery, right? Separating between these two, the initial two positive strokes and the dicrotic, right? This location actually correlates with the position of closure of aorta. So when aorta closes, the systole gets over and the diastole starts. And this is correlating with S2. And this notch that we see here, this notch we are going to call it as dicrotic notch. Dicrotic notch. And you see one more notch here between percussion and tidal waves. We will call it as anacrotic notch. And now you can say that dicrotic notch is due to closure of aortic valve. Due to closure of aortic valve. So this is our pulse waveform. Exam, what question they will ask? They will give this waveform and then they will mark some part and then either ask you what is it representing. Is it percussion wave, tidal wave, dicrotic notch, or anacrotic notch? Or they will ask you the physiological mechanism behind that. Why did you get this percussion wave? It's because of ejection of blood into the aorta by left ventricle. Why did you get tidal wave? It is because of the recoil of the aorta. Why did you get dicrotic wave? It is because of the peripheral reflected wave or peripheral vascular resistance. And why did you get this dicrotic notch? Dicrotic notch indicates the time where the aortic valve closed. Okay, clear? Now, if it is a pressure graph that I have sketched, then comes a question. Who decides the height of this pressure wave? Higher the pressure, higher is the pressure buildup, right? Higher the pressure, higher is the peak of this waveform. Now, who decides how much pressure will be built up in the aorta during systole? It is the volume of blood ejected. If I push more blood into the aorta will be distended more, the pressure in the aorta will be building up more. If I put less blood, less pressure builds up inside the aorta. And so the height of this percussion wave is directly proportionate to the blood ejected into the aorta, which we call as stroke volume. And the height of this tidal wave is proportionate to percussion wave because it is equal and opposite reaction by the aorta, recoil. So if I distend it more, it will recoil more. So can I say that the percussion wave, tidal wave put together, the height that I reach is directly proportionate to stroke volume? Yes. And because it is a pressure wave, can I measure its pressure? Yes, we can measure. If I measure, this pressure is what we call as systolic BP. So systolic BP is nothing but the height of your pulse waveform. And this BP of the dicrotic wave peak, this pressure is what we call as diastolic BP. So from this, we learn one important point today, that your systolic BP is directly proportionate to peak of the pulse, or the peak of the pulse pressure. Pulse itself is the systolic BP, and that is directly proportionate to stroke volume. So every time stroke volume decreases, your systolic BP drops down. Every time stroke volume increases, systolic BP increases. Okay, got it? Now this is a normal waveform. Apart from that, they may also ask you in what conditions you get different abnormal waveforms. Okay, so let me start with the important abnormal pulses. there is something called as pulsus bis variance. So this is a pulse where you get two palpable peaks. So normally in the pulse, this peak is not felt by us. When we palpate the pulse, do we see it coming and hitting us twice? No, it comes and hits our palpating finger once, and that is this peak that is hitting our finger. This peak, we don't notice it, right? So normally we can feel only one peak in the pulse, but sometimes you can feel two peaks in the pulse, that too both in systole. Then we will call it as pulsus bis variance. And in what conditions it is seen in? It is seen in aortic regurgitation and HOCM, rarely AS plus AR combined cases. Important MCQ point here is HOCM. Pulsus bis variance is usually described in HOCM. Okay. The second one is pulsus paradoxus. Pulsus paradoxus. What does it mean? It is not exactly a pulse. It is actually a BP measurement. Pulse is used here. So normally what happens? The BP is low in the inspiration and it's relatively higher in the expiration. Okay. Why is it higher in the expiration and low in inspiration? During inspiration, the blood flow to the right side of the heart increases. Why? Because inspiration ke time pe inside the chest there is negative pressure. Because of the negative pressure, blood from the superior and inferior vena cava gets drained into the right atrium. So more blood comes to the right atrium. So more blood goes to the right ventricle. More blood goes to the lungs. So during inspiration, right side of the heart gets more blood. And this extra blood or more blood that came to the right side of the heart during inspiration becomes available to the left side of the heart passing through the lungs during expiration. So left heart generally gets more blood during expiration. So if left heart is getting more blood during expiration, it will eject more. So stroke volume increases from the left side during expiration. And stroke volume is having a direct relationship with our systolic BP. They are proportionate. So if I increase the stroke volume, systolic BP increases. So that's why we have higher systolic BP in expiration, relatively lower systolic BP in inspiration. In inspiration. Okay. Okay. Then this variation in the BP that we're talking about during inspiration and landlord see, I'm going to touch the important topics, of course. So I'm expecting to cover hopefully more than 50% of the questions should come from what we are going to discuss today. Okay. Okay. So this inspiratory drop in BP can be up to 20 millimeters of mercury. But if it is more than 20 millimeters of mercury drop in inspiratory BP, then we will call it as pulsus paradoxus, right? So abnormal decrease in BP during inspiration, we will call it as pulsus paradoxus. It is seen in COPD, right heart failure, right ventricular MI. So basically pulsus paradoxus, think about the right side of the heart, and chronic constrictive pericarditis. So it's simple. Pulsus paradoxus, think about right side of the heart. Between right heart and lungs, there is a problem. Okay. Then pulsus parvus. Parvus means, parvus word refers to small. Pulsus parvus means small volume pulse. Small volume pulse means the peak of the pulse is small. It is seen in any condition with low stroke volume, because height of the pulse is directly proportionate to stroke volume, and any condition where there is low stroke volume, because of whatever reason, if there is decrease in stroke volume, the height of the pulse will be decreased. We will call it as pulsus parvus. Then we have something called as pulsus et tardus. What does that mean? Pulsus et tardus refers to tardus means slow. When things move slow, means when I palpate the pulse, quickly I feel the peak. But if peak appears very late, if the peak appears late, we will call it as pulsus et tardus. Instead of feeling the peak here, if I start feeling the peak here or here, then it is pulsus et tardus. late peaking pulse is called as pulsus et tardus. It's called as pulsus et tardus. It is seen in patients with aortic stenosis and left bundle branch block. Aortic stenosis and left bundle branch block. The last one is important. This is what is repeatedly asked. So if you ask me, sir, I want to remember only two abnormal pulses, then pulsus parvus et tardus and pulsus bispheriens. Pulsus bispheriens, I want you to remember HOCM. And pulsus parvus et tardus, what does that mean? Pulsus parvus et tardus refers to, parvus means low peak, et tardus means late peak. The peak is small and it appears late. Low peak, late peak. Usually we abbreviate it as slow rising late peaking pulse. Slow rising late peaking pulse. Peaking pulse. And that is classically seen in severe aortic stenosis. Severe aortic stenosis. This is again a very, very important MCQ point. Where do you get this so-called pulsus parvus et tardus? We get that in patients with severe aortic stenosis. That's it about pulse. Please don't forget the pulsus bispheriens and pulsus parvus et tardus. Okay. The next important topic from the cardio is going to be JVP. Almost every exam, one question is assured. So whatever we're going to discuss in next 10 minutes is going to hold 1 marks for you. Okay. So first we will understand the normal JVP waveform. So what is normal JVP waveform? Basically the jugular venous pressure or JVP, what we're talking about is actually the pressure of the internal jugular vein. And internal jugular vein is anatomically aligned with the right atrium. So it is an indirect reflection of right atrial pressure. Every time right atrial pressure increases, the pressure inside the internal jugular vein also increases. Every time right atrial pressure decreases, JVP also decreases. Okay. So first thing to learn is the jugular venous pressure is directly proportionate to right atrial pressure. That's why we are using JVP as a window to what is happening with the right side of the heart. Now it has a waveform, and in the waveform often they give you a picture of the waveform and then ask you to label or identify a labeled marker as which cardiac event is responsible for that particular component of the waveform. So now imagine that I have put a pressure measuring device in the right atrium and then I'm measuring the pressure in the right atrium throughout the cardiac cycle. So how is it going to look like if I'm measuring it throughout the cardiac cycle? Okay. So you know the cardiac cycle has phases. We have diastole and systole. Now think about the diastole. So in diastole what we do? In diastole we transfer the blood from right atrium to right ventricle. The transfer of blood happens in diastole and then we eject it to the aorta during aorta or the concerned blood vessel right side, it is pulmonary artery, during systole. So for this transfer of blood, the basic rule is the fluid moves from high pressure to low pressure zone. So if right atrial pressure, blood has to move from right atrium to right ventricle, then the pressure in the right ventricle should be lower than right atrial pressure. So how do we achieve that? Either I have to increase the right atrial pressure or decrease the right ventricular pressure. So what actually happens in the cardiac cycle is first we decrease the right ventricular pressure and we call that phase of cardiac cycle as isovolumetric relaxation. This ventricle relaxes. As it relaxes, the pressure decreases. And once the pressure decreased, because of the pressure difference, the blood starts moving from right atrium to right ventricle. This phase, after isovolumetric relaxation, we will call this phase as passive filling. The blood is moving just because of the pressure difference. We are calling it as passive filling. How long the blood can move? Till the two chambers pressure become equal. Like imagine this is my ventricle and this is atria. So I start filling. Why the fluid is moving from this container to this glass? It's only because the pressure in this is higher. But if they are connected through a tube, how long it can move? Till the pressure between the two chambers become equal. Once it becomes equal, remaining blood from the right atrium cannot be transferred to the ventricle. So that is where the end of passive filling. Now whatever blood that is remaining in the right atrium, I have to transfer it by force, right? That is what we call as active filling. The right atria contracts to push the blood into the right ventricle. That is active filling. So how many phases are there in the diastole? A relaxation phase called as isovolumetric relaxation, followed by passive filling, followed by active filling, right? Now let us think about active filling. So before the active filling, let me say the pressure in the atria was somewhere here. This was the level of pressure in the atria before I started active filling. Then once I start the active filling, what will happen to the pressure in the right atrium? The right atrium started contracting, and you remember Boyle's law, pressure and volume are inversely related. So if the right atrium started contracting, the volume started decreasing and the pressure in the right atrium starts increasing. So if I have to plot a graph, the graph should start showing pressure as going up. So this waveform, I'm going to call it as A wave. A wave. What is the reason for this A wave? Atrial contraction. Okay. Now after atria contracted and transferred the blood to the right ventricle, the diastole is over. Before that only we have already done the isovolumetric relaxation and passive filling. This was active filling. A wave was due to active filling or atrial contraction. Once the blood is transferred, no longer blood is there for the atria to transfer. All the blood that we had to transfer is transferred out to the ventricle. Now this atria should receive the blood. To receive the blood from vena cava, it has to relax because fluid always moves from high pressure to low pressure. So atria starts relaxing to receive the blood. So if it starts relaxing, the volume started increasing, so pressure starts decreasing. So now my graph should start taking a lower turn like this. And this waveform, we will call it as, it's a descent. So we'll call it as X descent. The reason for this X descent is atria is relaxing. Atrial relaxation is the reason for X descent. But when atria is relaxing, on the other side, ventricle which has received the blood, it has to eject the blood, right? So it starts contracting. So atria is relaxing this side, ventricle is contracting on the other side. So inside the ventricle, pressure is building up. That pressure also gets reflected onto the tricuspid valve and pushes the tricuspid valve into the atria. So this graph is not exactly going to look like this because relaxation is dropping the pressure, but suddenly the tricuspid valve bulges into the right atrium and that increases the right atrial pressure. So a graph going like this will eventually again start going up. And this slight upstroke that we are seeing here, I will call it as C wave. What is the reason for this C wave? The tricuspid valve got bulged into the right atrium. Will it remain bulged into the right atrium throughout the cardiac cycle? No. As the pulmonary valve opens and the blood starts moving into the pulmonary artery from the right ventricle, ventricular pressure will decrease. So pressure exerted on the tricuspid valve will also decrease. The valve will go back to its original position. The atria will continue to relax. So the pressure starts dropping again. So only transiently, as long as the valve was pushed inside, we will have a positive C wave. So basically the C wave comes in between and divides the X wave into two parts, before the C wave and after the C wave. So before the C wave X descent part is called as simple X descent, and after the C wave that comes is called as X dash descent. Okay. Now atria is relaxed. It is ready to receive the blood. The blood starts flowing now from the veins into the right atrium. And this phase we are going to call it as V wave. V wave stands for the filling of the blood into the veins, into the right atrium. So we'll call it as V wave. Who is responsible for the V wave? Blood coming from inferior and superior vena cava into the right atrium. Why blood came? Because I relaxed and brought the pressure down. That's why blood started coming in. So once the blood came, the atria is filled. It has to transfer this blood to the ventricle. Transfer happens in diastole. So in diastole, first isovolumetric relaxation, then passive filling, and then active filling. Active filling we have already studied. Now it is what? Passive filling. So during passive filling, 70% of the blood transfer happens, and this transfer, as the blood moves from atria to ventricle, the pressure starts dropping and the graph will go down. So this part we will call it as Y descent. Y descent. So in the exam, what are they going to ask you? They will be asking you the physiological reasons behind all these waves. So let me write down quickly. A wave stands for, is due to atrial contraction, and with respect to cardiac cycle, when atria contracts, it contracts for the active filling phase of diastole. It's active filling phase of diastole. X descent is because of the atrial relaxation. Why atria relax? Atria has to relax to receive the blood. To receive the blood. C wave is due to tricuspid bulge. Tricuspid valve bulging into the right atrium. This actually correlates with the isovolumetric contraction phase of the systole. Okay, and then we have a V wave, which is due to venous filling. The blood fills the atria from the superior and inferior vena cava. That's why we are going to call it as venous filling. And then last we have Y descent. Y descent, the pressure in the atria drops because we started transferring the blood from atria to ventricle in passive filling. This is passive filling or atrial emptying. Atria emptied itself into the right ventricle during passive filling phase of cardiac cycle. Passive filling phase of cardiac cycle, right? These are the terminologies I want you to literally by heart. If you did not understand the JVP, if you understood, then it is all cakewalk. Okay, I'll try to make it little easy for you guys to remember. So it's pretty easy because A wave is all about A. A wave is atrial contraction, active filling phase of cardiac cycle. X descent, I want you to stress on relaxation. Stress on X. X descent is due to atrial relaxation. C wave, stress on the tricuspid bulge, or simple say cusp bulge. C wave is due to cusp bulge. C for C. V for V. V wave is due to venous filling. V wave is due to venous filling. And Y descent also, you can stress on the emptying part of the Y part of atrial emptying. So that way you can remember which JVP waveform is due to which cardiac cycle event. Okay. Now let us list important abnormal JVP waveforms. So if they're asking medicine physiology integrated, then the questions may be coming from these abnormal JVP waveforms. So absent A wave. So please remember, A wave is due to atrial contraction. If atria does not contract, the A wave will be absent. Atria does not contract in patients with atrial fibrillation. So if you have AFib, you can say yes, you may have absent A waves. Tall A wave. When the A wave becomes tall, when I try to transfer the blood from right atrium to right ventricle, there is an obstruction, either because of narrow tricuspid valve or because of concentrically hypertrophied right ventricle or the stenosis of the pulmonary valve. Then I have to push the blood into a high pressure zone. So I have to put more effort. So pressure inside the right atrium increases, the A wave becomes tall. So in what all conditions we can have tall A wave? We can have tall A waves in patients with tricuspid stenosis, tricuspid regurgitation, right ventricular, particularly concentric type of right ventricular hypertrophy. Then you can also have tall A wave in patients with pulmonic stenosis. And you should also remember that the pericardial diseases, mainly the constrictive pericarditis and cardiac tamponade. Constrictive pericarditis and cardiac tamponade. They're all going to have tall A wave. And now if the A wave becomes tall, by default the X descent, this coming down, appears to be more steep. The more taller the A wave, the descent appears more steep. So you don't have to remember anything for the steep or prominent X descent. Any condition with tall A wave will have prominent or steep X descent. Okay. Now you come across this one, Canon A waves. Very important. From the JVP, Y descent and Canon A waves and absent A waves are the most important or most commonly asked questions. Okay. Now Canon A waves, what does that mean? These are nothing but tall A waves, but not constant. Means if every A wave is tall, then we will simply call it as tall A wave. But intermittently, if the A waves become tall, intermittently tall A waves, then we call it as Canon A waves. Intermittently tall A waves are called as Canon A waves. Where do we see that? We see that in patients with what we call as AV dissociation. AV dissociation. What is AV dissociation? Where there is separation of atrial and ventricular rate. So I will write the list of conditions where AV dissociation is seen to occur. Conditions with AV dissociation. So what are the conditions where we have the AV dissociation? Number one, you can have AV dissociation in patients with complete heart block. When there is complete heart block, the AV node is blocked completely. So the signal coming from SA node is not able to reach the ventricle. So ventricle will have its own pacemaker. Atria will have its own pacemaker. Now they are beating separately. Their rate is different. They are dissociated. Second, in patients with AVNRT, which is a abnormal cardiac rhythm or arrhythmia, then patients with ventricular tachycardia and ventricular fibrillation. These are the conditions where you have AV dissociation. And these Canon A waves can be seen. The intermittently appearing tall A waves can be seen in the JVP. And when they're seen in the JVP, it is called as frog sign. It's called as frog sign. Because frog's neck, it keeps bulging, popping back. There's something similar to that we will see in the JVP. Whenever a tall A waves comes, the JVP pops out. So we'll call it as frog sign. Okay. Now the next important thing is, where do you get prominent Y descent? So I want you to remember only one condition for prominent Y descent, though there are others like tricuspid regurgitation. The one that you have to remember is patients with constrictive pericarditis. A very, very important MCQ point. Why? Because we use this Y waves status to differentiate between cardiac tamponade and constrictive pericarditis. Last 3 years, almost every exam had a question asking you to differentiate between constrictive pericarditis and cardiac tamponade based on the JVP. Okay. Then fused CV waves and prominent V wave. You see that in patients with tricuspid regurgitation. Tricuspid regurgitation. And this fused CV wave, there is again a name given to it. It is called as Lancisi sign. They have already asked this question, where do you get Lancisi sign or what does it stand for? So I want you to remember it. Fusion of the C and V waves. We call it as Lancisi sign. Okay. One last addition to it, on whose basis repeatedly questions are asked, which is absent Y descent. Prominent, we get it in constrictive pericarditis. Absent Y descent, we get it in patients with cardiac tamponade. In patients with cardiac tamponade. Why is this important? Because cardiac tamponade and constrictive pericarditis may present with similar clinical features, but this Y descent in the MCQ may help you to differentiate. So if the Y descent is prominent, it is constrictive pericarditis. And if the Y descent is absent, it is pointing towards cardiac tamponade, right? So in the JVP question, what are the important points that I want you to remember? Yes, the prominent Y descent and absent Y descent, Canon A waves and absent A waves. Okay, so that completes our discussion on the JVP. Now let's go to the valvular heart diseases, from which you are expecting one question. Most likely the question is going to be clinical, asking you to diagnose which valvular heart disease this particular patient is suffering from. And for that, they are going to give the information which includes mainly 3 points. So just to give you an understanding, I will give you a question. This is how the questions in valvular heart disease are going to appear like. It's like a 35-year-old female presented with raised JVP, ascites and edema. Auscultation showed a murmur which is systolic, or let us say diastolic. Auscultation showed a diastolic murmur in left lower sternal border. And then they are asking what is the diagnosis. Okay, so what all information is there in the question? Number 1, symptoms, right? That is first level of information. What are the symptoms the patient has presented with? So this patient had ascites, JVP, elevation and edema. Second is the nature of the murmur, systolic, diastolic. They may give you more details like it's pansystolic, mid diastolic, early systolic, early diastolic, whatever, more details about the murmur. The third level of information is from which area this murmur is actually heard. So in this question, it is heard from the left lower sternal border. So out of this, if you are able to at least apply 2 out of 3 levels, even if you are able to apply 2 levels of information, mostly you will reach the diagnosis. You don't have to study the whole valvular heart disease to get the diagnosis right on such questions. So to help you, what we will do is, first we will understand the areas of auscultation, which area is representing which valve, and in which valvular diseases, what murmurs we are going to get. Okay. So the first area of auscultation is on the right side of the chest, that is right second intercostal space. Then we have one more on the left second intercostal space, one in the left third intercostal space, and then left lower sternal border, and then somewhere off. So the first area that is there on the right side of the heart, right? So this area, I'm going to call it as aortic area. So any question which mentions that this particular person has a murmur heard in the right second intercostal space, the examiner is telling you that this patient is having a problem in the aortic valve. It could be AS or AR. So you have only two differential diagnoses. Everything else is ruled out, right? So similarly, if examiner says that I have got a patient who has a murmur in the left second intercostal space, then that is pulmonary area. So if the murmur is heard in this area, that means either you have pulmonic stenosis or pulmonic regurgitation, right? So aortic area is there on the right second intercostal space, and pulmonic area is there on the left second intercostal space. And then this left third intercostal space that we had, it's called as Erb's area, which is also called as neo-aortic area. Aortic area has an extra area. Okay. Then this left lower sternal border, this is not one single region spread over 2-3 spaces. So I'm writing it as left lower sternal border, that is our tricuspid area. So if the teacher mentions that there is a murmur heard in the left lower parasternal region or left sternal border, he is telling you that this murmur is coming from tricuspid valve, right? That is left lower sternal border. Now tell me, in this question that we have, which valve is affected? The murmur is heard in the left lower sternal border. That means it is coming from tricuspid area. That means either tricuspid stenosis or tricuspid regurgitation should be the answer. So you have already ruled out pulmonic stenosis, pulmonic regurgitation, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation from your option. So if area is given, the job is quite easy. Okay. And then the last one, this part is mitral area. Where is the mitral area situated? Mitral area is situated at the apex. Wherever you have the apex bit, wherever you feel, that is where you have the mitral area. Okay. So now already you're thinking about tricuspid stenosis or tricuspid regurgitation because the murmur is heard in the left lower sternal border. Now let us ensure whether it is TS or TR by knowing which conditions present with which murmur. AS and PS present with aortic stenosis and pulmonic stenosis present with an ejection systolic murmur. Ejection systolic murmur. And there may be image-based questions. So image-based questions on this murmur, they will present with phonocardiographic image. So if it is systole, it happens between S1 and S2. The first phase of systole is isovolumetric contraction. Murmur is not heard there. The murmur is heard after isovolumetric contraction. And the murmur of aortic stenosis, this phase is called as rapid ejection and slow ejection. And because the murmur is heard only during the ejection, we call it as ejection systolic murmur. So murmur goes on increasing in intensity and then goes on decreasing. So that's why this is also called as crescendo decrescendo ejection systolic murmur. Crescendo decrescendo ejection systolic murmur. And here opening of the aortic valve might make a noise because it is stiff and stenosed, and that sound we call it as click. So we are getting ejection systolic crescendo decrescendo murmur for a patient with aortic stenosis as well as for a patient with pulmonic stenosis. The question is, how will I differentiate if the murmur is ejection systolic crescendo decrescendo, whether it is AS or PS? Rule number 1, look at the symptoms. So if I have right-sided heart disease, I will have raised JVP, hepatomegaly, ascites as symptoms. And if I have left valvular diseases like aortic or mitral valve pathology, I will have dyspnea, orthopnea, PND as the symptom. So symptoms will also help you to rule out. So in this question, we had raised JVP, ascites, edema. That means it is right heart pathology. So I'm not thinking about mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. Those are already ruled out. I am only left with the right pathology, that is my tricuspid stenosis, tricuspid regurgitation, pulmonic stenosis, pulmonic regurgitation. And when I look at the area, I already know it is coming from tricuspid valve. So pulmonic is also ruled out. In this question, I'm only thinking about TS and TR. Okay. Now, if I have AR and PR, you will have a early diastolic murmur. Again, you will look at the symptoms to decide whether it is right or left heart pathology, but the murmur wise it will be same, that is early diastolic murmur. AR murmur will be heard in the aortic and neo-aortic area. PR murmur will be heard in the pulmonary area, which is left lower sternal border. And if it is a diastolic murmur, it will be happening between S2 and S1. The first phase of diastole is isovolumetric relaxation. After that you have passive filling. After that you have active filling. So the murmur is mainly heard in the isovolumetric relaxation phase. So it is a early diastolic murmur. MS and TS, mitral stenosis and tricuspid stenosis, they are mid diastolic murmurs. Mid diastolic murmur. If it is heard in the apex, a mid diastolic murmur heard in the apex is mitral area, so it's mitral stenosis. A mid diastolic murmur heard in the tricuspid area is tricuspid stenosis. So if it is diastolic, it will be happening between S2 and S1. So the first phase of diastole is isovolumetric relaxation. Murmur is not heard there. After isovolumetric relaxation, the valve opens. It makes a noise. It is called as opening snap. And after the opening snap, the murmur starts. Initially, passive filling, you hear the murmur. Active filling, the murmur increases. So you hear the murmur here, passive filling. Active filling increases. We call it as pre-systolic accentuation. So this murmur has a plateau and then rising in the active filling. So we call it as a pre-systolic accentuation of the murmur. Okay. And if I have MR and TR, I will have a pan-systolic murmur. Pan-systolic murmur. Only thing is the murmur of MR will be heard in mitral area. The murmur of TR will be heard in tricuspid area. If I have MR, left heart symptom, that is dyspnea. If I have TR, right heart symptom, that is raised JVP, hepatomegaly, ascites. So left versus right symptoms, area of auscultation, and the nature of murmur. So if you by heart these three things, you can deal with the valvular heart disease questions. So if it is pan-systolic, it will be happening between S1 and S2, and it is pan-systolic. That means it is running throughout the systole. Okay, now let me write few important points in addition to the murmur that I want you to remember. So with respect to AS, the most common cause for aortic stenosis is aging. And the most common cause for AS in young is going to be bicuspid aortic valve. Okay. With respect to AR and PR, I want you to by heart what is called as peripheral signs of AR. Peripheral signs of AR. I'm not going to make an elaborate list here because it will take more than half an hour just to make that list. But the list is available in your books, notes, everywhere. You can just by heart that. Okay. And when it comes to MSTS, the MCQ they may ask is the most common cause for mitral stenosis is going to be rheumatic heart disease, RHD. Okay. And then for MR and TR, I want you to remember mainly most common cause for MR is going to be left ventricular dilatation. So any condition that causes left ventricular dilatation will cause mitral regurgitation. Okay. One more question may come on what we call as mitral valve prolapse. So if there is MR plus a click, you should consider it as mitral valve prolapse. Mitral valve prolapse. A question talking about patient having mitral regurgitation, but also a click is heard on auscultation, then that question is talking about mitral valve prolapse. Okay, so that's about the valvular heart diseases. Now you can look at this question and answer me. Which valve you're thinking of? The murmur is diastolic. So what are the conditions where we have diastolic murmur? We have ARPR and MSTS. ASPS, MRTR have systolic murmurs. So I'm only thinking about ARPR, MSTS. Looking at the symptoms, it's certainly not a left heart symptom, it is right heart symptom. So definitely I'm not considering AR, I'm not considering MS. So I'm left with PR and TS as my differential diagnosis. And as I see, the murmur is heard in the tricuspid area. So that means the patient has got tricuspid stenosis. So diagnosis for this question is going to be tricuspid stenosis. So please remember this table, areas of auscultation and left versus right symptoms. You will hit the valvular heart disease question right. Beyond that, these are few important MCQ points. The causes, the most common cause for AS is aging, but if it is in young, it is bicuspid aortic valve. For the MS, it is RHD, and for the MR, it is left ventricular dilatation. And in any patient, if you have MR, along with a clicking sound heard, then it is mitral valve prolapse. Okay. Now we will also quickly recap some abnormal heart sound. So first we will start with S1. S1, you know that it is due to closure of mitral valve and tricuspid valve, closure of mitral and tricuspid valve. And in terms of abnormalities, they may ask you, where do you get loud S1 and where do you get soft S1? The list is long. I'm only going to quote the important ones that I want you to remember. The loud S1, I want you to remember mitral stenosis, and remember the closure of the mitral valve happens with respect to ECG when you have the PR segment. During the PR segment, that's the time available for the closure of the mitral valve. So if the PR segment is short, it has to close quickly, so it makes more noise. And short PR interval, and soft S1, you get exactly opposite of it, that is MR and long PR interval. Just to make it easy for you to remember, you can remember the loudness of S1 is inversely proportionate to PR interval. More the PR interval, you will have less loud S1. Less the PR interval, you will have more loud S1. Okay. Now with respect to second heart sound is split. You can hear aortic valve closure and pulmonic valve closure separately. So it is due to closure of aortic valve and pulmonic valve. Now with respect to this, they will ask splitting. So you can have a physiological split and abnormal splits. So physiological split is, the split is not heard in expiration, heard only in inspiration. So you can call it as inspiration only split. Then this split can become wide split. This can become narrow split and fixed split. So wide split is where, see, basically split is separation between aortic closure and pulmonic closure, separation between A2 and P2, aortic closure and pulmonic closure. So anytime I make the aortic valve close early or pulmonic valve close late, the split becomes wide. So when the aortic valve closes early in patients with mitral regurgitation. Okay. And when can I make the P2 close later? In patients with pulmonic stenosis, right? Opposite of that is kind of true. The split becomes narrow when I have aortic stenosis or I have tricuspid regurgitation, where P2 becomes early. Okay, just by heart this. Conceptual understanding will definitely take a lot of time. So for now, by heart, if you don't know, if you know, it's the revision for you. Okay, what is most important from this splitting? It is the fixed split, the split that does not change with inspiration and expiration. It just remains same. Physiological split is heard in inspiration, not in expiration, but this does not change. It is there in inspiration, it is there in expiration, it remains constant. It is seen in patients with ASD. Okay. Then there is one more important MCQ point. Where do you get the so-called paradoxical split? Paradoxical split is opposite of physiological split. Physiological split is heard in inspiration. Paradoxical split is heard in expiration. Where do I see that? It is seen in two conditions: left bundle branch block and severe aortic stenosis. This is another important MCQ topic. So let me now quickly summarize the key points that I want you to remember. So when we talk about pulse, mainly two things you have to remember: pulsus bisferiens HOCM and pulsus parvus ectatus severe aortic stenosis. When it comes to JVP, absent A wave is atrial fibrillation. Canon A wave is in AV dissociation. I have listed the conditions where you get AV dissociation. Prominent Y descent, think of constrictive pericarditis, and an absent Y descent, think of cardiac. Then when it comes to valvular heart diseases, the area of auscultation and the murmur table by heart kar do, your valvular heart disease is sorted. When it comes to abnormal heart sounds, with respect to S1, I want you to remember where do you get loud S1, and you get that in patients mainly mitral stenosis. With respect to S2, they will ask the splitting. Most commonly asked questions on splitting is fixed split, ASD, and paradoxical split, mainly severe AS and left bundle branch block. Okay. Next, apart from these two abnormal sounds, we also have S3, S4, click and opening snap as abnormal sounds. So S3, what is it? S3 is a sound produced by mitral tricuspid closure produced S1 and aortic pulmonary closure produced S2. From where this S3 is coming? When I transfer the blood from left atrium to left ventricle during diastole, first in passive filling and then in active filling, actually no sound is produced. But if the ventricle size increases, it may be producing a sound. So sound produced by passive filling into large compliant LV. As in, when do I get large and compliant LV? Dilated cardiomyopathy. And left ventricular failure. And S4 is the sound produced by active filling. So basically, passive filling normally does not produce a sound, but if I dilate the left ventricle, it can. Passive filling sound is S3. Active filling sound is S4. Sound produced by active filling into stiff non-compliant. So you require a dilated LV to produce S3. You need a stiff LV to produce S4. Non-compliant LV, as in where I get non-compliant LV? Whenever there is concentric left ventricular hypertrophy, concentric LVH. So points to remember is S4 is due to active filling, S3 is due to passive filling. Another point I want you to remember is S3 can be physiological in children and athletes and pregnancy. S3 can be physiological. Where is it physiological? It can be physiological in children, pregnancy, and also athletes. On the other hand, S4 is always pathological. Always pathological. This is what is repeatedly tested. Which one is physiological, which one is pathological? S3 can be pathological or physiological, but S4 is always pathological. Okay. Now clicks. What are clicks? Clicks are sound produced by closure of, the opening of valves that open in systole. Normally they don't make noise. Only closure of the valves make a noise. But if the valve is stiff, when they close, they make a noise. So if I have aortic stenosis, the aortic valve, when it opens, it makes a noise. And if I have pulmonic stenosis, when the pulmonic valve opens, it makes a noise. So clicks are heard in ASPS. Apart from that, mitral valve prolapse is another condition. And opening snap is again the sound produced by opening of valves, as the name says, but the valves that open in diastole. So which valves open in diastole? Mitral valve. If it is stiff, it is MS. And if tricuspid valve is stiff, it is TS. So MS, TS produce opening snap. ASPS produce click. Remember, these points I have already covered. If MR with click, you think of mitral valve prolapse. And ASPS, we had a click. And MSTS, we had a opening snap. Okay. That's about our abnormal heart sounds. Now coming to the core medicine, the first topic is heart failure. Mainly what questions are asked is either classification based questions or diagnostic criteria based questions, or pharmacotherapy. Which drugs are known to reduce mortality and which drugs are not known to reduce mortality, right? So what is heart failure? Heart failure refers to impaired left ventricular ejection or filling. So we fill the blood into the ventricle during diastole. So if there is impairment in the filling, we will call it as diastolic heart failure. Diastolic heart failure. And we eject the blood from the ventricle during systole. So if there is a problem, we will call it as systolic heart failure. Now, regardless of whether it is diastolic or systolic heart failure, the outcome of heart failure is similar. That is reduction in the stroke volume. Heart is failed, it is not able to generate sufficient stroke volume. Okay. And because of the low stroke volume, patient starts suffering the symptoms. Now, how am I going to diagnose? For the diagnosis, we need signs and symptoms of heart failure. Can anybody tell me what are the signs and symptoms of heart failure? Plus, this is important. They can ask you what is the biomarker of choice for diagnosis of heart failure. It is not troponins or CKMB. It is BNP or N-terminal pro-BNP. Either you do a regular BNP or N-terminal pro-BNP. If they are elevated in a patient who has signs and symptoms of heart failure, then you diagnose it as heart failure. So what are the signs and symptoms of heart failure? If it is right heart which is failed, then you will have raised JVP, ascites, hepatomegaly, and edema. And if it is left heart which is failed, then you will have, yes, shortness of breath, or more technical terms, we call it as dyspnea. Then you can have orthopnea and paroxysmal nocturnal dyspnea, or PND. Right. So diagnosis is based on, if I have raised JVP, ascites, hepatomegaly, and N-terminal pro-BNP or BNP is elevated, you have heart failure, more precisely right heart failure. If I have dyspnea, orthopnea, PND, and my N-terminal pro-BNP or BNP is elevated, then I have left heart failure. And this N-terminal pro-BNP is considered as the biomarker of choice or investigation of choice for the diagnosis of heart failure. Once you are diagnosed, before you start managing, you need to know whether it is systolic heart failure or diastolic heart failure. How do I get to know? By looking at the ejection fraction. So heart failure is classified based on ejection fraction into heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So normal EF, as you know, is between 60 to 70%. And if EF is less than 40%, we will call it as heart failure with reduced ejection fraction. And if it is fairly close to normal, that is EF more than or equal to 50%, then we will call it as preserved. It's not lost much. So heart failure with reduced ejection fraction is equal to systolic heart failure. And heart failure with preserved ejection fraction is equal to diastolic heart failure. So here MCQ wise they will ask you, what is the most common cause for heart failure with reduced ejection fraction? Why heart is not able to eject the blood during systole? Most commonly it's not able to eject the blood because its muscle is dead. Why will it die? Because lack of blood supply. That is ischemic heart disease. Some part had an MI. So that infarcted part cannot contract. So I'm not able to generate sufficient force of contraction. That's why I'm failing in the systole. So the most common cause for heart failure with reduced ejection fraction is going to be ischemic heart disease. That's why after MI, most of the patients will have drop in ejection fraction. On the other hand, heart failure with preserved ejection fraction, the most common cause is hypertension. Hypertension is the most common cause for patients with heart failure where ejection fraction is preserved. That means the force of contraction during systole is fine. The problem is I'm not able to fill the blood into the ventricle. So if I fill less into the ventricle, I will be able to eject less. That's how the stroke volume is coming down. Why am I not able to fill the blood into the ventricle? Because ventricle has concentric hypertrophy. Its volume is small. So if it's a small ventricle, I can only fill small quantities. So it can only eject small quantities. And hypertension is the most common cause for concentric LVH. Okay, clear? The other examples I want you to mention for the diastolic heart failure is hypertrophic cardiomyopathy or HOCM. And other examples I want you to mention for systolic heart failure or reduced ejection fraction is dilated cardiomyopathy. Dilated cardiomyopathy. Okay, so this is about the important areas of heart failure that they can ask us MCQ. Now, when it comes to the management of heart failure, remember whenever heart fails, the neurohormonal adaptations happen in two types. The first type of neurohormonal adaptation is increase in the RAS. So remember, the increased activity of the RAS. Increased RAS activity is harmful. Why is it harmful? Because RAS will have aldosterone. It will make you reabsorb more salt and water. It will increase the edema, increase the burden on the heart. Heart fails more. Angiotensin will cause vasoconstriction. Now heart has to push with blood with more force through these constricted vessels. So heart has to put more effort. It's already failing. It fails more. That's why activation of the RAS that happens in heart failure is harmful. So I have to block it. And then there is also increased activity of ANP, BNP, the natriuretic peptides. They are helpful in recovering the failed heart. Why? Because the ANP, BNP, they cause vasodilatation, so reduce the burden on the heart, and they make you pee more sodium and water out through the kidney, and because of that the burden on the heart comes down. So it is beneficial. So when I have to treat heart, I have to block the RAS. So how do I block? Yes, first important agent for heart failure treatment is going to be AC inhibitors or ARBs. Second, often there is sympathetic nervous system overactivity in heart failure because stroke volume is less, BP is dropping down. Now the sympathetic nervous system wants to push the heart more so that we can elevate the BP, but that will harm the heart more. So we have to block. So we consider beta blockers, preferably cardioselective beta blockers. The third thing that we will give is spironolactone. Why? Because aldosterone that is activated is making you retain more salt and water and increasing the burden on the heart. So if I block the aldosterone, I will lose more sodium and water. Then the fourth drug that is useful for a patient with heart failure is going to be SGLT2 inhibitors. Okay, I am not getting into the details why it is useful because it will take some time. Just remember now that SGLT2 inhibitors are no longer restricted to diabetes. We use them in non-diabetics for various indications, and this is one of them. Okay. And then the fifth class, sir might have told you in pharmac as well, that is ARNI. What ARNI stands for? Angiotensin receptor plus neprilysin inhibitor. Angiotensin receptor plus, so this is a combination of two drugs. One is blocking the angiotensin receptor, the other one is blocking neprilysin. And neprilysin is the enzyme that actually breaks down ANP, BNP. So if I block neprilysin, ANP, BNP will not be broken down. So ANP, BNP levels will increase. That will benefit the heart. So an example for ARNI is going to be valsartan, which is an angiotensin receptor blocker, plus sacubitril. Sacubitril is the neprilysin inhibitor. So angiotensin receptor blocker here is valsartan and neprilysin inhibitor is sacubitril. This is repeatedly asked MCQ, so I want you to remember. So these are the main class of drugs used for treating heart failure. And remember, all these class of drugs that I mentioned, all these class of drugs decrease mortality in patients with heart failure. On the other hand, I also want you to remember that digoxin stimulate the heart more, and other inotropic agents like mildrenone, they stimulate the heart more, and because of that they are associated with increased mortality. So they may give symptomatic benefit, but they push you towards death, right? This is also an important MCQ that has been asked. Which of the following drug is not associated with lowering of mortality in patients with heart failure, right? Think about digoxin. So that completes our heart failure. Now we'll go to the next topic, which is constrictive pericarditis. Okay. What is constrictive pericarditis? Constrictive pericarditis is a condition where the pericardium has become stiff, and stiffening of the pericardium has resulted in inadequate relaxation of the pericardium during diastole. So basically we transfer the blood from atria to ventricle during diastole, but here the pericardium that is there, it has become stiff. So normally pericardium does not restrict the ventricular expansion. How much ever ventricle wants to expand, the pericardium allows. But here it is stiff. So it does not allow the full expansion of the ventricle. It only allows little bit expansion. So only as much it allows, I can fill. After that, ventricle cannot expand further, so I can't fill further. So filling of the ventricle gets reduced. Which side gets affected more? Right side. So constrictive pericarditis basically refers to stiff pericardium resulting in abrupt cessation of right ventricular filling. The most common cause for this constrictive pericarditis, why the pericardium is becoming stiff, the most common cause worldwide is recurrent acute pericarditis. If again and again I have acute pericarditis, it scars the pericardium and the scarred pericardium becomes stiff. It can't relax well. But in India, the most common cause is not recurrent acute pericarditis, but rather tubercular pericarditis. TB of the pericardium scars it and makes it stiff. So recurrent acute pericarditis is the most common cause world over, but in India it is the tuberculosis. It is going to be tuberculosis. Okay. Now what clinical features they present? Because remember, in cardiology things are very simple. Right versus left heart. As I have already told you, the pericardium stiffening is affecting the right ventricular filling more. So symptoms will be related to right side of the heart. If I can't transfer the blood to right ventricle, more blood will stay in the right atrium, right atrial pressure will increase, IVC pressure will increase, JVP will raise. Inferior vena cava pressure will increase, it will cause the congestion of the liver. So classical right heart symptoms. So what are the right heart symptoms we are expecting? We will have raised JVP, ascites, and hepatomegaly. Now you may ask, sir, how will I differentiate then between tricuspid stenosis and constrictive pericarditis? Simple, auscultation, guys. So if it was tricuspid stenosis, I would have heard a mid-diastolic murmur. I will not get this in constrictive pericarditis, right? Second is JVP also, because there is impairment of transfer of blood from right atrium to right ventricle. Right atrium has to put more effort. So during active filling, it contracts with more force. So A wave becomes tall. And we have written that when we wrote the JVP as well. So you will have tall A wave. And I've already told you, whenever you have tall A wave, you will have a steep or prominent X descent. Because if A becomes tall, the X descent appears steep. And then here the passive filling, which is represented by the Y wave, does happen. As long as the pericardium allows, we keep filling. It's not like the passive filling is totally stopped. Blood transfer happens till the limit of pericardial stretch is reached. So passive filling is there, and because of that, Y descent will be there, and it will be steep or prominent Y descent. We have written it down when we wrote about JVP. And this steep or prominent Y descent is also called as Frederick's sign. It's called as Frederick's sign. This is very, very important because similar symptoms a cardiac tamponade patient will also present, but they will have absent Y descent, and this is a differentiating feature. And on auscultation, because there is abrupt cessation of passive filling. So when suddenly I stop the passive filling, ventricle which was expanding is suddenly stopped by the pericardium. It's like pericardium applied a brake. So it violently jerks, and that jerking makes a noise, and that noise we call it as pericardial knock. Pericardial knock. So for its diagnosis, we are going to rely on right heart catheterization, and it is going to show something called as square root sign. Preeti, yeah, we are live. The square root sign. Now again, I'm not going into the details how that square root sign is produced, but in the MCQ, if you see square root sign being visible, especially if it is patient with a right heart symptom, you can take it as constrictive pericarditis, right? There is something called as square root sign on the right heart catheterization. Now, what is the management of a patient with constrictive pericarditis? Simple. The pericardium has become stiff. Remove it. So the management is pericardiectomy or pericardial stripping. That is going to be the management. Okay. So that's about the constrictive pericarditis. So the simple thing is right-sided symptoms, pericardial knock, steep Y descent. These are the points I want you to remember. Elevated JVP, hepatomegaly, ascites, that is right-sided symptoms, steep Y descent on the JVP, pericardial knock on auscultation, right? Now, Let us study a closely related differential diagnosis, that is cardiac tamponade. So what is cardiac tamponade? Cardiac tamponade refers to massive pericardial effusion or fluid collection leading to right ventricular collapse. And if RV collapses, that will lead to. So first point about cardiac tamponade is, see, if just there is fluid in the pericardium, like in this space I have fluid, that is pericardial effusion. But if there is so much fluid that it compresses and collapses the right ventricle, then I will call it as cardiac tamponade. And if the right ventricle collapses, it can't relax because there is so much fluid compressing it. It can't do the isovolumetric relaxation. And if there is no isovolumetric relaxation, there will be no passive filling. So whatever filling you do in active filling. So there is no passive filling. These are the 2 points I want you to remember. Now, what is the most common cause for cardiac tamponade? The most common cause for cardiac tamponade is hemopericardium. Hemopericardium means bleeding into the pericardial space. And the most common cause for the hemopericardium is trauma. So when you have trauma to the chest, fractured ribs, penetrating into the heart, you bleed profusely into the pericardium, and that fluid compresses the right ventricle, make it collapse. Okay. So in terms of clinical features, these patients of cardiac tamponade, they present with classical right heart symptoms itself, that is raised JVP. Then you will have hepatomegaly, ascites, pedal edema if it is chronic, but most of them present acutely, so you're unlikely to expect the pedal edema and ascites at the time of presentation. The other thing you notice is there is drop in BP, or you can have hypotension. Why are you getting hypotension? The mechanism is simple. If the right ventricle got collapsed because of the fluid, right, I'm not able to fill it properly because it's already collapsed. So I will be able to eject less amount of blood out from the right ventricle. So if less amount of blood is ejected, less amount of blood goes to the lungs, less amount of blood comes to the left ventricle. So the amount of blood ejected by the left ventricle will also be less. That is low stroke volume. So if stroke volume is low, the BP will be low. We have already learned that the systolic BP is directly proportionate to stroke volume. So you ended up with hypotension because from the right side, less blood was ejected. And now in this pericardial space, there is a lot of fluid, and fluid is not a good conductor of sound. So whenever I keep a stethoscope here and try to auscultate, fluid is not a good conductor of sound. So the heart sounds will get muffled or blunted. It feels like they are heard from a very far away distance and not coming from the heart. We will call it as muffled heart sound. And collectively, these three findings together are called as Beck's triad. You talk about any past FMGE MCQ on cardiac tamponade, it always mentioned the Beck's triad features. But I'm going to add little more extra details today. First one is JVP. So in the JVP, you will have a tall A wave. And I have already told you, whenever there's a tall A wave, you will have a steep X descent. So you will have steep X descent. The only difference between the JVP findings of constrictive pericarditis and cardiac tamponade is because there is no passive filling, the wave of passive filling, which is Y descent, will be absent. So you will have absent Y descent. So if you have a question with raised JVP and steep Y descent, that is Frederick sign, it is constrictive pericarditis. So if you have a question with raised JVP and absent Y descent, it is cardiac tamponade. Okay, and then when you investigate ECG, shows something called as electrical alternance. So what is this electrical alternance? You will have alternatively tall and small QRS. So one QRS will be tall, the next QRS complex will be small. One QRS will be tall, the next QRS will be small. So alternating tall and small QRS complexes, we call it as electrical alternance. And in the echocardiography, you will see right ventricular collapse. If they're asking you what is the investigation of choice, see, merely having fluid is called as pericardial effusion. Only when RV is collapsed, we are calling it as cardiac tamponade. So the best investigation to prove that RV is collapsed because of this fluid is echo. So that's why echo is the investigation of choice. Okay. Anyway, I have put a table which helps you to compare the cardiac tamponade and constrictive pericarditis, and any question asking you to differentiate between these two, you can answer from this table. So in cardiac tamponade, as we just learned, no passive filling. That means absent Y descent. In constrictive pericarditis, passive filling does happen. So you have Y descent present. In fact, it is steep, called as Frederick's sign. Okay. Then pulsus paradoxus is present in patients with the cardiac tamponade. It's usually absent in constrictive pericarditis. You have a Kussmaul sign, which is present in constrictive pericarditis, but relatively rare in the cardiac tamponade. Then other characteristic feature is the cardiac tamponade shows RV collapse on echo. On the other hand, you get pericardial calcification in X-ray and square root sign on right heart catheterization in the constrictive pericarditis. So if you by heart this table, you will be able to deal with the questions asking you to differentiate between CT and CC. Please spend 10 minutes on this after the class, because last 3 years consistently they have asked the question to differentiate between constrictive pericarditis and cardiac tamponade. So whatever we discussed now almost likely holds 1 mark. Okay. The next one is acute rheumatic fever. Okay, so here mostly the questions are related to the diagnostic criteria, but we will quickly understand what acute rheumatic fever stands for. So acute rheumatic fever, what is it? It's a post-infectious multi-system autoimmune inflammatory disorder. That means the infection is not the cause. Infection triggers your immune system, and your own immune system is starting to damage the organs, and it is not affecting only one organ, it affects multiple organs. So 2 important MCQs from the definition: what is the most common infection and what is the most commonly affected organ? The most common infection, as you know, it is group A beta hemolytic, group A beta hemolytic streptococci. Most commonly throat infection, rarely skin infection. So gas pharyngitis, as we call it as group A beta hemolytic streptococcal pharyngitis, usually triggers a multi-system disease. And in the multi-system, in the era of ECG, echo and MRI of the heart, today we consider CVS is the most commonly affected system, or you can say carditis as the most common manifestation. Second most common is musculoskeletal system. In the past, we used to consider musculoskeletal system as the most commonly affected because the subclinical involvement of heart could not be diagnosed, because we were only diagnosing clinical basis. But now we have echo, ECG, cardiac MRI, so we diagnose even when patients don't have symptoms. So that's why CVS is the most common cause. Second most commonly affected is the musculoskeletal system. Musculoskeletal system. So if it is a multi-organ involvement, right? So how do they present? They present with the manifestations of individual organ, and those manifestations we will classify them as major and minor. So what are the major criteria? You can remember it as cases. It's a mnemonic. And as we just told, CVS is the most commonly affected. So in the heart, it causes carditis. And then A stands for arthritis. With respect to carditis, I want you to remember that it causes pancarditis. What do you mean by that? It means it causes valvulitis. Endocarditis means all the components of the heart, they get affected. Endocardium gets affected. Myocardium gets affected. Pericardium gets affected. And valvulitis predominantly affects the mitral valve more than aortic valve. And what it causes to the mitral valve? It may present as mitral regurgitation. So MR is the most common valvular manifestation of acute rheumatic fever. Arthritis, it mainly causes migratory polyarthritis. Arthritis can be classified as mono, oligo, and poly. So it is poly. And the involvement of joint jumps from one joint to the next. That's what is called as migratory polyarthritis. The S here stands for Sydenham's chorea. So after the musculoskeletal and heart, even the nervous system gets affected, mainly the caudate nucleus, which presents as Sydenham's chorea. E here stands for erythema nodosum. Skin also gets affected. So in skin you get red nodular lesion. So we call it as erythema nodosum. Sorry, erythema marginatum. Erythema marginatum. And then you have subcutaneous nodules. Subcutaneous nodules. So these are considered as the major criteria. Easy to remember the major criteria. It is cases. So what are the minor criteria we have? Minor criteria we have fever, prolonged PR interval, and fever, prolonged PR interval, raised ESR or CRP, and monoarthralgia, single joint pain. These are minor criteria. And for the diagnosis, we need two major or one major plus two minor criteria. Okay, now with respect to management of rheumatic fever, they may ask only 2-3 important questions. So the first related question is, what is the initial management? Initial management is mainly with the help of aspirin or other NSAIDs to reduce the inflammation, like joint inflammation, heart inflammation, carditis, arthritis, all of that. Then you need antibiotic prophylaxis, because rheumatic fever can come again and again, and every time it comes it causes more damage to the heart. So we need prophylaxis. So for that, drug of choice is benzathine penicillin G. Usually 1.2 million units intramuscular once in 2 to 3 weeks. That's the antibiotic prophylaxis we follow for the rheumatic fever. So what is the question I'm expecting from this topic? Mostly they will frame a question asking which of the following is not a major criteria, or which of the following is not a minor criteria, or they will give you a story where some minor and major manifestations are mentioned, and then they will ask you how many more criteria need to be met. Like they have mentioned the story where only one major criteria is present, that is patient has got Sydenham's chorea, nothing else is there. Now for the diagnosis, how many more criteria are required? Option A, one more major. Option B, two minor. Option C, both A and B. Option D, three minor. So option A was like we need two major. In this story, only one major was there. So if I add one more major, then also it is diagnosed. Or if I add two minor, then also it can be diagnosed. So C was talking about both A and B, and that will be our right answer. Okay. So that's about rheumatic fever. Remember this mnemonic cases. That's why you will be able to remember the major criteria. So that completes the important topics from cardiology. Now let's move to the neurology. Now to understand the neurology, we need to have a fair idea about LMN versus UMN lesions. Even if you don't understand the neuro conceptually now, I want you to by heart the table that I'm going to put, because almost every alternate exam, one question directly comes. This is physiology, not medicine, but the question does come from it. So whenever we cause damage to the UMN, upper motor neuron, that brings the signal from brain to spinal cord, and whenever I damage the neurons which bring the signal from the spinal cord to the neuromuscular junction, it is called as LMN lesion. So with respect to tone, muscle tone, whenever there is UMN lesion, there is increase in the muscle tone. We will call it as hypertonia. It's called as hypertonia. The more precise word for this hypertonia is spasticity. It is called as spasticity. And in the LMN lesion, there is decrease in the tone, we will call it as hypotonia. The other term that we use for this is flaccidity. It's also called as flaccidity. So any question which says patient has got flaccid paralysis, it is talking about the lower motor neurons being damaged. Any question which says spastic paralysis, it is talking about upper motor neurons being damaged. Then the second thing that helps us to differentiate is the deep tendon reflexes. In lower motor neuron damage, the deep tendon reflexes will be diminished. In upper motor neuron damage, they will be increased. So you can say hyperreflexia in UMN damage. And you will have decreased deep tendon reflexes, that is hypo or even absent reflexes, hypo or areflexia in LMN damage. And then plantar reflex. The plantar reflex will be extensor in upper motor neuron lesion and flexor in lower motor neuron lesion. And this extensor plantar is also called as Babinski sign. Babinski sign positive. Another thing is atrophy. Atrophy is a classical finding of lower motor neuron lesion. It is not usually encountered in upper motor neuron lesion. So key points I want you to remember here is simple. In the upper motor neuron lesion, everything goes up. In lower motor neuron lesion, everything goes low. In upper motor neuron damage, tone increases, reflexes increase, and plantar is extensor. That is Babinski. Extensor means going towards the sky. Flexor means going towards the ground. So everything goes down in the lower motor neuron lesion, everything goes up in the upper motor neuron lesion. Right? So this is one table I want you to buy. So with that basics, we'll start with the first important topic. So in fact, from the neuro, in the recent times, 3 topics are most important. The first one is Myasthenia Gravis, second one is GB syndrome, third one is multiple sclerosis. Right? So we'll start with Myasthenia Gravis. So what is Myasthenia Gravis? Myasthenia Gravis is a neuromuscular junction disorder. And when we talk about neuromuscular junction, we're talking about a nerve terminal and a muscle, right? The junction between the nerve terminal and the muscle. The nerve terminal is the motor neuron because it is connecting the muscle. So motor neuron begins its journey in the brain and ends in the spinal cord, that is upper motor neuron. From the spinal cord to muscle, whatever comes, that is lower motor neuron. So the junction between the lower motor neuron and the muscle is neuromuscular junction. And in that we have a nerve end and a muscle end. So if a disease affects the nerve side of it, we will call it as presynaptic neuromuscular junction disorder. And if a disease affects the muscle side of it, we will call it as postsynaptic. So in the Myasthenia Gravis, most commonly you have antibodies targeting what we call as acetylcholine receptors. These are the acetylcholine receptors, to be more precise, the nicotinic type of acetylcholine receptors. So antibodies are targeting them. So that's why the Myasthenia Gravis is considered as a postsynaptic neuromuscular junction disorder. It's a postsynaptic neuromuscular junction disorder. It's an autoimmune disorder. Your own immune system is producing antibodies against your acetylcholine receptors, and if that is the case, what is the name of the antibodies? So the antibodies that we get in patients with Myasthenia Gravis are number 1, anti-acetylcholine receptor antibody. Number 2, we have anti-muscle specific kinase antibody. And number 3, relatively less common, we have anti-lipoprotein 4 receptor antibody. So among them, the most common antibody is anti-acetylcholine receptor and the second most common is anti-MuSK. The anti-LP4 is rare. Okay. Now how the patients present if I have Myasthenia Gravis? So the clinical features are very peculiar. So in Myasthenia Gravis, basically there's a battle going on between the antibodies and our own acetylcholine to bind to the receptor. Okay. Generally, who binds depends on whose concentration is more. Antibodies are more, antibodies bind. Acetylcholine is more, acetylcholine binds. So generally what happens is when we start the day, we have a lot of acetylcholine. So acetylcholine wins in the mornings. But as the time progresses, acetylcholine level starts decreasing because we are using it. Antibodies are constant. So they start winning as the day progresses. So as the day progresses, antibodies start binding to the receptors and blocking the neuromuscular junction communication. So as the day progresses, the symptoms worsen. So these patients present with ptosis or drooping of the eyelids plus proximal muscle weakness, which worsens on repetitive use of muscles. The more I use a muscle, more weak it becomes, because acetylcholine all gets spent, right? That's why they have more weakness in the evening than morning. And exactly opposite of it can be said for the Lambert eater. Okay, so that's a key differentiating point. In the Lambert eater, the more I use the muscle, more stronger it becomes. In myasthenia gravis, more weaker it becomes. So if someone presents with drooping of eyelids and proximal muscle weakness, which worsens in the evening, the story is about myasthenia gravis. Now, how am I going to diagnose? So when it comes to diagnosis, all of you are familiar with the tensilon test, but that's not the preferred investigation. The preferred investigation is called as single fiber electromyography, SFEMG, single fiber electromyography. What it shows? It shows in the single fiber electromyography, repeatedly we keep stimulating the muscle with an electrical impulse, and we already know that repetitive use of the muscle worsens the weakness. So if I keep stimulating, the force of contraction of the muscle goes on decreasing. So it will present with what we call as decreasing compound muscle action potential. We call it as decremental response. Decremental response. Some books, some authors may also mention it as increasing jitter. What is jitter? Jitter refers to a failed contraction. So if a muscle contracts well, it's a contraction. But if it fails to contract, it partially contracts, it's a jitter. So the more I start using the muscle, initially it may be able to contract, but as I start using it more, it fails to contract. It starts producing half partial contractions. We call them as jitter. So either you can say force of contraction went down, or the jitteriness increased. Increasing jitter or decreasing force of contraction. But if they ask you what is the screening test of choice, this is not screening test. This is for confirmation. The screening test of choice is ice pack test. So if you put ice pack to an eye with a ptosis, it will show that ptosis improves upon putting a ice pack. And it's very convenient and safe, so it's considered as screening test. But if the teacher is asking you what is the most specific test, the most specific test, so there are 3 MCQs here. What is preferred test? Single fiber electromyography. What is screening test? Ice pack. What is most specific? Getting the anti-acetylcholine receptor antibody. Anti-acetylcholine receptor antibody. Okay. So we have understood the basics of myasthenia gravis. Let's quickly write it down. So what are the antibodies present? The most common antibody that we got is anti-acetylcholine receptor antibody. Okay. Apart from that, anti-MuSK was the second most common, and we had least common as anti-LP4R. If anti-acetylcholine receptor antibody is present, it is called as seropositive myasthenia gravis. Okay. And why are we getting this classical ptosis? Because the levator palpebrae superioris is the first affected muscle which produces the ptosis. And after the levator palpebrae superioris, the next muscle that gets affected is the extraocular movement muscles. So once the other eyeball muscles get affected, the patient starts developing diplopia, double vision. After this, there will be involvement of proximal muscles. And when the proximal muscles get involved, they get proximal weakness. Eventually, there will be involvement of facial muscles. And when the facial muscles get affected, very important, there will be drooping of face. And this drooping of face produces what is called as myasthenic smile. Myasthenic smile. When you ask them to smile, they can't raise the lateral edge of the lip of the lateral edge of the mouth. The lips don't raise like this. Normal smile is we elevate. They fail to elevate, only the philtrum gets lifted, revealing the teeth. So that smile is called as myasthenic smile, or there is another name given to that. It is called as there's another name given to this. It looks like the expression of a dog. So dog has various expressions: barking, growling, right? So can anybody tell me what is another name given to the myasthenic smile? What are the expressions of a dog? Growling, barking. Okay, just give me 1 second. The word is not coming to my mind, but they can directly use that word. It's called snarling faces. So snarling is the expression of a dog where dog is trying to scare you by showing its teeth. So it's called snarling face. Now, investigation wise, we have already discussed what is the preferred, what is more specific, and what is screening test. Let us also talk about tensilon test. So in tensilon test, what do we do? In tensilon test, patient has ptosis because of myasthenia gravis. We administer edrophonium or other acetylcholine esterase inhibitor. So acetylcholine increases and ptosis improves, or you can say decreases. That is equal to myasthenia gravis. But why is it not preferred? Because there is a risk of, due to risk of cholinergic crisis. What do I mean by cholinergic crisis? See, if I give a acetylcholine esterase inhibitor like edrophonium, the acetylcholine starts increasing. I want more acetylcholine in the neuromuscular junctions of the skeletal muscles, but the acetylcholine will increase in other locations also, and that start causing the side effects like lacrimation, salivation, defecation, urination, all those problems, bradycardia, and certainly we don't want that. That's why tensilon test is not preferred today. Okay. Now coming to the management of myasthenia gravis. How do you manage? As I've already told you, myasthenia gravis, you have to think of a fight between antibodies and acetylcholine. So what I want, which side I want to win? I want the acetylcholine to win. So how can I make it win? Either increase the quantity of acetylcholine or decrease the antibodies. We'll try to do both. How will I increase the acetylcholine? I can increase the acetylcholine by acetylcholine esterase inhibitors. And the drug of choice acetylcholine esterase inhibitor is going to be pyridostigmine. Why pyridostigmine? Because it is long acting. I don't want to keep repeatedly giving the acetylcholine esterase inhibitors, right? I want relatively longest acting so that I have to have less frequent dosing. And at the same time, I also want to decrease antibodies. How do I decrease antibodies? One of the choices immunosuppression, other one is steroids. So I can use steroids or immunosuppressants like azathioprine. They will reduce the immune system's activity and reduce the antibody production. But antibodies can also be decreased by removing the thymus gland. So, and I want you to remember one point here, thymectomy only useful for, so it's not useful for everyone. It's only useful for seropositive myasthenia gravis. And what do I mean by seropositive myasthenia gravis? Those are the myasthenia gravis patient. Those are the myasthenia gravis patients who have anti-acetylcholine receptor antibody positivity. Anti-acetylcholine receptor antibody positive myasthenia gravis is seropositive myasthenia gravis. So if I have myasthenia gravis because of anti-MuSK or anti-lipoprotein 4 receptor antibody, then thymectomy is not useful in reducing the antibody load. So you have to give me pyridostigmine, you have to give me steroids or immunosuppressants. But if you have seropositive, thymectomy may be useful, it may be curative. So it's like thymectomy done and after that you may not require drugs. So this is a very, very important MCQ point. Where is it useful? And again, remember, we do it for fit patients. Elderly patients are not generally fit, so we don't do thymectomy for elderly seropositive patients as well. Okay, so the next topic is GB syndrome. GB syndrome. What is GB syndrome? It is similar to rheumatic fever. Like how streptococcal infection activated immune system produces antibodies and causes the damage to multiple organs in rheumatic fever like carditis, syndrome, scoria and all. In GB syndrome also, infection is responsible, but not directly. Infection triggers your immune system. So GB syndrome is an infection triggered autoimmune inflammatory polyneuropathy. Means it's a disease of the peripheral nerves. affecting multiple peripheral nerves, and peripheral nerves contain lower motor neurons. So this is a lower motor neuron disease. Myasthenia gravis was a neuromuscular junction disease. This is a lower motor neuron disease where multiple nerves get affected because of your own immune system causing them damage. And if infection is a trigger, the first question is which infection is responsible. So the most commonly responsible infection is Campylobacter jejuni gastroenteritis. Various other infections can also cause, but this is the most common infection. So story of the question may go like this. A patient had dysentery. 2 to 3 weeks later, he presented with weakness. So how do they present? They present with, because when peripheral nerves get affected, longest nerves get affected first, followed by next longest, followed by next longest, and longest nerves are going to the distal body parts, that is hands and feet. So feet is the one which gets affected first, and then the weakness starts progressing from distal to proximal. So that we will call it as ascending paralysis. So they present with rapidly progressing ascending paralysis. And because it is the lower motor neurons that are affected, all the paralyzed limbs, if you examine, element is affected. So what will happen to the tone? The tone will be decreased. So you will have flaccidity or hypotonia. And when you examine the reflexes, you will notice that the reflexes will be diminished or absent. So you can have hypo or absent, areflexia. So clinically the story goes like this. Patient had dysentery, followed by that he presented with ascending paralysis. Examination showed decreased tone and decreased reflexes, or flaccidity and hypo or areflexia. Now, is that enough for diagnosis? Clinically it's usually enough, but we do get some help from the laboratory. So 2 laboratory support systems are there. The first one is you can do nerve conduction studies. In nerve conduction studies show why the nerves are damaged, either because of demyelination or because of the injury to the axons or because of axonal injury. Then you can also do a CSF analysis. And because GB syndrome is predominantly a antibody mediated disorder, minimal or no role of cell mediated injury. So you will notice that in the CSF, the antibodies are increasing in concentration, and antibodies are immunoglobulins. Immunoglobulins are globulins, means proteins. So protein in the CSF increases. You will have high CSF protein, but fairly normal or minimally abnormal cell count. So this high protein but not increase in the cell count, we will call it as albuminocytological dissociation. A very, very important clue in any question. If any question says this patient has albuminocytological dissociation, though it is seen in various conditions, for you in the exam, it's always almost about GB syndrome, albuminocytological dissociation. And what does that mean actually? Albumin is protein, cytology means cells. They are dissociated. In various conditions like meningitis, encephalitis, brain abscess, subarachnoid bleed, the CSF protein as well as cell count both increase. But here, cell count is not increased, only protein is increased. They are separated or divorced. That's the meaning of albuminocytological dissociation. And these 5 things put together, the diagnosis, there is a name given to this criteria. It is called as Brighton's criteria. Okay. So what is the criteria used? Brighton's criteria. 3 clinical parameters, that is ascending paralysis, flaccidity, hypo or areflexia, and 2 lab parameters, that is nerve conduction study either showing damage to myelin or axons, and CSF analysis showing albuminocytological dissociation. Once you're diagnosed, let's talk about the management. And remember, when it comes to management, the most common cause, see, nobody dies just because of paralysis. If one limb is paralyzed, nobody is going to die. If both the lower limbs are paralyzed, nobody is going to die. The most common cause of death is due to respiratory failure. Because the ascending paralysis one day will hit the respiratory muscles, and if the respiratory muscles get affected, breathing stops and you will end up with loss of life. So respiratory failure is the most common cause for death. So the main goal of treatment is to make sure that you don't develop respiratory failure. And why will the patient develop respiratory failure? Because antibodies cause the damage to the neurons going to the respiratory muscles. So if I remove the antibodies from the body, no more damage to the respiratory muscle neurons, so no more dysfunction of the respiratory muscle, no chance of death. So how will I remove the antibodies? So antibodies can be removed from the body through plasmapheresis or plasma exchange or IV immunoglobulins. And because of the slight superiority, IV immunoglobulins are the preferred mode of treatment for the GB syndrome, right? Another thing you have to remember is FVC monitoring. Because in GB syndrome patients, the involvement of respiratory muscles, I want to detect early so that I can intubate and keep the patient on ventilator. I don't want to do it as an emergency when the things are bad for the patient. So I can identify the development of respiratory muscle involvement by monitoring the forced vital capacity. And then I ask you when the intubation is indicated. So intubation indicated if FVC is less than, if forced vital capacity is less than 15 ml per kg. So you keep monitoring regularly, and anytime it drops less than 15 ml per kg, intubate and put the patient on ventilator, right? So that's about the GB syndrome. Okay, the next topic we have is stroke. So what is stroke? Stroke refers to focal or global neurological deficit or neurological dysfunction of vascular origin. Function of vascular origin means when a problem in the blood vessel leads to loss of function of some or whole of the brain, we will call it as stroke. And what can go wrong with the blood vessel? Either it can get blocked, in that case we will call it as ischemic stroke, or it can rupture and bleed, in that case we will call it as hemorrhagic stroke. So we have predominantly two types of stroke, ischemic stroke and hemorrhagic stroke. And please remember, the ischemic stroke is more common than hemorrhagic stroke. Ischemic stroke accounts for 85% of the cases, while hemorrhagic stroke accounts for around 15% of the cases. Okay. Then I also want you to be familiar with the term called as TIA, transient ischemic attack. So what is TIA? So to call it as TIA, it has to be transient, right? So transient ischemic attack refers to stroke-like symptoms showing complete resolution of symptoms. Like let us say someone developed hemiplegia, possibility of a stroke is there, but the symptoms resolve within 24 hours without, what I'm writing next is important, without objective evidence of an infarct. So you saw a patient, he had hemiplegia, the symptoms improved within 24 hours, and when you did the brain imaging, no infarct is there. So when the two criteria are met, then it is TIA, right? Please remember, there should be no objective evidence of infarction. Any question where symptoms resolve even after 10 minutes, if the infarct is visible, we will count it as stroke. That is not going to be TIA, right? And TIA, if today TIA has happened, the patient was lucky because the blocked blood vessel got relieved, because the clot got dislodged or got dissolved, and that's why the symptoms recovered. But tomorrow he may not be lucky, because if he had developed TIA today, that means he has risk factors. He has risk factors for the blockage of blood vessel. So today it was a lucky event, tomorrow you may get a stroke, right? So they are associated with, TIA episodes are associated with increased risk of stroke. And if there is increased risk of stroke, can I quantify it? Yes, the risk stratification can be done. I can quantify by what we call as ABCD2 score. CD2 score. So ABCD2 score decides how much is the risk of developing a stroke in a patient who had presented with TIA, right? The ABCD2 score is very easy to remember because it's there in the name itself. ABCD2 itself is a mnemonic where A stands for age, B for blood pressure, C for clinical features, D for duration of symptoms, another D, ABCD2, another D is diabetes, right? Okay, so if age is more than or equal to 60 years, patient gets 1 point. BP more than 140 by 80 or equal, patient gets 1 point. In terms of clinical features, if patient has got unilateral weakness, that is hemiplegia, he will get 2 points. But instead of hemiplegia, he has got only speech impairment, Broca's or Wernicke's aphasia, then he will get 1 point. If the symptoms resolve within 24 hours to call it as TIA, but within that 24 hours period, if they last for less than 60 minutes, 1 point. But if they lasted for more than 60 minutes, 2 points. And if patient is diabetic, 1 point. And now we will stratify it as low, moderate or high risk of developing stroke. So when do we call it as high is an MCQ. So whenever the ABCD2 score is more than or equal to 6, if the score is more than or equal to 6, there is a high stroke risk. If the score comes less than 6, then the stroke risk is less. It is mild or moderate. So 6 is the number I want you to remember. Okay. So now we learned what is stroke and what is TI. Stroke refers to focal or global neurological dysfunction due to vascular origin. But if these symptoms resolve within 24 hours and you don't find any infarct, you call it as TI. Okay. Now the question is, when I have stroke, the early recognition of stroke is very, very important, because one of the blood vessel is blocked and because of that the neurons are dying. If I open the blood vessel early, then I will be able to re-establish the blood flow to the brain, and at least the neurons which are not dead but they are likely to die in next few hours, they will be saved. So early recognition and opening the blocked blood vessel is very, very important. But how will I recognize the stroke early? So there are two things that will help for you to recognize the stroke early. The first is for the layman or patient attenders, and then for a clinician. So for laymen, we have something called as B-fast algorithm. MCQs have been asked on this. Which of the following is, or which of the following is or is not a component of B-fast algorithm? So what is this B-fast stands for? B stands for balance issues. If the patient notices that any issue with the balancing, or I stands for vision or eyesight issues. If you notice blurring of vision, diplopia, or any symptom related to vision. F stands for face. If you notice any asymmetry or drooping of the face. A stands for arm. If you notice weakness of arms on any side, right side or left side. S stands for speech. Any abnormality of speech, not able to understand speech, not able to produce speech, or producing a slurred speech, that is yes. So if any of these symptoms are noticed, balance issues, eyesight issues, facial asymmetry, arm weakness, or speech issues, T stands for time. Without wasting time, you're supposed to call an ambulance service. In the West, it is 911, right? That is the B fast. For the clinicians, for a quick recognition of stroke in the emergency room, we have something called as Barre's sign or pronator drift sign. Pronator drift sign. This is considered as the earliest sign of motor stroke. Earliest sign of motor stroke. So with this, once you recognize a stroke, how are you going to manage? So first I need to know whether it is ischemic stroke or hemorrhagic stroke. So for that I need to go for the imaging. So any case of stroke or a suspected stroke, I have to go ahead with the imaging. The investigation of choice is going to be non-contrast CT. Non-contrast CT is a good investigation for identification of bleed, not for the infarct. But if bleed is not there, because it's highly sensitive for bleed. If bleed is present, of course it is hemorrhagic stroke. But if there is no bleed, that means hemorrhagic stroke is ruled out. And whatever left is ischemic stroke. So if contrast CT, non-contrast CT does not show bleed, that means you are dealing with a ischemic stroke. You're dealing with ischemic stroke. Now let us understand the management of ischemic stroke. If I have ischemic stroke, how do you manage? So if you have acute ischemic stroke, the best treatment is opening the blocked blood vessel. If I open the blocked blood vessel, I can re-establish the blood flow to the brain. But how long after the onset of stroke I can open the blocked blood vessel? Up to 24 hours is the window period. After 24 hours, if a blood vessel is blocked going to this part of the brain, right? Let us say this part of the brain was getting the blood supply. If it is blocked, by 24 hours, all this brain area will be dead. After that, even if you open this blocked blood vessel, you don't get any benefit. If you want to open, you have to open it before 24 hours. So 24 hours is the window period. So that's why when we want to open, like when I get a case of stroke, it's very important the time of presentation after the onset of symptoms. Time of presentation. If patient has presented more than 24 hours after onset of symptoms, then all the area that was supplied by that blocked blood vessel is dead. So there is no role of opening the blood vessel. We will only offer them secondary prevention. This stroke, we can't do anything. It's gone. That brain is dead. That part is gone. I just want to prevent you from developing another episode of stroke, another blood vessel getting blocked and developing another stroke. That I can prevent. How can I prevent? I can give aspirin or clopidogrel plus statins. Now, if the patient presents within 24 hours, then there is a role of opening the blocked blood vessel. You can say role of revascularization is present. But how can I open the blocked blood vessels? I have two methods. The first one is to give a medication to dissolve the clot. The second one is to pass a wire and remove the clot. So when we pass the wire and remove the clot, it is called as mechanical thrombectomy. But if I give the medication to dissolve the clot, it is called as thrombolysis. Thrombolysis is easy. Mechanical thrombectomy needs expertise. So mechanical thrombectomy right now is not readily available and it is not suitable for all blood vessels. Only selected blood vessels can be handled by mechanical thrombectomy. So that's why the go-to treatment, if they present well in time, is generally going to be thrombolysis. But thrombolysis is safe only up to 4.5 hours. So if they have presented within 4.5 hours, then we go for thrombolysis. If they present anywhere between 4.5 to 24 hours, then thrombolysis is not considered safe. So in that case, we can go for mechanical thrombectomy. But to understand whether the block is there in a blood vessel where mechanical thrombectomy is possible or not, we need to go for CT angio. And if CT angio shows that there is a block in a large vessel, it's called as large vessel occlusion, where mechanical thrombectomy is possible, then you go ahead with mechanical thrombectomy. But if there is no large vessel occlusion, then mechanical thrombectomy is not possible. So in that case, nothing is possible. Patient is presented after 4.5 hours, so I can't do thrombolysis. And block is there in a vessel where mechanical thrombectomy is not possible. So I'm again sticking to secondary prevention. This stroke is gone. The remaining neurons which are alive will also die. I can't do anything about it. Right? And then the patients who had presented within 4.5 hours, after thrombolysis, only 50% clots open, remaining 50% may not dissolve. So you have to still go for a CT angio, and if the CT angio still shows that there is a large vessel occlusion, you still go ahead with mechanical thrombectomy, right? So this is about your approach to stroke. This algorithm is highly important. So please memorize this. Hopefully you will get one more important question from this topic. So that's about stroke. Okay, so from neuro now let's move to the nephrology. Okay, so nephrology, what are the important questions asked? The questions are mainly related to the ABG, AKI versus the pre-renal AKI versus intrinsic renal or ATM, CKD related complications, and glomerular disorders. Glomerular disorders, you don't have to study from medicine if you've done it from path, because most questions are going to come from path, not from medicine. Medicine questions will be related to AKI, mainly AKI renal versus pre-renal, then CKD complications mainly, and ABG, right? So we'll start with the ABG. Hopefully we'll get 1 mark because almost every year there is a question on ABG. So I will start with a example and then we will see how to deal with that. Okay, and before that, let me also list the normal values. So normal parameters in a ABG are pH, PaO2 anyway not required right now, PaCO2 and bicarbonate, right? So the normal pH, as you know, it is 7.35 to 7.45. Normal PaCO2 is 35 to 45 millimeters of mercury, and normal bicarbonate is 22 to 26 millimoles per liter. These are normal values, right? Now we are going to take an example. Please spend 10-15 minutes trying to understand concepts of the ABG, because after JVP, ABG is the next most important topic. Almost one question is guaranteed. 99% the question will be asking you on a metabolic acidosis, whether it is high anion gap metabolic acidosis or non-anion gap metabolic acidosis. So we will take one question. So let us say we are talking about pH mentioned here is 7.39. Partial pressure of carbon dioxide, PCO2 or PaCO2, is around 20 millimeters of mercury, and bicarbonate here is 10 millimoles per liter. Okay, I will also mention your sodium value, which is 138, and chloride value, which is 110 millimoles per liter. Okay, so this is the ABG. You have to analyze and diagnose what is the problem. So when you look at the pH, it appears to be normal, right? Isn't it? Within the normal range of 7.35 to 7.45. So how will I address this? Is it normal? No, there is an acid-base disorder. So every time you see normal pH, don't jump to conclude that there is no acid-base disorder. It's not normal. Because you have to also see PaCO2 and bicarb. If all the three parameters are normal, pH, PaCO2 and bicarb are normal, then you don't have any acid-base disorder. If pH appears normal, but PaCO2 or bicarb are abnormal, there is an acid-base disorder, but a counter-regulatory mechanisms have pushed the pH back to normal range. Such ABG disorders are called as fully compensated. So basically what happens is, the respiratory system and kidneys act as compensatory organs. So if I have a problem in the respiratory system, kidneys try to compensate. And if I have a problem in the metabolic system, the lungs try to compensate. How do they compensate? Kidneys handle bicarbonate, lungs handle carbon dioxide. Okay, and carbon dioxide is acid. So please remember, carbon dioxide is acid. Why is it acid? Because carbon dioxide, when dissolved in water, it becomes carbonic acid. So lungs can increase or decrease the excretion of carbon dioxide, and kidneys can increase or decrease the excretion of bicarbonate, which is base. So now tell me, if acid increases, to counter that, what will happen to the base? Decrease or increase? Increase. If acid is increasing, but if I want to keep the pH same, I have to increase the base. If base is decreasing and I want to keep the pH same, I have to decrease the acid. So one rule is very important here. The PaCO2 and bicarbonate, whichever is the primary abnormality, if PaCO2 is increasing, bicarbonate is supposed to increase to compensate. If bicarbonate is decreasing, PaCO2 is supposed to decrease to compensate. So if bicarbonate is increasing or decreasing as a primary abnormality, it is a metabolic abnormality. If carbon dioxide is increasing or decreasing as a primary abnormality, it is a respiratory abnormality, right? So now let us say that lungs fail to excrete the carbon dioxide. That's the primary abnormality. So carbon dioxide increase. So primary problem is with lungs. Now what should happen to bicarbonate? Bicarbonate should also increase. Who will do that? Kidneys. So kidneys will reabsorb more bicarbonate so that the pH remains normalized. That's a compensatory change. And if the compensatory change is strong enough to push the pH back to normal, like you see in this case, then we will call it as fully compensated acid-base disorder, right? Got it? So this abnormality, whatever it is a fully compensated acid-base disorder. Now the question is whether it is metabolic acidosis or metabolic alkalosis, or whether it is respiratory acidosis or respiratory alkalosis. How will we decide? Okay, so there is a simple rule. So first thing, you have to identify whether it is acidosis or alkalosis, right? So step number one, you have to decide acidosis or alkalosis. How do you decide this? If the pH is not fully compensated, it is pretty easy, right? If you know that pH is less than 7.35, it is acidosis. If it is more than 7.45, it is alkalosis. So you have this range. Sorry. So if it is 7.35, 7.45. So more than 7.45, you have alkalosis. Less than 7.35, you have acidosis. But if the compensatory changes put it back to normal, how will I decide whether it is acidosis or alkalosis? You will take a median number. Median number between 7.35 and 7.45 is 7.4. So if it is on this side of 7.4, it is acidosis. If it is on that side of 7.4, it is alkalosis. we are applying this rule only if the pH is in the normal range. If it is outside the normal range, directly you know which is acidosis and which is alkalosis. So in this case, it is in the normal range. So we are using the 7.4 as the cutoff. Is it less than 7.4 or more than 7.4? Less than 7.4. So it falls in the acidosis. So that means we are dealing with acidosis in this question. So now let me label this as acidosis. So this is a case of acidosis. The now next question is, I have to decide whether it is respiratory or metabolic. So that is going to be my step 2. Respiratory versus metabolic. So how we decide that? We follow what is called as Rome or ROMS criteria. What does that stands for? Respiratory opposite, metabolic same side. So we will assign a direction to pH and PCO2. Right, we're not looking at bicarbonate, please remember. pH and PCO2. If they are in the same direction, then it is a metabolic abnormality, whatever it is, acidosis or alkalosis, it is metabolic. And if they are in the opposite direction, it is respiratory. Right, let us assign the direction to the pH. What is happening to the pH here? So in a fully compensated, 7.4 is the cutoff. So it is decreased than 7.4. So pH is down. And what about carbon dioxide? Normal is 35 to 45. That is also decreased. So both are in the same direction. pH and PaCO2 are in the same direction. Respiratory is opposite, metabolic same. That means we are dealing with metabolic acidosis. So this is a classical metabolic acidosis. Now, in that case, what is the primary abnormality? Metabolic means you should always think about bicarbonate as the primary abnormality. Respiratory means carbon dioxide. So here, the bicarbonate, as you know, is normal 22 to 26. It is decreased. And this decreased bicarbonate is the primary abnormality. And decrease in carbon dioxide is the compensatory change, or it is secondary to bicarbonate decrease. Okay, so now we understood that this is metabolic acidosis. Now we can also calculate whether for this level of bicarbonate, the decreased carbon dioxide is appropriate or not. At the FMGE level, all that is not required. Mostly they will ask you further if it is metabolic acidosis. So step number 3, I will only concentrate on the metabolic acidosis. If it is metabolic acidosis, you have to calculate anion gap. So what is this anion gap then? So anion gap refers to the difference between, so in our body, we have anions and cations. Anions means like chloride, then phosphates. These are all negatively charged. They are anion. Cations are calcium, magnesium, and more importantly, sodium, potassium. These are cations. The truth is, in human body, the number of anions and cations is always equal, balanced. There is no differences in the negative and positively charged ions. Because if there is a difference, then we literally become a human battery. Means there will be stored electricity which will flow out whenever connected to a conducting source. We are not batteries, we are human beings. So we have equal amount of anions and cations. But if I have to measure, would I normally measure all the anions in the body and all the cations? If I measure, they are equal. But in routine measurement, we don't measure all anions and all cations. We measure some anions, some cations, and when we measure and look at the difference between them, that gap is called as anion gap. Anion gap is nothing but the difference between the measured anions and measured cations. What is the major measured cation? It is the sodium. And what is the major measured anion? You have chloride plus bicarbonate. These are measured, commonly measured anions, and the difference between the two is anion gap. The normal anion gap ranges from 8 to 12 millimoles per liter. That's the unit. If it is more than 12, if anion gap is more than 12, that patient with metabolic acidosis is said to have high anion gap metabolic acidosis. If it is less than 12, you can say non-anion gap or normal anion gap metabolic acidosis. Okay. So now let us calculate the anion gap also for this patient. We took this example, right? So we learned that it is a metabolic acidosis, and the term that should go behind this is it is a fully compensated because pH is normal. And now I have to decide whether it is high anion gap fully compensated metabolic acidosis or non-anion gap fully compensated metabolic acidosis. So I have to calculate anion gap. So what is the formula? Sodium minus bicarbonate plus chloride. So sodium is 138 here, minus bicarbonate is 10, chloride is 110, so 120. So how much is the anion gap? 138 minus 120 is 18. 18 is more than 12. That means this patient has got high anion gap metabolic acidosis. So it is fully compensated and it is actually high anion gap metabolic acidosis, right? So most likely they will ask you questions related to the anion gap calculation itself. So I want you to remember how to calculate it. It is sodium minus chloride and bicarbonate combined. More than 12 hagma, less than 12 nagma, right? So what are the common causes for high anion gap metabolic acidosis? This mnemonic you might have heard. So for the high anion gap metabolic acidosis, the common mnemonic that everyone remembers is mud piles. You can also remember it as gold mark or gold pert. Mud piles. Mud piles, M stands for methanol poisoning, uremia, that is seen in patients with acute kidney failure or CKD. Diabetic ketoacidosis is D. P for fenformin and paraldehyde, I for INH and iron toxicity, L for lactic acidosis, E for ethanol poisoning or ethylene glycol poisoning, and S for salicylates. And then if the anion gap is normal, then you can remember mnemonic used part. What used part stands for? U for urinary diversion or ureteroenterostomy, S for small bowel fistula, E for extra chloride, D for diarrhea. So diarrhea causes non-ion gap metabolic acidosis. Similarly, renal tubular acidosis causes non-ion gap metabolic acidosis. These are the two important causes I want you to remember. Addison disease, pancreatic fistula, tenofovir, and topinamide. The mnemonic is used part. Used part, gold mark or mud piles for high anion gap metabolic acidosis. So I hope you have understood the approach. Simple. Look at the ABG, look at the pH. Okay. Let me give you an algorithm. I will add a page here, or there is space here. So I will write the algorithm for the ABG. So first thing you will see is pH. So if pH is less than 7.35, then you know it is acidosis. If it is more than 7.45, then it is alkalosis. Next is ROMS. To decide, in both these cases you are following RAMS to decide whether it is metabolic versus respiratory. Okay. On the other hand, if the pH turns out to be between 7.35 to 7.45, there are two possibilities. Either you have no acid-base disorder or you have a fully compensated acid-base disorder. So in all these cases, you have to call it as partially compensated. So you have partially compensated acidosis if pH is less than 7.35, or you have partially compensated alkalosis if the pH is more than 7.45. But if it is in the normal range, either you have no acid-base disorder at all or you have fully compensated. So what you have to do is then you have to see PaCO2 and bicarbonate. If these values are normal, means pH also normal, PaCO2 bicarbonate also normal, that means there is no acid-base disorder. But if they are abnormal, increased, decreased, whatever, then you will look at pH, whether it is less than 7.4 or whether it is more than 7.4. So if it is more than 7.4, you have a fully compensated alkalosis. Again, you will follow the ROMS to decide whether it is metabolic or respiratory. And if it is less than 7.4, you have fully compensated acidosis. You will follow the ROMS to decide whether it is metabolic or respiratory, right? So this is the approach to ABG. And if with this, you will always get the right diagnosis of acid-base disorder with this algorithm. Once you've done that, if it is metabolic acidosis, they may ask you to calculate the anion gap. What is anion gap? Sodium minus chloride and bicarbonate combined. Less than 8, non-anion gap metabolic acidosis, you have the mnemonic used part. More than 12, you have high anion gap metabolic acidosis, you have the mnemonic multiples. Do you have to by heart it? Yes, literally you have to by heart it, because repeatedly they are asking questions on this. Okay, so that completed our acid-base disorders. Okay, so next we'll go to the acute kidney injury part of AKI. As I've already told you, the glomerular disorders like PSGN, IgA nephropathy, all of that study from path, it is more than enough, because mostly questions are related to path image findings or the site of deposition of immunoglobulins. From medicine, it's mostly about AKI, CKD, and ABG, and renal tubular acidosis. So if you're talking about AKI, what is AKI? Acute kidney injury, I know. The criteria, when do you call it as acute kidney injury? There are 3 criteria. The first criteria, serum creatinine increases by more than or equal to 0.3 milligrams within 48 hours. Means, let us say right now when I checked my creatinine, it was 1, and when I check tomorrow, that's of course 24 hours, so within 48 hours, tomorrow it is 1.4, so it increased by 0.4, more than 0.3 increase within 48 hours. So then yes, I developed AKI. That's the first criteria. The second criteria is if serum creatinine increases by 1.5x within 7 days. And remember, some books, instead of calling it as 1.5x, they may mention it as 50%. Like I had 1 milligram today, and when you check 5 days later, it is 1.6 milligram. So how much it increased? It became 1.5 times or more, right? 1.5 times of 1 is 1.5. It became more than that. Or in terms of percentage, how much it increased? 60%, more than 50%. So either it can be labeled as increase by more than 1.5 times the baseline value, or by more than or equal to 50%. That is second criteria. Both are creatinine based, and we also have a urine output based criteria, because you need not always have increase in the creatinine when kidneys are becoming dysfunctional. Instead, your urine output might come down. So if there is urine output decreases, how much decrease in the urine output? Less than 0.5 ml per kg per hour for more than or equal to 6 hours. Then we will call it as acute kidney injury. Acute kidney injury. Now this AKI, we also have a staging. This I want you to by heart, because number wise questions are asked. There's also a KDIGO staging of this acute kidney injury. KDIGO staging, basically classified as stage 1, 2 and 3. So because in the diagnostic criteria we have creatinine and urine output, so both parameters will be used for staging. So first we will understand the creatinine parameters. To call it as acute kidney injury, I need 0.3 milligrams increase in 48 hours, or 1.5 times the normal value or baseline value, which should become within 7 days. So if it is more than 1.5 times the baseline value, then it is AKI for sure. If it is 1.5 to 1.9 times the baseline, that is stage 1. So to call it as AKI, I need it to be more than 1.5 times. But if it is 1.5 to 1.9 times, it is stage 1. And if it is 2 to 2.9 times, it is stage 2. And if it is 3 times the baseline or higher, it is stage 3. For any patients who required dialysis, regardless of the creatinine value, it is stage 3. Okay. So simple way to remember is 1.5, more than 1.5x is stage 1, more than 2x is stage 2, and more than 3x is stage 3. So 1.5 to 1.9 is stage 1, 2 to 2.9 is stage 2, and 3 or higher is stage 3. Or anyone requiring renal replacement therapy, that is dialysis, it is stage 3. This is based on creat. If I am looking at urine output less than 0.5 ml per kg per hour for 6 hours is AKI. If it is remaining that low for 6 to 12 hours, stage 1. If more than 12 hours is already over, it is stage 2. And if urine output is even less, that is 0.3 ml per kg per hour for 24 hours, we will call it as stage 3, right? This is KDIGO staging. Staging is not very important, but the diagnostic criteria is. Okay. Now the question is, what are the causes why someone develops this acute kidney injury? So the causes for AKI will be classified into 3 categories. Pre-renal. The kidneys may lose their function just because they're not getting sufficient blood supply. That is pre-renal. Or there could be damage to the kidney itself. That is renal. Or kidneys are getting the blood supply. They're doing the filtration process, but you're not able to excrete it out because there is an obstruction to the outflow of urine. Then it is post-renal. Post-renal. Okay. So what are the common causes for post-renal? You can have bilateral urethral obstruction. Bilateral ureteric obstruction, sorry. That could be because of stones, tumors compressing, or it could be bladder outlet obstruction. And if I'm suspecting post-renal, what is the investigation of choice? It could be ultrasound or CT scan. It can clearly identify that, okay, the outflow of urine from the kidney is impaired. Either both the ureters are blocked or the bladder outlet is blocked. I don't have to do any more special investigation. CT or ultrasound will solve the problem. Okay. Now, if it is renal, the renal AKI could be because of glomerular injury, that is glomerulonephritis. See, kidney basically has a nephron, means multiple of those nephrons, and the nephrons and the surrounding connective tissue. And nephrons, as you know, has glomeruli. So nephron parts can be divided as glomeruli and then tubules, PCT, DCT, and the surrounding connective tissue. So when the glomeruli get affected, that is glomerulonephritis, like your post-streptococcal glomerulonephritis, IgA nephropathy, these are all glomerulonephritis. They can present with acute kidney injury. Then damage to the tubules can present with acute kidney injury, and when tubules get acutely damaged, we will call it as acute tubular necrosis or ATN. Okay. The third thing is surrounding these is connective tissue. All these nephrons are held together by connective tissue, and this surrounding connective tissue gets damaged. It is called as interstitial nephritis. So you have 3 renal level injuries: glomeruli or tubules or the interstitial nephritis. These are the 3 causes. So now what are the glomerulonephritic conditions that can cause acute presentation? Example I can quote is post-streptococcal glomerulonephritis. Even IgA nephropathy may present acutely, right? Acute tubular necrosis is usually because of drugs like acyclovir. They get precipitated in the tubules, block the tubules and cause the injury to the tubules, or anything that can cause pre-renal AKI will eventually cause acute tubular necrosis. For the interstitial nephritis, the most common cause why connective tissue gets affected is the drug allergy. So when you have allergy to certain drugs, it can trigger interstitial nephritis. Okay. Now pre-renal, what are the common causes? The most common cause for pre-renal AKI is hypotension. If your BP drops, then blood flow to kidney comes down, kidneys lose the function, right? This is what we routinely hear. He had acute GE, hospitalized, and after that kidney shut down. Why? Because during acute GE, he was severely dehydrated, BP dropped, renal perfusion decreased, right? That is most common cause. Apart from that, you can have bilateral renal artery stenosis. Hypotension could be because of any cause, blood loss, dehydration, side effect of drugs, right? These are common causes for acute kidney injury. Now the question is, among them, the most common cause overall is pre-renal, and renal is second, and within the renal, it is the ATN, which is the second most common cause, because even pre-renal itself can lead to ATN. So in the exams, your teachers are mostly going to be interested in asking you to differentiate between the pre-renal AKI and renal, particularly acute tubular necrosis. That's a hot spot for MCQs. Now, to understand how do we differentiate, right? Let us understand the basic renal physiology. So if this is a glomerulus that we're looking at, we have Bowman's capsule, proximal convoluted tubule, then loop of Henle, ascending, descending, distal convoluted tubule, collecting ducts. And blood comes into this glomeruli through an afferent arteriole, leaves it through an efferent arteriole. Okay. Now here in the glomeruli, there is formation of a glomerular filtrate. So we filter the blood, right? And this filtrate contains most of the small molecular weight substances and lot of water. So small molecular weight substances include the sodium, potassium, amino acids, glucose, all of that is filtered. And then we start reabsorbing the wanted substances and we don't reabsorb the unwanted. So what are the unwanted? Urea, creatinine, right? Then H plus ions, these are unwanted. We don't reabsorb them. But I want bicarbonate back, I want sodium back, I want like chloride back. So I want most of the amino acids back. So we will reabsorb. So reabsorption starts in the proximal convoluted tubule, continues in the loop of Henle and distal convoluted tubule. So these will be lost while these substances will be reabsorbed. Filtration happens in glomeruli, reabsorption happens in tubules, right? So if you say acute tubular necrosis, the tubules are the ones which are damaged. So what will happen to the reabsorption? I will not be able to reabsorb. So I start losing all these substances in the urine, right? That is one thing. Second thing is, when I have pre-renal AKI, the blood flow to the glomeruli is reduced. And whenever blood flow to glomeruli is reduced, there is a signaling mechanism that whenever blood flow is reduced, there will be activation of RAS to tell that, oh, you need to increase the BP, I need more blood flow. So when RAS gets activated, RAS has aldosterone. So what aldosterone does? It's basically logic, right? You have dehydrated. What do you want the kidneys to do? Reabsorb more sodium and water or excrete more sodium and water? You're already dehydrated. Blood flow to the kidney is less. Of course, you want more reabsorption, not lose. That reabsorption is mediated by RAS. So if the blood flow to kidney comes down in pre-renal AKI, RAS gets activated and reabsorb more sodium and water. Sodium and water gets reabsorbed from the urine if you have pre-renal. So the urine that goes out will have less sodium and less water. But what if I have done the damage to the tubules? Where the reabsorption happens in the tubules, right? If the tubules are damaged, I will not be able to reabsorb. So in case of ATN, I will be losing a lot of sodium and water in urine. So I will have increased sodium and water loss in urine. Okay, you got this point? So can I say that sodium in the urine is a determining factor whether I have renal ATN or pre-renal AKI as a cause? Yes, we can estimate the excretion of sodium. We call it as GINA, fractional excretion of sodium. If it is more, that means I'm excreting more sodium, then I have ATN. If I'm excreting less sodium, then I have pre-renal AKI, right? That is one point. Second thing is, when I have damaged the tubules, the tubules epithelial cells will be shed and they will go and get stuck on a protein cast called as hyaline cast, loaded with these epithelial cells. So when they get loaded with these epithelial cells, we call it as renal tubular epithelial cell cast. And with time, the cells will go into apoptosis. They release lipofuscin, a brown pigment, so it starts looking brown. So you can also call it as muddy brown cast. So these points will help you to differentiate between renal ATN and pre-renal AKI. So in pre-renal AKI, you will have, because you have decreased perfusion of the kidney. So kidneys think that we need to increase the BP, RAS gets activated, we absorb sodium and water a lot. So the amount of urine you excrete is less. You will have concentrated urine. That means the urine specific gravity will be high. Urine osmolality will be high, right? Concentrated urine. On the other hand, the reabsorption happens in the tubules damage, you can't reabsorb. So you will have dilute urine. Urine specific gravity will be less. Second, you will estimate something called as fractional excretion of sodium. So when you have pre-renal AKI, the RAS is activated and you're reabsorbing most of the sodium, you're excreting less sodium. So it is going to be less than 1%. Means less than 1% of the sodium going to kidney gets excreted, right? More than 99% is getting reabsorbed. But in case of the acute tubular necrosis, the reabsorption of sodium happens in tubules, tubules are damaged. So you are losing more than 2% of sodium that is being presented to kidney in urine. You're not able to reabsorb it, right? This is a very, very important MCQ point. The third one, in pre-renal AKI, you get the normal cast, which is hyaline cast. But in renal ATN, you get the renal tubular epithelial cell casts. And if they are standing for a long time, you get muddy brown casts. So these are the points I want you to remember to differentiate between pre-renal AKI and ATN. A hot topic for the MCQs. Dilute urine means low specific gravity, low osmolality, high sodium, and RTEC or muddy brown cast. Concentrated urine means high osmolality, high specific gravity, but low sodium in the urine, hyaline cast. Okay. Next we go to CKD. And when it comes to CKD, they will ask you questions related to what is the most common and second most common cause. They may ask related to the staging of CKD and they may ask questions related to the complications of CKD. Right? So first let us start with the causes. And when it comes to the causes, the most common cause for CKD is diabetic nephropathy. Diabetic nephropathy accounts for more than 2/3 or 66% of cases. Means if I have 100 cases of CKD, 70 or more than that are because of diabetic nephropathy. Diabetes is the leading cause for someone requiring dialysis. The second most common cause is going to be hypertensive nephropathy. So hypertension also causes damage to kidneys. Hypertensive nephropathy is the second most common cause. The other causes for CKD include chronic glomerulonephritis. Chronic glomerulonephritis. Can anybody tell me which glomerular disorders present as chronic glomerulonephritis? Chronic glomerulonephritis. PSGN is usually acute, right? Complete recovery happens. IgA nephropathy also usually recurrent attacks, but less likely to progress to chronic glomerulonephritis. Yes, examples we can quote here is lupus nephritis, which will have frequent acute flares, but it can run chronically. Lupus nephritis, focal segmental glomerulosclerosis, these are. Okay, so these are the causes for CKD. Another chronic is analgesic nephropathy. If chronically use NSAIDs, they can also cause nephropathy. So these are all common causes for CKD. So in the CKD, they will ask you staging. The staging of CKD is based on two parameters. One is GFR and the second one is albuminuria. So every patient of CKD is given two numbers, a GFR number and an albuminuria number. So it may be expressed like G2, A2. That means with respect to GFR, his stage 2. With respect to albuminuria also, his stage 2. Or it may be G2, A3. Or it may be G1, A2, like that. In common terms, whenever you say it is stage 2 CKD, we are mostly referring to the GFR based stage. That is more important. Okay. So what's the G1? Normal GFR, that is 90 or more. If it is 60 to 89, it is G2. And if it is below 60, right, up to 30, it is called as G3, which is further divided into G3A and G3B. 45 to 59 is G3A and 30 to 44 is G3B. And less than 30, that is 15 to 29 is G4. And less than 15, it is G5. Less than 15 is G5. Right. So I want you to remember this number. Again, I know you have to by heart it. Just give me 1 second, guys. Hello. Yeah, tell me. यहाँ तो क्लियर है, फुल वॉल्यूम लगा हुआ है. ठीक है, ओके। नंबर नोट कर लीजिए 141। एक सेकेंड में वॉल्यूम यहाँ पे म्यूट कर लेता हूँ 1 मिनट के लिए। So guys, there were some technical issues related to the volume. Many of you are also commenting. My team is looking at, so give me 1 minute and we will start back again. So just give me 1 minute. The team is looking at the voice issues. Once they're sorted, we will get back. Yeah, tell me. Okay, so guys, if the audio is clear now, just let me know in the comments. Ananya, if you are able to hear me, just let me know. Okay, so if it is clear, I will continue with the discussion. Okay, so we were talking about CKD and staging. So CKD, the most common cause is diabetic nephropathy, hypertension is second most, and all other chronic renal disorders are responsible for the very tiny fraction of cases. Anytime you encounter CKD, we stage them. Staging is based on GFR and albuminuria. GFR parameters, 90 or higher is G1, then 60 to 90 is G2, then 30 to 60 is G3, which is further divided into 15 blocks as G3A and G3B. 15 to 30 is G4 and less than 15 is G5. With respect to albuminuria, if the 24-hour urine albumin, the albuminuria is categorized based on either 24-hour urine albumin, or if you can't measure 24-hour urine albumin, you can calculate something called as urine albumin creat ratio, UACR. One of them can be used. For both of them, the number is same. If UACR is less than 30 milligrams per gram or 24-hour urine albumin is less than 30 milligrams per day, then it is A1. If it is 30 to 300, it is A2, and if it is more than 300, it is A3. So just for the sake of understanding how the staging is done, let me give you an example. Example of a person whose GFR, estimated GFR is, let us say, 50, and his urine albumin creat ratio is 150 milligrams per gram of creatinine. So which stage this patient belongs to? So when you look at GFR, it is not stage 1, it is not stage 2, it is stage 3 because it is less than 60, and more precisely it is G3A, right? It falls in that. So it is, so this patient stage is G3A with respect to GFR, and common terminology is stage 3 CKD means this. Okay. And then with respect to albuminuria, 150 falls in this A2, right? So it is G3A, A2. This is how we will be staging this patient's CKD. Okay. Now we know the causes and staging. Let us look at the complications. What complications kidneys can do if they fail? Well, number one, kidneys are supposed to excrete urine. All the excess volume load is excreted through kidneys, and if kidneys are dysfunctional, we will not be able to excrete. So what it will lead to? Fluid overload, including pulmonary edema and pulmonary edema. Okay. The second thing it can lead to, kidneys are supposed to excrete potassium, and if there is potassium load but kidneys are dysfunctional, we will not be able to excrete. We will develop hyperkalemia. So with respect to fluid overload and pulmonary edema, right, what is going to be the initial treatment? Of course, you will restrict the fluids and you can consider diuretics. As long as the remaining nephrons are working, we want to flush them out. But if it is hyperkalemia, what is going to be the initial treatment? We can treat them with dextrose plus insulin. We can give calcium gluconate, right? Then potassium binders or potassium binding resins. And we can also give salbutamol nebulization, right? Repeatedly asked question, what is the mechanism of action of dextrose and insulin? Insulin shifts the potassium from extracellular to intracellular compartment. Salbutamol does the same. Calcium gluconate stabilizes the cardiac membrane and reduces the risk of developing hyperkalemia-induced arrhythmias. Calcium binders bind the calcium and help us eliminate in stool. Bind the potassium binders, bind the potassium and help us eliminate potassium in the stool. Okay. Another complication we can expect in patients with CKD is anemia of CKD. Anemia of CKD. Why are we developing anemia in CKD? There are two mechanisms. The main mechanism is, this is what MCQ they ask. Kidneys are the ones which are producing erythropoietin, but if kidneys are dysfunctional, there is decreased erythropoietin production. Apart from that, the other mechanisms, there can be iron deficiency because you have CKD, and CKD also is associated with increased urea, and increased urea means it will also lead to some GIT bleed sometimes, so you may be losing blood, so that will be contributing to the iron deficiency. CKD is associated with severe nausea, vomiting, so they may not be able to take sufficient food, so that might contribute to iron deficiency. And then CKD is an inflammatory disorder. There is increased production of interleukin 1, and interleukin 1 is associated with bone marrow suppression. Bone marrow suppression. So these are all the causes for anemia in CKD. Most important MCQ is, what is the main cause? The main cause is erythropoietin deficiency. So if you have to treat, how do I treat? So treatment is by erythropoietin or darbepoietin injections. So you can inject erythropoietin, or you can give a derivative called darbepoietin, which is relatively more long acting. But also make sure that before you give erythropoietin, whatever iron deficiency patient has got, fulfill it. Because if he continues to be in iron deficiency, how much ever stimulant you give, there's no iron to make hemoglobin, so they will not be able to recover from the anemia. Okay. Second, fourth, there is impairment of phosphate excretion. So phosphate level starts increasing. So we'll have hyperphosphatemia. And this hyperphosphatemia will lead to increase in the parathyroid hormone. Parathyroid hormone, right? We will call it as secondary parathyroidism. And this parathyroid hormone will start, that will increase the osteoclastic activity. That will stimulate osteoclastic activity. And because of the increased osteoclastic activity, you will have increased bone turnover. Increased bone turnover, and it produces what is called as CKD related mineral bone disease or brown tumors. So if I have to treat this problem, how do I treat? I can treat it with Sevelamer. What is sevelamer? It is a phosphate binder. So you can give phosphate binder so that whatever phosphate that comes from the diet, this phosphate binder binds to it and takes it away in stool and you don't get it absorbed. Okay, then fifth, vitamin D inactive to active conversion by 1-alpha hydroxylase is done by the kidneys. So there is renal failure, there is decreased 1-alpha hydroxylase activity, and that results in decreased active form of vitamin D. And this decreased active form of vitamin D results in decreased calcium absorption in the gut. So this will lead to hypocalcemia. This hypocalcemia will also contribute to increased parathyroid hormone activity. So that again will make your bones become weak. So how do I treat this complication? By giving vitamin D plus calcium supplementation, right? So these are the common complications and the basic ways to handle them. But if you ask me what is the definitive treatment of CKD, the definitive treatment is of course renal transplantation. It's going to be renal transplantation. What other modes? Another mode of managing is renal replacement therapy or RRT, which is basically dialysis. And dialysis is of two types: the peritoneal dialysis and hemodialysis. In hemodialysis, we remove the blood from the patient's body and make it run through a machine. The machine will have a membrane which does the filtration process. In peritoneal dialysis, the membrane is within the body, that is your peritoneum. We are using the peritoneum as a membrane. We add the fluid into the peritoneum, and that fluid will get all the urea, creatinine filtered into it, and then we discard the fluid. Hemodialysis and peritoneal dialysis. So in terms of questions, they will ask you what are the absolute indications for dialysis. Absolute indications for dialysis. The absolute indications for dialysis include, see, all these are too much of fluid overload, hyperkalemia, anemia, hyperphosphatemia. These are all relative indications for dialysis. Why? Because I have initial treatment available. If fluid overload, I can put fluid restriction and diuretics. If hyperkalemia, I can give dextrose insulin. Right? If it is anemia, I can give erythropoietin. If there is hyperphosphatemia, I can give phosphate binders. So I have ways to manage them. But urea elevation and its related complications, there is no way to bring down the urea. So if urea is high, it will cause the symptoms until and unless the urea is removed from the body. And right now for urea removal, only treatment available is dialysis. So uremic symptoms are considered as the absolute indications for dialysis. Remaining everything else is relative. If diuretics fail to reduce the volume overload, then you go for dialysis. If dextrose insulin is not able to lower the potassium, then you go for dialysis. But uremic symptoms, that is including severe nausea and vomiting, that is intractable, difficult to control nausea and vomiting, or uremic encephalopathy, or development of uremic pericarditis, then it's an absolute indication for dialysis. You have to go ahead and do dialysis. There's no other way you can help the patient, right? So MCQ wise, they can ask you common complications, their initial management, and absolute indications for dialysis. I got you covered. So from the kidney, from the medicine, it's mostly about the definition or diagnostic criteria for AKI, staging of AKI, AKI pre-renal versus ATM. Then from the CKD, staging of CKD, then complications of CKD and their initial management of complications and indications for dialysis, right? Other than that, what else is asked from nephrology? Mostly glomerular disorders, PSGN, IgA nephropathy, FSGS, rapidly progressing glomerulonephritis, membranous glomerulonephritis. So I leave it to pathology for the coverage because most questions are going to be from path. Now let us go to the rheumatology. From rheumat, so plethora of diseases are there. 50% questions come from the SLE and 30% from rheumatoid arthritis. Rheumatoid arthritis will be addressed in orthopedics, right? So we'll concentrate a little more on SLE. And the other important topic from rheumatology is going to be scleroderma, right? So we'll concentrate on that. So we'll start with SLE. MCQs from rheumatology are kind of predictable. Either you have to recognize the disease from the symptoms, which is pretty simple. If it is SLE, it's always about a malar rash. If it is scleroderma, it's always about microstomia and the injuries to the finger or finger resorption. If it is rheumatoid arthritis, it's always about those deformities. The questions are easy to recognize from the story. Apart from that, if it is a rheumatological disorder, there is always some cytokine causing the damage to the tissue. So you need to know which cytokine. And then antibody and their correlation, or some points about diagnosis. And when it comes to management, what is the initial drug of choice? These are the points you need to remember. So when it comes to SLE, the main cytokine responsible for all the manifestations of SLE. SLE is a multi-organ autoimmune disorder. It's not only about the skin, right? The principal cytokine is interferon 1. Interferon 1. So IFN1, particularly IFN1 gamma, is the cytokine responsible for the injuries. So when these cytokines elevate because of autoimmune process, what organs get affected? The most common organ manifestations. So you can have, in terms of organ manifestations, you can have constitutional symptoms. Means not specifically pointing towards any organ system. Such symptoms are called as constitutional symptoms. Then you can have the involvement of skin, you can have involvement of musculoskeletal system, you can have the involvement of CVS, you can have the involvement of CNS, you can have the involvement of RS. So when it comes to constitutional symptoms, the most common constitutional symptom is fever. When it comes to skin, the most common manifestation, as you know, is malar rash, the classical butterfly rash with a nasolabial fold pairing, which is photosensitive. When it comes to musculoskeletal system, polyarthritis is the most common manifestation, right? Little extra because we have to compare and differentiate it from rheumatoid arthritis. So in rheumatoid arthritis, also polyarthritis. Rheumatoid arthritis affects small joints more than large joint. SLE also same. It affects small joints more than large joints. SLE arthritis also affects the upper limb joints more than lower limb joints. Rheumatoid arthritis also affects upper limb joints more than lower limb joints. This is also an inflammatory arthritis, not degenerative arthritis. So it is also associated with early morning stiffness. Stiffness of more than 30 minutes. Then comes the question, then how am I going to differentiate it from rheumatoid arthritis? The key differentiating feature here is there is no damage to the synovial membrane, so it is non-deforming. You'll have the swelling, redness, pain, everything, but it doesn't lead to deformities. Rheumatoid arthritis is deforming polyarthritis. Here it is non-deforming polyarthritis. So what is the CVS manifestation we get? It causes, again, pancarditis. It affects all the three layers of the heart. And when it is affecting all the three layers of the heart, here comes the question, what is the most common manifestation? The most common CVS manifestation is pericarditis. Right. Apart from that, it can also cause myocarditis and endocarditis. Endocarditis without infection, here it is called as Libman-Sachs. When SLE causes endocarditis, what do we call it as? It is called as Libman-Sachs endocarditis. Libman-Sachs endocarditis. When it comes to CNS involvement, the most common manifestation is cognitive dysfunction. That means some mild degree of dementia is encountered in patients with SLE as the time progresses. And when it comes to the respiratory system involvement, the most common respiratory system manifestation, basically it all affects, it causes the inflammation of the layers, pericarditis, pleuritis. So pleuritis is the most common SLE manifestation. Okay. Apart from pleuritis, what else SLE can cause? It can cause something called as shrinking lung syndrome. So the lungs start shrinking. It's called shrinking lung syndrome. From all these manifestations, what MCQs they're going to ask? Well, malar rash is repeatedly asked, but you know it, so I don't have to elaborate on it. So main thing is they will ask what is most common cardiovascular manifestation. It is pericarditis. Most common respiratory manifestation, it is pleuritis. And the endocarditis here is called as Libman sac. It's a sterile endocarditis. Without infection, you have inflammation of the endocardium. And another MCQ asked, especially in NEET PG, is where do you get shrinking lung syndrome? We get that in patients with SL. Okay. Now, when it comes to the diagnosis, see, please remember there's something called as classification criteria. I'm not expecting them to ask classification criteria in an undergraduate exam, especially in the FMG. So in terms of diagnosis, mainly they will ask you what are the investigations that we do. The classification criteria that is followed is ACR, Euler criteria, American College of Rheumatology, European League Against Rheumatological Disorders criteria. So according to that, you need more than or equal to 10 points, out of which, again, you don't have to remember this. I'm not expecting them to ask a question. At least one from clinical domain. So in this criteria, we have a lab parameter, that is your ANA, anti-dsDNA, all those lab parameters, CRP and all. And then on the other side, you have clinical symptoms like fever, then arthritis, pericarditis, all this clinical. So you need at least one clinical point. Even if you have 10 lab points but no clinical, you can't classify it as SL. So you need at least one clinical point. Along with that, if remaining points come from lab, it's fine. So what MCQs they may ask you, mostly they will ask you, what is the newly introduced constitutional symptom? The newly introduced constitutional symptom is fever. So earlier SLICC criteria that may be there in some of your notes, still fever was not part of the classification criteria. Now it is newly introduced in the ACR Euler criteria. That's the only MCQ I can get from the classification criteria. Beyond that, nothing much is expected. Otherwise, every SLE story, you know, there will be a malar rash. Another important thing. So in this, there is something called as entry criteria. Means if this test is negative, you don't consider SLE at all according to the classification criteria, and that is ANA positivity. ANA should be positive with a titer of more than or equal to 1:80. This is the entry criteria. These 2 points I want you to remember. Okay. If you have diagnosed the case as SLE, how do you manage it? So that the drug of choice for management of SLE is hydroxychloroquine. So for all patients of SLE, you give hydroxychloroquine. If not well controlled, you add steroids and immunosuppressants. And if they ask you what are the newer drugs, so I want you to remember 2 new drugs for the SLE. One is belimumab. The other one is anifrolumab. So as you know from the name, these are monoclonal antibodies. So belimumab is a anti-B-list. What this B-list stands for? B lymphocyte stimulant. So for the B lymphocytes to grow, there is a substance produced in the body called as B lymphocyte stimulant, and it blocks that, so that B lymphocytes don't grow. If B lymphocytes don't grow and they don't have the activity, then they are not able to produce antibodies, so you don't have the organ damage. And the B lymphocytes are producing antibodies, and these antibodies are stimulating the cells to produce interferon 1, which is the main cytokine responsible for the organ damage. So what if I block the interferon 1 itself? Yes, we can block the interferon 1 with anifrolumab. So anifrolumab is anti-interferon 1 monoclonal antibody. These are 2 new drugs for SLE. Drug of choice is hydroxychloroquine. Remember, hydroxychloroquine can cause retinopathy. So retinal screening before initiation and also subsequently regular screening is recommended. If there is retinopathy of whatever cause, hydroxychloroquine is contraindicated. Okay. The other level of questions that are going to come from the SLE is antibodies and their correlations. Repeatedly asked. The first one is, what is the most sensitive antibody? Then they will ask you what is the most specific. Then they will ask you what is the second most sensitive, and what is second most? Specific. Then which antibody correlates with? Antibody correlating with Zika syndrome, antibody correlating with lupus nephritis or kidney involvement, and antibody correlating with drug-induced lupus. Drug-induced lupus. So the most sensitive antibody is of course ANA, and the most specific antibody is anti-Smith. But the second most sensitive is anti-dsDNA, and second most specific is also anti-dsDNA. And being second most sensitive and second most specific, it is the most useful antibody in diagnosis and management of SL. Why it is also useful in management? This also correlates with disease severity. Now, what do I mean by that? More severe the disease, you will have more anti-dsDNA titer. Less severe the disease, less. So if the disease severity increases, disease activity increases, anti-dsDNA levels also increase. So it also correlates with disease activity. So if anti-dsDNA levels are very low, that means disease activity is less. So the antibody that correlates with the Zika syndrome is, just give me 1 second, the screen is behaving odd. So the one that correlates with the Zika syndrome is anti-SSA or anti-Rho antibodies and anti-SSB or anti-La antibodies. The one that correlates with the lupus nephritis risk is again anti-dsDNA. So anti-dsDNA is a very, very important antibody. The one that correlates with the drug-induced is anti-histone antibodies. Anti-histone antibodies. One more we missed. The one that correlates with the neonatal lupus. What is neonatal lupus? If mother is having SLE and she has this antibody, the chances that these antibodies will be transferred transplacentally to the newborn, and the newborn might start showing SLE manifestations. We will call it as neonatal lupus, which is transient and it settles down because newborn is not producing antibodies against itself. The antibodies are borrowed from the mother. The one that correlates with this anti-SSA or anti-Rho antibodies, also called as anti-Rho antibodies. So if mother is SLE and she has anti-SSA antibodies, high chances that the neonate will be having SLE manifestations. Okay, that's about the SLE. Rheumatoid arthritis, I'm leaving it to orthopedics. So let me address scleroderma. Okay, what is scleroderma? Scleroderma is also an autoimmune rheumatological disorder which is characterized by the thickening of or fibrosis of the skin and organs and vasculitis. So it is a vasculitic disorder with fibrosis of skin and internal organs. Skin and internal organs. So what is the principal cytokine which is responsible for all this vasculitis and internal organ fibrosis? It is transforming growth factor beta, TGF beta, IgR. In rheumatoid arthritis, it is the TNF alpha. In case of the SLE, it is interferon 1. In case of scleroderma, it is transforming growth factor beta. That's why if you go back to orthopedics and think about drugs used for treatment of rheumatoid arthritis, apart from methotrexate as the initial drug of choice, when these methotrexate and other simple drugs fail, you come to monoclonal antibodies. Mostly today we focus on TNF alpha blocking agents because that is the main cytokine causing all the organ damage. So here it is TGF beta. Unfortunately, we don't have great drugs that block the TGF beta. So that's why we don't have great treatment available for the scleroderma as of now. Now, scleroderma is classified into limited cutaneous and diffuse cutaneous. So what is the basis for this classification? There are two subtypes and they behave totally as different entities. Totally as different entities, and this is where majority of the questions are going to come. So limited cutaneous refers to involvement of the skin. There is thickening of the skin. Let us mention the clinical features so that. So you will have skin thickening, then Raynaud's phenomenon, because there is vasculitis, blood vessels tend to constrict when exposed to cold, resulting in feeling of numbness and pain. Whenever the extreme body parts, hands and feet, are exposed to cold, there is more than normal vasoconstriction, resulting in the sensation of pallor, tingling sensation, or loss of sensations. We call it as Raynaud's phenomenon. Okay. Apart from that, there can be microstomia. What do you mean by microstomia? Because just like how the skin is getting fibrous, even of the hands, resulting in finger deformities, you also have the fibrosis of the facial skin, right, resulting in inadequate mouth opening. We call it as microstomia. You can have a beaked nose, that is also because of the thickening of the skin, or parrot beaking of the nose. Then the fibrosis can also affect the lungs. So in the lungs, it can cause ILD. It can also cause pulmonary arterial hypertension because there is vasculitis. There can also be gastric antral vascular ectasia, which may lead to bleed as well. So GI bleed is also a possibility. Then there can be esophageal dysmotility. So these are all the manifestations we are expecting. It's not restricted to skin. But every case of scleroderma is classified into either limited cutaneous or diffuse cutaneous. When we talk about limited cutaneous, it refers to the skin thickening changes restricted to the elbow joints and distal, not proximal to that, or the knee joints and distal. So if this is the patient that I'm looking at, and if the skin thickening changes are restricted to hands and forearm, like it's not extending proximal to elbow joint, face can be involved in undoubtedly, and the lower limb involvement is restricted to the knee joints and distal and not extending proximal to them, then it is called as limited cutaneous. But if it extends proximal to that, then we will call it as diffuse cutaneous. The skin thickening extending proximal to the knee joint and elbow joint. So skin is thickened beyond the elbow joint, beyond or proximal to the knee joint, then we will call it as diffuse cutaneous. Okay. Now the limited cutaneous variant is also known as crest syndrome, because there is calcinosis of the skin, Raynaud's phenomenon, esophageal dysmotility, and all. Telangiectasia, I forgot to mention. You can have telangiectasia of the skin as well. Now, these diffuse cutaneous patients are more prone to develop interstitial lung disease and a complication called as scleroderma renal crisis. And these patients of limited cutaneous, they are more prone for pulmonary hypertension and fingertip ulcers. These patients have mostly anti-centromere. Limited cutaneous have anti-centromere antibodies, and diffuse cutaneous have anti-DNA topoisomerase antibodies. Okay, so both the SLEs are not same. These patients are most likely to develop pulmonary hypertension. These patients are likely to develop ILD. These patients are likely to develop the renal crisis. These patients are likely to develop the ulcers of the finger tip, apart from esophageal dysmotility and other components of the crest syndrome. So how do I recognize whether my patient is limited cutaneous or diffuse cutaneous? You can see the extent of skin involvement, or you can see the antibody. The classical antibody of the limited cutaneous is anti-centromere, and the classical antibody of the diffuse cutaneous is anti-DNA topoisomerase. Now in the examination hall, I'm very sure you will get confused which one is characteristic of limited cutaneous, which one is of diffuse, right? So let me make it simple. So whenever you think of limited cutaneous, right, think of vasculitis. And whenever you think of diffuse cutaneous, think of organ fibrosis. That's a basic rule. So now tell me, which patient is more prone to develop pulmonary hypertension, whichever is associated with the vasculitis, and which one is that limited cutaneous? Which patient is more likely to develop the ILD, the one that is associated with fibrosis, which is diffuse cutaneous. Now how about antibodies, sir? How will I remember? So if I see a cell, no, in a cell you have a nucleus. Inside the nucleus you have DNA, right? And that DNA inside the nucleus is organized in the form of chromosomes, and we know that the chromosomes have something called as centromere, right? So if I want to find the centromere in a cell, where do I find? Inside the nucleus. That too where? In a chromosome. And is the DNA always arranged like chromosome? No, it gets arranged as chromosome for the cell division. When the cell is not dividing, the chromatin is freely distributed. So I rarely get to see centromere. So centromere has a limited presence inside the cell. It is only there in the nucleus and only seen in some phase of cell cycle, not always. On the other hand, if I have to find DNA, where do I find? Yes. Do I find it in nucleus? Yes. Can I find DNA outside the nucleus? Yes. Outside the nucleus you have mitochondria, and in the mitochondria also you have DNA. So can I say that DNA has diffuse presence in the cell, but centromere has limited presence? Yes. So anti-centromere antibodies are seen in limited cutaneous, and DNA has diffuse presence. So anti-DNA topoisomerase antibodies are seen in diffuse cutaneous, right? So that way you can remember. Centromere has limited presence, so limited cutaneous. DNA is there not only in the nucleus but also outside, so it is diffuse cutaneous. So that completes our scleroderma as well. Okay. Now we will take two quick topics from the pulmonology, and then we will wind up our quick review of the medicine. So from pulmo, mostly questions are going to be related to asthma or COPD. So let me start with the asthma first. Okay. Now, what kind of question they are going to ask? Mostly they will give you a PFT and ask you to interpret to know whether this patient is having asthma or not. Otherwise, it is related to management. Okay. So for the diagnosis of asthma, we know investigation of choice is PFT. And asthma is a obstructive airway disorder. Airway disorder with reversible obstruction. Reversible obstruction. So in the PFT, first I have to prove that it is obstructive airway disorder. And what is the parameter we are looking at? We are looking at FEV1 by FVC. Normal FEV1 by FVC is 0.7 or 70% or higher. Less than that, that is 0.7 or 70%, then it is called as obstructive airway disorder. In asthma, you get the obstructive picture. If it is obstructive airway disorder, we have n number of causes. So COPD is there, bronchiectasis is there, small airway disease is there. So how will I get to know that this is asthma only? I have to prove that it is reversible. So you know the asthma story. Whenever I get exposed to dust or some allergen or a trigger, the bronchi constrict, I have wheezing and shortness of breath. After some time, or if I take a medication, you know that the wheezing settles because the obstruction got relieved. How did it get relieved? On giving a bronchodilator. So we will do a test called as bronchodilator reversibility test. It's called as bronchodilator reversibility test. Or BDR. So what we do is, we already know patient's baseline FEV1 and we will administer a SABA, which is a bronchodilator, and we will repeat the FEV1, and this repeat FEV1 is called as post bronchodilator FEV1. The FEV1 done after giving a bronchodilator. This is post bronchodilator FEV1, and we will see how much it increased. If it is asthma, the bronchodilator should cause significant bronchodilation and the FEV1 should have a significant improvement. So if it increases by more than or equal to 12% or by more than or equal to 200 ml, any one of them, that means you have reversible obstruction, and that is equal to asthma. But if you have less than 12% increase after giving a bronchodilator, then it is persistent obstruction. And persistent obstruction can be seen. Just give me 1 second, guys. The file is behaving a little odd. Persistent obstruction is seen in COPD and bronchiectasis. Now, based on the history or other parameters, you can decide whether it is COPD or whether it is bronchiectasis. For example, if it is a patient of tuberculosis and then he presented with this PFT picture, it is bronchiectasis, post-TB bronchiectasis. If it is a heavy smoker who presented, then you know it is COPD. That is the diagnosis. Once you have diagnosed, how are we going to manage a case of asthma? So for that, we are following the GINA guidelines. I'm giving you a very simplified version of GINA guidelines for a quick recap. So what GINA guidelines say is, any patient of asthma, we might have to give them inhaler. That's our first line treatment. But the choice of inhaler. Okay, so the preferred treatment today is a combination of inhaled corticosteroid plus formoterol. Why? Inhaled corticosteroids will suppress the inflammatory part of the asthma and formoterol will cause bronchodilation. Why is it preferred? It's a beta agonist because formoterol is special. Its onset of action is rapid. So it is a rapid onset beta agonist. So anytime asthma attack is there, you can use it for relieving the attack. But at the same time, it is also long acting beta agonist. So it can be used for prevention as well. So it's a perfect drug. Means can be relieving the asthma, can also be preventing it. That's why this is preferred agent. Now the question is, okay, I have the preferred drug ready, ICS plus formoterol. Should I ask the patient to take it only when an asthma attack happens or every day so that he prevents the asthma attack? That is what we need to decide. So for that, I have to look at the patient history. So if patient has more than 4 attacks of asthma per week or more than or equal to 1 nocturnal attack of asthma per week. So we are taking the weekly history of asthma. In 1 week, how many attacks the patient is experiencing. So if he is experiencing 4 or more than 4 or at least 1 nighttime attack, that patient needs daily inhaler. And this daily inhaler is called as MART. MART refers to maintenance and reliever therapy. Means we are giving an inhaler which he uses for maintenance, and whenever there is an attack, he will take the same for relieving. But if the frequency is less, means if I say no, he does not have that frequent asthma attacks. If yes, he needs. If you say like no, he is getting 1 or 2 attacks of asthma per week, definitely not in the night, then he does not need a daily inhaler. So then there is no need for maintenance and reliever therapy. Treat only with SOS or as and when required combination of ICS, which of course will be low dose ICS plus formoterol. But those who require the inhaler, who are having 4 attacks of asthma per week or 1 nighttime attack per week, such patients, now I have to decide whether the inhaler I am giving should be low dose or high dose. So for that, we will look at the post bronchodilator FEV1, post BDR FEV1. If the post bronchodilator FEV1 that we had already got it done, if that is more than 30% of predicted value. For now, don't bother about what is this predicted and all. Just remember the numbers. That's more than enough. If it is more than 30% of the predicted value, then it is still good. I don't have to start with the relatively high dose. So I will start with the low dose combination of ICS plus formoterol. So you can also call it as low dose MART. I'm using the same drug for maintenance as well as relief. But if it is less than 30%, that means this patient requires relatively higher dose. So we'll start with medium dose combination of ICS plus formoterol, or you can also call it as medium dose MART. If still not controlled, then you can have a step ladder escalation. So if they ask you initial treatment based on the history, I want you to follow the algorithm. If they ask you what is the preferred treatment, it is ICS plus formoterol, right? So that completes a quick take on asthma. Now let me spend 5 or 6 minutes more on the COPD. So from the COPD, what are the important questions they will ask? They will ask you mainly to recognize COPD from the PFT. Second, they will ask you to differentiate between the chronic bronchitis and emphysema. They may ask you few management related questions. So what is COPD? COPD is a obstructive airway disorder, just like asthma. Airway disorder characterized by persistent obstruction. So here the obstruction cannot be reversed completely by giving a bronchodilator. You might get partial reversal but not complete. In asthma, complete reversal was possible. So what is the most common cause for COPD? The most common cause for COPD is, of course, tobacco smoking in whatever form, cigarette, BD, chillum, whatever. But the most common cause for COPD in non-smoking females is going to be burning of biomass fuel. That is chula, biomass fuel. And genetics also is an important cause. When it comes to genetics, it's mostly alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. Okay. Now, when someone develops COPD, they can develop two subtypes, right? So one of them is called as chronic bronchitis. The other one is called as emphysema. Chronic bronchitis. The other one is called as emphysema. So what is this chronic bronchitis? Well, the definition of chronic bronchitis is pretty clinical. The patients of chronic bronchitis are also called as blue bloaters. Why are they called as blue bloaters? Because of this chronic bronchitis, the airway is narrowed and the amount of oxygen entering the alveoli is reduced. So because of that, they develop hypoxia. And hypoxia leads to cyanosis. Cyanosis is why they are called as blue. And because the amount of oxygen entering the alveoli is reduced, the blood vessels or the capillaries of the pulmonary capillaries around these alveoli get constricted because no oxygen coming. So why should I be dilated? They get constricted. And because of that, behind that, the pulmonary artery pressure starts increasing. And because of the pulmonary artery pressure, right heart pressure increases, right heart fails, and you develop what is called as cor pulmonale. So chronic bronchitis patients are prone to develop cor pulmonale. Cor pulmonale leads to edema. Edema is why they are called as bloaters. They are bloated with fluid. Okay, so chronic bronchitis, the definition is clinical. MCQs are asked on this. So more than or equal to 3 months of productive cough, means cough with sputum per year. Productive cough per year for 2 consecutive years. What do you mean by consecutive? Sequential years. Means this year, next year, or this year, previous year. The chronic bronchitis patients are prone for cor pulmonale or right heart failure. And also I want you to remember that right heart failure is the second most common cause of death in COPD patients. Remember, the most common cause, because these are smokers, they die before the COPD kills them because of the ischemic heart disease. They may die because of MI. MI is the most common cause of death in patients with COPD. Second most common cause is right heart failure. Now, what is emphysema? Emphysema is defined as irreversible dilatation of acini, irreversible dilatation of acini. So acini are the distal part of the airway, that is alveoli, alveolar ducts and respiratory bronchioles. So they are irreversibly dilated. And because they are irreversibly dilated, their pressure is low. So air from atmosphere goes into these dilated areas easily. But because they are irreversibly dilated, they cannot recoil back. So they are not able to push the air out. So they keep air trapping. And because of that, the lungs start expanding. And because the lungs start expanding, their lungs appear puffed. So that's why these are called as pink puffers. Pink puffers. And this expanding lung leads to change in the shape of the thorax. So thorax becomes barrel shaped. Now the patient starts struggling to exhale the air. Air goes in easily because the alveoli are dilated. Dilation means volume increase, pressure decrease. So air comes in easily, but difficult to throw the air out. So they struggle to exhale and they make some physical changes to exhale. One such physical change is pursing of the lip. So emphysema patients often have pursed lip breathing. Second is they take a tripod position that compresses the diaphragm and pushes the air out. So tripod position. And because repeatedly they are resting their elbows to achieve the tripod position on their thighs, they develop hyperpigmentation of the thighs, and we call it as Dahl sign. Hyperpigmentation of thighs, and that is called as Dahl sign. So these are the manifestations that we get in emphysema. Okay, is that clear? Now, two extra points I want you to remember here. In case of emphysema, emphysema could be because of COPD due to smoking, or emphysema could be COPD due to alpha-1 antitrypsin deficiency. So when emphysema happens in alpha-1 antitrypsin deficiency, when it is due to smoking, it predominantly affects the upper lobes and it causes centriacinar emphysema. And if it is due to alpha-1 antitrypsin deficiency, it affects the lower lobes and it causes pan-acinar emphysema. Okay, that's an extra point repeatedly asked, so I want you to remember. Okay, now coming to the diagnosis of COPD. The diagnosis of COPD. Remember, it is PFT again. PFT shows FEV1 by FVC less than 0.7, which we know is suggestive of obstruction, not COPD, just suggestive of obstruction. To call it a COPD, I have to prove that there is irreversible obstruction. So when we do bronchodilator reversibility test, if asthma, it will show more than 12% increase. Here we will show less than 12% increase in FEV1. It could be as low as 0% increase in the FEV1, right? That is how we make a diagnosis, which is equal to persistent obstruction. And if you have persistent obstruction, you can count it as COPD. Okay. Now, with respect to the management, I've done a small document on the very recently updated gold guidelines. So if you want, just ping me on the Instagram. Tomorrow I will be able to push that to you. Apart from the gold guidelines, so I'm not discussing the gold guidelines because it will consume more than 1 hour time. But if you glance the 1-page PDF, you will be able to deal with the questions. What I want you to remember, apart from that gold guidelines, there is a recommendation for vaccination. So they might ask what are the vaccines recommended, and then they may ask what are the drugs for refractory cases, and they may also ask the treatment known to decrease mortality in COPD patients. So the recommended vaccines are, because infections are known to cause recurrent exacerbations, the vaccines recommended include, the infections are often caused by pneumococci, so pneumococcal vaccine is recommended. And then the H1N1 or the influenza vaccine is recommended. And the DTP, diphtheria, tetanus, pertussis vaccine is recommended for all patients with COPD. The drugs for refractory cases include those who are not responding to the inhalers, that include azithromycin, and roflumilast. So they may ask you what is the mechanism of this roflumilast. Roflumilast is a phosphodiesterase 4 inhibitor. Sildenafil is phosphodiesterase 5 inhibitor. But all of these drugs only make their life better. They do not reduce the mortality. So what drugs reduce the mortality? No drug per se, but some treatments. One of them is long-term oxygen therapy. And second one is, of course, smoking cessation. So if I quit smoking, at least the coronary artery disease progression, COPD progression will come down. So my chance of death comes down. But long-term oxygen therapy does decrease the mortality. So they may ask indications for the long-term oxygen therapy. So what are the indications? Two indications I want you to remember. SpO2 less than 88% or SpO2 less than 89% with raised erythropoietin or right heart failure. Okay, so these are the points I want you to remember for COPD, right? Apart from that, if you guys get some time to go through other important topics, then from the rheumatology, I want you to quickly glance mainly from your path notes on the mixed connective tissue disorder. Mainly remember U1 RNP antibodies. Then from the respiratory medicine, it is about ILD. ILD mainly the diagnosis of the IPF, idiopathic pulmonary fibrosis. From the cardiology, the arrhythmias and AV blocks. And from the neurology, multiple sclerosis. These are additional. It might take 1 or 2 hours of your preparation time. Go through your detailed notes on these topics. And with that, you've kind of covered 40 to 50% of questions that will come from medicine. And if you have a good foundational understanding, you will definitely cross that to 60 or 65%. Good enough for an average student. If you're aiming for much higher number, then I would recommend that at least spare 1 day of the remaining time scanning the topics that you have covered from whatever source you have studied. So that's it from me today. I'll see you on the other end of the exam, hoping to hear good news from all of you. All the best, guys. Study well. See you soon. Bye.
that also. So let's discuss one by one the questions coming from these three topics. First, nutrition, disaster management, and demographic cycle and dividend. Then we will go to environment, vaccination, biostats, and epidemiology part. And if time persists, we will discuss many questions also coming from this topic. So first is the question which they have asked, if there is a female of, this is a very controversial question actually, that there is a female of, let's say 65 kg, how much protein per day she need? And student usually think that protein per day is 1 gram per kg. So 65 kgs, they answer 65 gram. But all the protein requirement which should be there is answered based on reference female and reference male. And the weight of a reference female is 55 kg, weight of a reference male is 65 kg. You might have seen Akshay Kumar ad, वैसे कूदते हुए आता है, ये बोलता है whatever is your weight, you should take 1 gram protein per day. That's wrong. Guidelines say we don't have to give 1 gram protein per day, we have to give 0.83 gram protein per day. And this 0.83 gram per day per kg is for all the population. But when we are advising someone, we cannot advise that whatever is your weight, eat 0.83 gram per kg per day. Because let's say suppose my weight is 200 kg and you advise me to take 200 into 0.83, roughly 180 gram protein per day. Then now some part are hanging, then more part will be hanging. You cannot advise a 100 kg male to eat 100 gram protein per day. So all the advice is given based on reference female and male. And because reference female weight is 55, so if you multiply 55 with 0.83, it comes roughly 46 gram. 46 or 45 gram you can say. So for all the female, no matter whether the weight is 65 kg or the weight is 75 or 85, it doesn't matter. For all the female, the protein requirement is 45 gram, no matter what is the weight. Similarly, for all the males, the protein requirement is roughly 55 gram, no matter what is the weight. Because advice is given based on reference female and reference male, and their weight is very important, remember 55 and 65. And height also you can remember, female is 162, male is 177. So the difference in weight is 10 kg, difference in height is 15. Okay. When it comes to BMI, Indian normal BMI is only from 18.5 to 22.9. If you are 23 to 24.9, you are pre-obese. And if you are more than 25 BMI, you are obese according to the WHO classification for Asian population. So here for reference female, the BMI will be a bit higher, 20.95, and here a bit lower, 20.75, because female have lesser height, so BMI will be a bit higher. Age previously was 19 to 29, but just to include me, they extended the age till 39 years. Main thing from this reference male female is, remember, female of any weight need 45 gram protein, male of any weight need 55 gram protein. First information. Second information, weight is 55 and 65 kg of reference female and male. Never forget these two information. Now, what is the average extra energy needed per day? If I am a pregnant lady, as you can see, the extra energy is 350 kilocalorie. And during lactation, the extra kilocalorie is 600 kilocalorie. Very important, remember. Then the question came on RDA and EAR. I was taking that guest paper series or expected question series, which I will also take for FMGE exam tomorrow. What is the, where I will try to guess the expected question for your upcoming FMGE exam. So I was taking it for NEET, and in the front page with my name, I write this question, that EAR, which is estimated average requirement, fulfill need of 50% population, and RDA, which is recommended dietary allowance, fulfill need of 97.5% population. So RDA is looking over 97.5% population, and EAR is looking over 50% population. This question I write with my name on the slide because this came in previous FMG exam. And whatever new question come in FMG exam, they copy in NEET. And whatever new question come in NEET exam, they copy in FMG. So that's why I again and again request all my students to do 5 years of NEET PG and revise it year-wise before going for FMG exam. Because in FMG, they will copy paste the many questions of NEET PG of last 5 to 7 years. So do remember, RDA fulfill need of almost everyone, and estimated average requirement fulfill need of around 50% of the population. Estimated for 50%, RDA for 97.5%. What is the RDA of calcium, vitamin D and iodine, they ask. They have never asked about iron till now, but they do have asked about iodine. And it's very easy to remember because vitamin D, everyone needs 600 international unit per day. Everyone means everyone, it doesn't matter. So it's done. For calcium, do remember these 2 points that in old age, they need 1200 milligram. In lactating female also 1200 milligram. But pregnant female don't need that much of calcium, only 1000 milligram. And this 1000 milligram is same for adult male and female. Male, female both need the same amount of calcium as pregnant female. But question they have asked already from lactating female and old age. Their calcium is 1200. When it comes to iodine, iodine of only pregnant and lactating female you have to focus. For pregnant female, the iodine written in PARC textbook is 250 microgram per day, and it's 280 microgram per day for pregnant female. So it's actually 230 to 250 here, and it's 250 to 280 microgram there. So according to PARC, this is the data for iodine, roughly 250 for both. You can remember like that, and 1200 for lactating female and old age is the requirement of calcium. Never forget this part. Then they can ask you the definition and formula of net protein utilization. It's very simple to understand. Whenever you will go to gym, the first thing they will ask you is start eating egg. So I also go to gym. Yes. In 5 months, I went 4 times. I'm very regular to gym. Just missed 1 day. Otherwise, I will be regularly irregular. So suppose they also advise me to eat egg. And on the first day of gym, I eat 17 egg. I eat so much egg that I started looking like an egg myself. So 17 ande, I hope you know this thing. 1 egg gives 6 gram of protein. It also gives 6 gram of fat. And 1 egg gives 250 milligram cholesterol. And of course, egg is deficient in vitamin C. Egg do not have vitamin C. And what is deficient in milk? Milk is deficient in vitamin K. So I went to the gym and they said me also to eat egg. So if I eat 17 egg, from 17 egg, I will roughly get 100 gram of protein. So what is the protein present in 17 egg? Protein present is 100 gram protein. This 100 gram protein is what is present in the food in our 17 egg. So how much protein present we write below. And out of that 100 gram protein which I will take, 96 gram my body will utilize in making muscles and hormones and other things, enzymes and all. Only 4 gram will go out. So how much protein is utilized? How much protein? Protein can be written as nitrogen. How much protein is utilized? Protein utilized is 96 gram. Protein present is 100 gram. So this 100 gram will cancel out with this 100. And finally, net protein utilization of egg will be 96, which is maximum out of all the protein. And that is why egg protein is the best quality protein. This is the definition of net protein utilization. It's very simple to remember actually. Net protein utilization simply means what is the protein which we utilized. divided by what is the protein which is present in food. Okay. So out of the 100 gram protein which was present in 17 egg, my body utilized 96 gram. So do remember NPU have U here. So U is the numerator, utilization is the numerator, and P, present, is the denominator. P is the denominator, utilization is the numerator. And you can simply understand it because I use 96 gram protein out of 100. So NPU of egg is maximum 96. Okay. That's why egg is best quality protein. But if they ask which food has maximum amount of protein, maximum amount of protein is in soybean. It is roughly 49 gram, 44 to 49 gram in 100 gram soybean. No, it's 44, not 49. 44 gram in 100 gram soybean. So soybean have high amount of protein, but soybean protein is not utilized by body so well. So it's not best quality protein. Best quality protein is egg only. And fish has maximum protein energy ratio. What is protein energy ratio? Very simple thing. If I eat a fish which give me 1000 kilocalorie energy, so this is the energy from food. How much energy I got from eating food? That is written below. And out of this energy, how much energy is from protein? So if I eat 1000 kilocalorie fish, then out of that 1000 kilocalorie, 800 kilocalorie only come from protein. That means fish has maximum protein energy ratio, and that protein energy ratio is 80%. If I got 1000 kilocalorie by eating it, 800 is coming only from protein of the fish. And you can see it yourself. If you remove the upper skin of the fish, it's directly protein inside it. There is no fat or carb inside a fish. So do remember protein energy ratio maximum of fish 80%, where we write protein above, energy below. NPU of maximum of egg, and soybean has maximum protein. And before going ahead, I want to discuss you two concept of the various different type of diet which they are asking. First is, what is high fat diet? High fat diet is same as keto diet. So in keto diet or high fat diet, the total energy is very less. Total energy is just 1000 kilocalorie. And out of that 1000 kilocalorie energy, 60% should come from fat. That means 600 kilocalorie is fat. Rest all are carbohydrate and protein. So is carbohydrate 400 kilocalorie? No. Is protein 400 kilocalorie? No. They both combine to form 400 kilocalorie. But because the total calorie is very less, so the weight loss occur. The second type of diet is prudent diet, which we discussed yesterday also. This is the diet which is advised to cardiovascular disease patient. Prudent diet to CVD, cardiovascular disease patient. In this diet, the salt intake should be less than 5 gram, and the fat, saturated fat or cholesterol, should be less than 100 kilocalorie out of 1000 kilocalorie food. If the total food is 1000 kilocalorie, less than 10% should be from saturated fat. So saturated fat should be less than 10%, and less than 10% saturated fat. Other than that, salt should be less than 5 gram or equal to 5 gram. They say sugar should also be less than 5 gram, and alcohol should not be there. No processed food should be there, and more vegetable and fruits should be there. So this is second type of diet, prudent diet. The last type of diet is DAS diet. What is DAS? Dietary approach to stop hypertension. This is DAS diet. In this DAS diet, they say that in a day, if you have hypertension and all, you should take 4 to 5 serving of fruit and 4 to 5 serving of salads or vegetable. If you eat more fruits and vegetables, then your hypertension will stop, because then you will not have a space for eating other carb and fatty things. Other than that, they say you can take some amount of protein, some amount of this. The main thing is focus on this part, which is protein and carbohydrate. Now, very important is the topic of food adulteration, because every alternate exam, one question come from it. Like in the food adulteration, how they will create question, they will ask that if someone was eating, some population is eating mustard oil, and after eating mustard oil, they started developing bilateral pitting edema. So, what is the poison for that? What is the poison which is causing this problem? So, the poison in this case is sanguarine. Now, in the last NEET exam, they went one step ahead and they asked to detect sanguarine. Sanguarine, G is also there. Sanguarine. Which test is best? Nitric acid test or paper chromatography test? Actually, in the option, there was only one test out of the following. Nitric acid was only in the option. But if the both are in the option, remember, paper chromatography is a better test as compared to nitric acid test. Paper chromatography test is more sensitive. It can detect the sanguarine poison at 0.02 microgram concentration, much lower concentration. And what is the second test name? Second test is nitric acid test. So due to this sanguarine poison, patient start developing edema, and then this edema goes to CHF, congestive heart failure. And this occur because mustard oil many a time is contaminated with seeds of Argemone mexicana. Argemone mexicana is a weed, not that weed which we smoke, but the weed which has 5 yellow petals, and this is with thorn all over the leaf and all. And you can see such weeds. You can Google it also. This yellow color flower of Argemone mexicana and yellow color flower of mustard look similar. So sometimes they get naturally mixed, but most of the time, to lower the price of mustard oil, they are being mixed with mustard oil. And this Argemone mexicana, it released the poison sanguarine, which caused this problem of bilateral pitting edema and congestive heart failure. And this disease is known as epidemic dropsy. The name of the disease is epidemic dropsy. So how will you remember it? To remember it, suppose you are sleeping with someone of your dream. S for sanguarine, S for sleeping. And anyway, sang means together. And so suppose you are sleeping together with someone of your dream. If you sleep, first you will not sleep, you will do some action only. But if you sleep, due to sleeping, the eyelids will drop. And here, if you look at the symptom also, that is also pitting edema, it is also dropping inside. So sanguarine is causing dropsy, pitting edema also. Okay. Then the second illness is endemic ascites. So epidemic dropsy and endemic ascites are the two things about which I used to get confused a lot. This endemic ascites have the symptoms of course, ascites. So the symptoms will be ascites. Ascites means pate swelling. Pate is a Hindi word for abdomen. So I can say it's pate or abdomen which gets swelling. And due to this swelling, the problem arises. But the poison which is responsible for this is pyrazolidine. So it's very easy to remember. Very easy actually. See, what is happening? In ascites, there is swelling of pate. And the poison is also from P. pyrazolidine. So ascites is with pate. Poison will be from P. pyrazolidine. Okay. Second point is ki, what is the poison? Plant related plant which cause this problem is crotolaria. This crotolaria is mixed with Panicum miliare. So this Panicum miliare is the one which is causing the problem. So P for Panicum miliare, P for pate, P for pyrazolidine, everything is PPP. and you can easily remember it. Now, one question which has been asked multiple times in MCI exam already is कि मूंगफली में दाना नहीं, हम तुम्हारे मामा नहीं. Someone is eating groundnut, and this groundnut is contaminated with some green color fungus. So if you eat groundnut or maize which has Aspergillus flavus fungus, this Aspergillus flavus fungus releases which toxin? They ask the name of the toxin, that is aflatoxin. They say someone eat contaminated groundnut due to which they develop hepatocellular carcinoma of liver. What is the poison? So the poison is aflatoxin. The second similar food adulteration is when someone eat rye or wheat or jawar. This rye or wheat or jawar is having a black color ergot. The ergot is actually Claviceps purpurea fungus. So this Claviceps purpurea or ergot is black in color. It develop on rye, and due to this ergot intake, just like ergotoxin drug which we take in migraine treatment like sumatriptan, ergotamine, they relieve the migraine pain by causing vasoconstriction, because in migraine abnormal vasodilatation occurs which cause the pain. So this ergotamine have the property of constricting the capillary. Similar thing here, ergot is releasing ergotoxin. This ergotoxin will also cause constriction of peripheral capillaries and all. That lead to cyanosis or necrosis of finger and hallucination like thing. So what will happen in ergotism? Ergotoxin will be released and there will be cyanosis or necrosis of fingers and toes, and along with cyanosis and necrosis of finger and toes, there will be hallucination like the one which occur with LSD and all. Similarly here it is occurring due to ergotoxin, hallucination. Okay, so these are the 4 poison, but in NEET 2023, just with one food adulterant, they asked 2 questions in the same paper. So that in that question they asked this, they gave the hint that people in an area are walking on toe, walking cross leg on toe. People are walking like this, cross leg on toe. Okay, cross leg on toe. And one exam they asked this question. Second exam they said patient is from Chhattisgarh. It not necessarily to be from Chhattisgarh. He can also be from Bihar or UP. But in that exam they have used the word patient from Chhattisgarh, eating pulse and rice mostly, develop spasticity of lower leg. उसका कड़ा हो गया, खड़ा नहीं कड़ा, क्या कड़ा हो गया? Lower leg, spasticity of lower leg. So what is the poison responsible for it? So in both of the thing, if spasticity of lower leg is happening or cross leg walking on toe is happening, this both are due to the poison BOA, beta oxalyl aminoallyl, and this BOA poison is causing neurolethyrism. So this is neurolethyrism. Neurolethyrism is due to this Khesari pulse. This Khesari pulse is something which is mixed with arhar dal. Arhar, and arhar is a common pulse which we all eat in our sambar also and normal pulses also. So when Khesari and arhar are mixed, it is very difficult to differentiate between them. And this Khesari and arhar pulse, they are the one which are releasing, Khesari is releasing the poison BOA, causing the problem neurolethyrism. So what is the treatment for this? They have asked in the NEET exam already. Treatment is vitamin C, 500 milligram to 1000 milligram. And how can you remove BOA? BOA can be removed by keeping this Khesari saag overnight in lime water. This is known as parboiling. So how you can remove it? You can remove it by parboiling. Okay, so these are the 5 food adulteration topic. I hope you will remember. And remember, Food Safety Standard Authority of India, it come under both state list as well as central government list. Similarly, ESI and Ayushman Bharat also come under both state list as well as center list. Okay, so these were the topics which I wanted to discuss from uh, the topic of nutrition. Now, after discussing the salient and important point of uh, this nutrition topic, let's go and discuss demographic cycle, demographic dividend, and then disaster management. Okay, very important area. So let's go from this part now. First thing is that they can ask you an image based question also from demographic cycle and dividend. And it's very easy to remember actually. If you see the history of India, you will easily remember it. Point is, if there is any question from that part, feel free to ask it. Let me see. Is there anything you want to ask? Very good. You were answering. Chandra is answering. Himalaya is answering. Jessica is answering. Very good. Yes, stiffness and muscle rigidity. Correct. Priti is replying. Anumitha is replying. Thank you so much. Very good. Thank you so much, dear friend. Let's come to this part. Very important. The thing is very simple that if India story you see before 1950, India was in this phase of high stationary when many people were taking birth and many were dying also. You have heard this story from your grandparent. At their time, 8 children used to take birth, 6 died, 2 leave, like that. So high birth, high death rate was there. That's why the population was stationary. After that, India entered into early expanding where the birth rate was still high. And what do you think? Where our grandparents were also high? Huh? They must be high. They are actually the one who have this high phase in birth rate in these 2 phases, high stationary as well as early expanding. So this was one MCI question, that in which 2 phases birth rate is high. Birth rate is high in a high stationary and early expanding. These 2 birth rate is high. Then after early expanding, we have in the early expanding itself, some delivery started occurring in government hospital. So death rate started decreasing. Okay, so do remember this point, that high stationary and early expanding both have high birth rate. This is a PYQ of MCI itself. Then India is right now in late expanding. In late expanding, birth rate start decreasing, and our birth rate is decreasing. After 10 years, India will be like China in the declining phase. What is declining phase? In declining phase, death will be more, birth will be less. China for last 2 years is declining. All of the Europe is almost declining. Japan is declining. So declining simply means birth rate become very low. Birth rate becomes so low that birth rate become less than death rate. And death rate is low, but death rate is higher than birth rate. More people are dying than taking birth. That is declining. Okay, and India right now is in late expanding. In late expanding, our birth rate start decreasing. Of course, death rate with medical advancement, it decreases further. So sometimes they ask this whole term also. What happened in late expanding? Birth rate start decreasing, death rate decreases further. Second point is that, remember, this is very simple table to remember. In high stationary, both things were high. So in low stationary, both birth rate and death rate will be low. So high stationary, low stationary can be easily remember. High stationary both high, low stationary both low. Declining, you already understood that death rate is more than birth rate. Only thing that Only thing that you have to focus is early and late expanding. And it's very easy to differentiate. Early expanding birth rate is still high. Late expanding is where India is right now, where death rate start decreasing, birth rate start decreasing, death rate decreases further. So based on this table, in one of the MCI exam, just 2024, they have asked you to level some of the point in the table, okay, in the graph. So let's draw a simple graph to understand it. I think Blinkit वालों का call होगा इसलिए आ रहा दूसरा एक call So let's understand this graph from this table. The graph had this 5 phases, 1, 2, 3, 4, and the 5th will be the last. Suppose I am representing birth with white. So this is the birth rate with white, which is high in the first phase. This is first phase, second phase, third phase, fourth phase, fifth phase. I could have shown you the diagram directly, but by drawing it in front of you, you will understand it better, plus you will remember it better. Birth rate is always the upper line, and death rate is the one which is lower line. But in the initial phase, they get mixed, like death rate is like this, and birth rate is like this. And so that's why the population growth remains stable. But after this, in the second phase, birth rate is still high in the early expanding. Third phase, late expanding, birth rate start decreasing. This is the phase where India belong. Fourth state is decreases further. Fifth, it become very low. So this is how birth rate goes. Now, in the exam, the question was from this part. They have asked what is the lower line. So the lower line is definitely death rate. In the second phase, early expanding, death rate start decreasing. In the third phase, it decreases further. In the fourth phase, of course, it decreases. And the fifth phase, you can see death rate become more than birth rate. Okay. So what is happening here? This is the way how a population grow. Population remain low, 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 then start growing in early expanding, grows in late expanding, and then it becomes stable and then start declining. So if they ask to level this lower line, this is the line of population growth. And they can ask 2 more questions from this part. First question, which part has highest birth rate, highest growth rate? So remember one very important definition from which a numerical also came in MCI exam, that this growth rate is simply not birth rate minus death rate. Growth rate is birth rate minus death rate by 10. Why we divide by 10? Because birth rate, death rate both are in 1000. Per 1000 population, we measure birth rate and death rate. We will discuss the definition also. Death rate means how many deaths occur in a year divided by mid-year population measure on 1st of July, multiply by 1000. And this definition has also came. That what is death rate? Death rate is total death, of course, in a year by mid-year population on 1st July, multiply by 1000. So whenever we measure death rate or birth rate, we measure it on 1st of July and we multiply by 1000. But growth rate is in percentage. Percentage means growth rate is in 100. Death rate, birth rate is in 1000. So there is a 1 extra 0 in birth rate, death rate. To remove that extra 0, we are dividing birth rate, death rate with 10. So it will come in 100. So that's why growth rate is birth rate minus death rate by 10. So second question which they ask from this graph is, which phase has maximum growth rate? So what is growth rate? Birth rate minus death rate by 10. So if the gap is maximum, growth rate will be maximum. And you can see this is the part where gap is maximum. So where the growth rate is maximum? Growth rate is maximum in late half of second, late half of early expanding. This is early expanding second. इनके आधे हाफ में, लेट हाफ में जाके गैप बढ़ा है और गैप बढ़ा है तो ग्रोथ रेट बढ़ा है. अगला सवाल आता है कि ग्रोथ रेट कम होना कब शुरू करता है? तो थर्ड फेज के अर्ली हाफ में ग्रोथ रेट कम होने लग जाता है. इन अर्ली हाफ ऑफ थर्ड फेज growth rate start decreasing because the gap also start decreasing. So growth rate start decreasing in early half of third phase and growth rate is maximum in late half of second phase. Okay. So because in NEET 2024, this question has came from this graph, they can ask it again in your exam. Do remember this graph and do remember this demographic cycle. If there is any confusion, feel free to ask it right now. Don't hesitate in asking your doubt. So in phase in which growth rate is 0, growth rate कब 0 होगा? किस फेज में? Second, third, fourth or fifth? Tell me. This is the question which I am asking to all of you. In which phase of demographic cycle growth rate is 0? कब होगा growth rate 0? बताओ. Tell me, second, third, fourth, or fifth, because we right now learned about it. We learned that growth rate is maximum in late half of second phase, early expanding phase. Growth rate is maximum, and growth rate start decreasing in early half of third phase, in early half of late expanding. And late expanding is the phase where India belong right now. Okay, so do let me know, in which phase out of second, third, fourth, fifth growth rate is 0? Tell me, कब होगा growth rate 0? 2, 3, 4, 5. बताओ, when is the growth rate 0? When is the growth rate 0? Very good, Rudraksh and Dr. Golas, both of you are right. Growth rate is 0 in phase 1 and phase 4 because they are stationary. So answer here will be either 4 or 1. 1 is not in the option, so answer will be phase 4. Phase 1 and 4 will have the growth rate 0 because they are stationary. So now we know everything about demographic cycle. From the population pyramid, they ask this question: which population pyramid have bigger base? What does bigger base indicate? And you must have seen the animal movie also. She was saying, the ex of Deepika was saying, by looking at the actress, you have bigger base, which means you have high chance of producing children and a high fertility rate. So similarly, the big base of developing country indicate high fertility rate. So big base is high fertility rate, big base of population pyramid. And that big base of population pyramid is for which type of country? Of course, it is for developing country. And developing country has this सीधा खड़ा pyramid, upright straight pyramidal. Okay, so this is for developing country, straight pyramidal, सीधा खड़ा. And when I watched that movie, I said he is objectifying female. You know? But just 2-3 days after that movie, I was roaming around in my room, of course, and my wife saw me from back and said, "Baby, you have cute bum." To me. So it's not just that male objectify female, female also objectify male, and it's okay. It's not so big deal. So do remember, developing country have which type of population pyramid? It's straight upright pyramidal. है ना? सीधा खड़ा pyramid. Upright pyramidal is the population pyramid of developing country. Now, when it is developed country, in the developed country, young people are less and old are also less. So it will look like spindle shaped. This is spindle shaped. This is like my body. Narrow, center swollen. So that is the same way how the population pyramid of developed country look, spindle shaped. And remember, population pyramid not just tell about the age distribution, it also tell about sex distribution. It has male and female on the two sides. So population pyramid tell age also, sex also. Let's now come to this one very new type of question from the concept of demographic dividend or demographic bonus. So देखो, bonus, Rudraksh is saying कि sir have Hindi please. United States of Bihar से अरुणो नमस्ते कर रहा है. Use English. Okay, bro, I will use English. Don't worry. Chandra is saying, sir, this cycle is always so confusing and almost making me anxious and panic. So I need to discuss demographic cycle. Or Chandra, is it clear? Or should I discuss it again? फिर से एक बार डिस्कस करूं क्या चंद्रा भाई, बताओ. देखो, डेमोग्राफिक बोनस और डेमोग्राफिक डिविडेंड बड़ा ही सिंपल कंसेप्ट है. पहले इसको डिस्कस करते हैं, फिर अगर चंद्रा बोलेगा तो डेमोग्राफिक साइकिल को फिर से एक बार डिस्कस कर लेंगे. बट इट इज वेरी सिंपल टू अंडरस्टैंड दिस कंसेप्ट. सी, बोनस इज ए गुड न्यूज. डेमोग्राफिक बोनस अच्छी बात है, और डिपेंडेंसी रेशियो एक बुरी बात है. ज्यादा लोग निर्भर होंगे तो वो कंट्री के लिए बोनस नहीं है. बोनस तब होगा जब डिपेंडेंट लोग कम होंगे, निर्भर लोग कम होंगे, तब कंट्री को अच्छी न्यूज बोनस मिलेगी. तो बोनस मिलने के लिए डिपेंडेंसी रेशियो को घटना चाहिए. कंट्री को डेमोग्राफिक बोनस तब मिलेगा जब डिपेंडेंसी रेशियो घटेगा। जब कम लोग होंगे निर्भर, तो देश के लिए अच्छी न्यूज होगी। हाँ, डोंट वरी, आई विल डिस्कस ची एनोवा कंसेप्ट। बस फर्स्ट टेल मी, हाँ, चंद्रा ऑल्सो वांट डेमोग्राफिक साइकिल वन मोर टाइम। ओके, सो फॉर श्योर, Chandra, you want it in Hindi or in English? Do tell me. So then I will explain in that way. Very simple. See, country will get bonus when dependent population will be less. So when we will have demographic bonus, कब मिलेगा बोनस? जब डिपेंडेंसी रेशियो कम होगा तब। अब डिपेंडेंसी रेशियो को कैसे कम कर सकते हैं? डिपेंडेंसी रेशियो में सीधे सीधे हम लोग ऊपर उन लोगों को लिखते हैं जो निर्भर है, और नीचे उन लोगों को लिखते हैं जो कमा रहे हैं। तो जब निर्भर लोग कम होंगे तभी तो डिपेंडेंसी रेशियो कम होगा। अब निर्भर लोगों में दो लोग हैं जो हम पे निर्भर हैं, एक तो 15 साल से छोटे बच्चे, एक तो 65 साल से बड़े वाले। 65 साल से बड़े वालों को तो कुछ नहीं कर सकते हैं, लेकिन अगर 15 साल से कम बच्चों को हम कम कर दें पैदा करना, तो डिपेंडेंट पॉपुलेशन कम हो जाएगा, डिपेंडेंसी रेशियो कम हो जाएगी, और उससे कंट्री को मिलेगा डेमोग्राफिक बोनस। तो डेमोग्राफिक बोनस मिलने के लिए डिपेंडेंसी रेशियो कम होना चाहिए। और वो कैसे कम होगा? जब हम फर्टिलिटी रेट को कम करेंगे। जब हम बच्चे कम पैदा करेंगे तो कंट्री में निर्भर लोग कम हो जाएंगे, और निर्भर लोग कम होने की वजह से जो डिपेंडेंसी रेशियो है वो कम हो जाएगा, और डिपेंडेंसी रेशियो कम होते ही कंट्री को मिलेगा डेमोग्राफिक बोनस। समझ गए? What I was saying in Hindi was, if we decrease our fertility rate, less than 15 year will be less, and if less than 15 year will be less, dependency ratio will be less, and country will get the demographic bonus. So for demographic bonus, both things should decrease. Fertility rate should also decrease, and dependency ratio should also decrease. Now similarly, in one of the MCI exam they ask, when the country will get demographic burden, हम पे बोझ कब पड़ेगा? तो बोझ पढ़ने के लिए दोनों चीजों को बढ़ना चाहिए। डिपेंडेंसी रेशियो बढ़ेगा, ज्यादा लोग निर्भर रहेंगे तो कंट्री पे बोझ बढ़ेगा, और साथ ही साथ अगर हम फर्टिलिटी रेट बढ़ाएंगे तभी तो डिपेंडेंट लोग बढ़ जाएंगे। जब हम ज्यादा बच्चे पैदा करेंगे तो 15 साल से छोटे वाले जो न्यूमरेटर में रख रहे हैं वो ज्यादा हो जाएंगे, और जब 15 साल से छोटे लोगों की संख्या बढ़ जाएगी तो जो निर्भर लोग हैं वो बढ़ जाएंगे, डिपेंडेंसी रेशियो बढ़ जाएगा, और वो कंट्री के लिए डेमोग्राफिक बर्डन की तरह काम करेगा, एक बोझ बन जाएगा। तो बोझ तब बनेगा जब हम ज्यादा बच्चे पैदा करेंगे, और बोनस तब मिलेगा जब हम कम बच्चे पैदा करेंगे। क्या ये सिंपल है? डेमोग्राफिक बर्डन कंट्री विल गेट बाय इंक्रीजिंग डिपेंडेंसी रेशियो, and how can you increase dependency ratio? By increasing population less than 15 years. So demographic burden increases by increasing dependency ratio. And how does dependency ratio increases? By increasing fertility rate. तो देखो ये कंसेप्ट क्यों सिंपल है, सीधी सी बात है। जब हम बोनस की बात करेंगे तो दोनों चीजें कम होंगी, डिपेंडेंसी रेशियो भी और फर्टिलिटी रेट भी। और जब हम बर्डन की बात करेंगे तो दोनों चीजें बढ़ेंगी, डिपेंडेंसी रेशियो भी, फर्टिलिटी रेट भी। तो याद रखना इस बात को कि जब कभी भी हम डेमोग्राफिक, दो चीजें हैं, डेमोग्राफिक बोनस को ही लिखते हैं डेमोग्राफिक डिविडेंड। डेमोग्राफिक बोनस और डिविडेंड में दोनों चीजें घटेंगी। कौन कौन सी चीज घटेंगी? डिपेंडेंसी रेशियो एंड फर्टिलिटी रेट, बोथ विल डिक्रीज। एंड डेमोग्राफिक बर्डन, बर्डन में क्या होगा? बर्डन में बोथ विल इंक्रीज। Which both will increase? What does both means? Both means two things: fertility rate and dependency ratio. जब दोनों बढ़ेगा तो बर्डन है, और जब दोनों घटेगा तो बोनस है। ओके, आई होप इट इज क्लियर। इफ नॉट, फील फ्री टू आस्क इट अगेन। यस, वेरी गुड। Chandra want to learn about demographic cycle. First, let's clear demographic cycle, then we will come to demographic indicator. देखो चंद्रा, डेमोग्राफिक साइकिल एक बड़ी सिंपल सी बात है। इन डेमोग्राफिक साइकिल, पहली बात इंडिया की इमेजिन करो, हम लोग 1950 से पहले का इंडिया देखें अगर, तो इस टाइम में क्या था कि जितने लोग पैदा होते थे, बहुत लोग पैदा होते थे, उसी संख्या में लोग मर भी जाते थे। दोनों चीज हाई थी, बर्थ रेट भी हाई था, डेथ रेट भी हाई था। इसीलिए इंडिया हाई स्टेशनरी फेज में था, क्योंकि जितने लोग पैदा हो रहे थे उतने मर रहे थे। ठीक है, अब 1950 से लेके 1990 तक इंडिया ने क्या किया, खूब बच्चे पैदा किए, तो बर्थ रेट तो हाई रहा, और साथ ही साथ 1950 से 90 के बीच में डिलीवरी सरकारी में होने लगी। तो डिलीवरी जब सरकारी अस्पताल में होगी तो डेथ रेट भी कम होना शुरू हो जाएगा, स्टार्ट डिक्रीजिंग। तो इस फेज में आप समझ सकते हो 1950 से 90 के बीच में इंडिया खूब फला फूला, बहुत फैला। तो इसीलिए इसको कहते हैं अर्ली एक्सपेंडिंग। सबसे पहला फैलने का काम हमने 50 से 90 के बीच में शुरू किया। अब एक बात बताओ, क्या इंडिया अभी भी फल फूल रहा है? क्या अभी भी इंडिया में पॉपुलेशन बढ़ रही है? हाँ बढ़ रही है, लेकिन बहुत ज्यादा तेज स्पीड से नहीं, बट बढ़ रही है। तो अब इंडिया किस फेज में आ गया? लेट एक्सपेंडिंग में। लेट एक्सपेंडिंग में तुम ये समझ सकते हो कि 1990 से लेके 2030 तक हम लोग इस फेज में रहने वाले हैं, या हो सकता है 2028 तक रहेंगे। 28 के बाद हम लोग पहुंच जाएंगे लो स्टेशनरी में। और लो स्टेशनरी में क्या होगा कि बर्थ रेट डेथ रेट दोनों लो हो जाएगा, लोग पैदा भी कम लेंगे, मरे भी कम, तो पॉपुलेशन स्टेबल हो जाएगा। तो इस डेमोग्राफिक साइकिल को याद करना जाने मन बहुत आसान है। पहला फेज है हाई स्टेशनरी, जिसमें सब कुछ हाई है। चौथा फेज है लो स्टेशनरी, जिसमें सब कुछ लो है। तो हाई में दोनों हाई, लो में दोनों लो, क्या मुश्किल है? हो गया याद। अर्ली एक्सपेंडिंग में बस एक बात याद रखना, बर्थ रेट हाई रहता है। लेट एक्सपेंडिंग में, जिसमें अभी इंडिया है, बर्थ रेट घटना शुरू हो जाता है। और एक हिंदी में मैंने वीडियो भी बनाई है अलग से डेमोग्राफिक साइकिल की, मेरे यूट्यूब चैनल पे ही पड़ी हुई है, वहां भी आप इसको समझ सकते हो डिटेल में, अगर यहां नहीं समझ में आ रहा है तो भी। बट ये बहुत आसान है समझना। हाई स्टेशनरी दोनों हाई, लो स्टेशनरी दोनों लो। अर्ली एक्सपेंडिंग में बर्थ रेट हाई, लेट एक्सपेंडिंग में बर्थ रेट डिक्रीज करना शुरू हो जाता है। अब जब हम डेथ रेट की बात करेंगे, तो एक बार मेडिकल फैसिलिटी की वजह से डेथ रेट डिक्रीज करना शुरू कर गया है, तो ये आगे और भी डिक्रीज करेगा, डिक्रीजेस फर्दर। इसी को कहते हैं लेट एक्सपेंडिंग। ये दोनों बात, अर्ली लेट एक्सपेंडिंग, बस आपको याद रखनी है, क्योंकि जो पांचवा और आखिरी फेज है डिक्लाइनिंग, उसमें ये सब कोई समझ पा रहा है कि डिक्लाइनिंग में बर्थ रेट जो है पैदा होगा कम और डेथ रेट हो जाएगा ज्यादा। इसलिए डिक्लाइनिंग में बर्थ रेट को हम लिखते हैं वेरी लो, और डेथ रेट को केवल लो लिखते हैं, क्योंकि डेथ रेट बर्थ रेट से भी ज्यादा हो गया, मर ज्यादा रहे हैं, पैदा कम हो रहे हैं, इसलिए पॉपुलेशन घटने लग गया। तो क्या ये पांचों क्लियर हुआ साइकिल चंद्रा ब्रो? 10B, इज इट क्लियर? आई थिंक यस। ओके, नाउ demographic bonus dividend is clear. Let's discuss this topic of demographic indicator, then we will do some question on it. अगर आपसे कोई बोले कि 1000 माओं ने कितने बच्चे पैदा किए, तो उसको कहते हैं जनरल फर्टिलिटी रेट। जनरल फर्टिलिटी रेट का क्या मतलब हुआ? नंबर ऑफ लाइव बर्थ पर 1000 फीमेल। सो इसको मल्टीप्लाई करेंगे 1000 से, वही 1000 वहां लिखा हुआ है। 1000 मां ने कितना बच्चा किया? जनरल फर्टिलिटी रेट। हाउ मेनी चिल्ड्रन आर प्रोड्यूस्ड बाय 1000 फीमेल? दैट इज जनरल फर्टिलिटी। But if they ask how many children are produced by one female, that is total fertility. So total fertility is one female, TFR, one female live birth. एक मां ने कितने बच्चे पैदा करे, टोटल है। और 1000 मां ने कितने बच्चे पैदा किए, वो है जनरल फर्टिलिटी। तो सोच के बताओ कि इंडिया का टीएफआर का टारगेट क्या होगा। व्हाट इज द टारगेट टीएफआर फॉर इंडिया? हम क्या चाहते हैं, भारत में एक मां कितने बच्चे पैदा करें? व्हाट इज द टारगेट टीएफआर ऑफ इंडिया? आंसर करो इन द चैट बॉक्स, डू रिप्लाई। व्हाट इज द टारगेट टीएफआर ऑफ इंडिया? 1000 मां ने कितना बच्चा पैदा किया, जीएफआर। एक मां ने कितना बच्चा पैदा किया, टीएफआर। फिर जो बच्चे पैदा होते हैं वो मेल और फीमेल दोनों होते हैं, और आपको पता ही होगा मेल तो सारे खाली टाइम पास के लिए हैं। असली नेचर में जरूरत किसकी है? फीमेल की, क्योंकि फीमेल ही नया बर्थ कर सकती है। तो जो ग्रॉस रिप्रोडक्शन रेट है वो सिर्फ एक माँ ने लड़कियां कितने पैदा करी उस पर ध्यान देता है. Gross reproduction rate only focus on how many girl child are produced. So what is gross reproduction rate? Number of girl live birth per female. लड़कियां कितनी पैदा हुई, गर्ल लाइव बर्थ पर फीमेल. सो अगर टोटल बर्थ की बात करेंगे TFR, एक फीमेल ने टोटल कितना पैदा किया, हाउ मेनी टोटल बर्थ ऑकर पर फीमेल इज TFR, हाउ मेनी गर्ल लाइव बर्थ ऑकर पर फीमेल इज GRR, ग्रॉस रिप्रोडक्शन रेट, एंड हाउ मेनी टोटल चिल्ड्रन पर 1000 फीमेल इज GFR. तो the target TFR, Rudraksh and Himalaya has answered 2.1. Target TFR is actually 2.1. Very good. You both are correct. So government of India think कि every female will produce 2 and 0.1 children. Now you will ask, sir, how 0.1 children? Of course, let's say Nikhil produced 3 children, I produced 2 child, Golu produced, my brother produced 1 child. So if you take average like this, it will come 2.1. TFR we never calculate for one person, we calculate it for a population. So in a population, our target is 2.1. Why? Because out of 2.1, some will die also. So if you remove those who died, finally it will be 2 child per couple. So what is the target TFR? 2.1. What is current TFR of India? 2. So we are producing less children than needed to replace us. So you need not to worry, you can produce as many children. Population growth is no more a problem for India because we have achieved this target of 2.1 and we are now having TFR of 2 right now. So is this 3 thing clear? Last thing is net reproduction rate. एक आप सोच के बताओ, एक फीमेल ने जितनी बच्चियां पैदा करी वो तो GRR है, लेकिन क्या जो भी बच्ची एक फीमेल पैदा करेगी वो सब बचेंगी क्या एडल्ट होने तक? नहीं ना, कुछ मर भी जाएंगी. तो जो मर गई जब हम उनको माइनस कर देते हैं तब NRR मिलता है. What I was saying in Hindi was that GRR is saying total girl child per female, but not all girl child will survive till they can become adult. So those who died before becoming adult, when we subtract them from the total child, then we get NRR. So what is NRR? Number of girl child per female between 15 to 49 years, considering age specific mortality rate. So we are going to subtract those who died before becoming adult. We are considering the mortality rate. So answer NRR should only be marked if there is mortality word in the question and there is no girl live birth but girl child. If you found girl child and mortality in the question, only then answer is NRR. Okay. So imagine me as a female. Okay. And suppose I gave birth to more than 2 girl child. One will replace me, one will be extra. That extra will produce some extra children. So population will grow. So if NRR is more than 1, population is expanding. Now, if NRR is equal to 1, suppose I gave birth to only 1 girl child, she will replace me. So if NRR is equal to 1, population become stable. This NRR equal to 1 means, this is the question in MCI exam also which has been asked, NRI equal to 1 means stable, it means 2 child per couple. तो हम दो हमारे दो के लिए NRR कितना होना चाहिए? NRR 1 होना चाहिए. Then finally, if NRR is less than 1, it means I have not produced even 1 girl child. So then I will die and no one will replace me and population will decline. So NRR less than 1, population is declining. Okay. What is the target TFR of India? 2.1. Now, let's do some question on this indicator which will make this concept more simple. But before moving to the question, let me explain one more thing. कि मान लो एक गांव में 100 कपल रहते हैं और हमारा डॉक्टर हिमालयन उस गांव में पहुंच गया मेडिकल ऑफिसर इंचार्ज बनके. तो 100 कपल है मैरिड, उसमें से कितनों को कॉन्डम बांटोगे डॉक्टर हिमालयन? How many will you distribute contraceptive and condom to out of 100 eligible couple? If there are 100 eligible couple in a village, how much will you like to distribute the condom to? है ना? Chandra is non-Hindi but still understood that by explanation when I write the age and all. Oh, very good. So my question is कि if you are the medical officer in charge and there are 100 eligible couple, how many of you will you try to have the contraceptive? Even if you try that all 100 should have the contraceptive, will all 100 will use it? No, not all 100 will use it. है ना? What I'm saying, in a village, total eligible couple is 100. And out of 100 eligible couple, you try to give condom to all of them. But some people like me who have gone through vasectomy, tubectomy, if you will give me the condom, what I will do? I will fill it with water and throw it on you back. No use of condom for me. I will fill it with air and blow it on in my birthday. So even if you try to give it to 100 eligible couple, not 100 will use it. If 60 also use it, how many couple are using contraceptive? 60. And how many were eligible couple? 100. So here the couple protection rate came out to be 60%. If 60% couple use it out of 100, then couple protection rate is 60%. And it has been found that if couple protection rate becomes 60%, अगर 60% लोग contraceptive use करने लग जाएं, if couple protection rate becomes 60%, then net reproduction rate become 1. And net reproduction rate 1 means 2 child per couple. So if you want to control the population, you have to give condom and contraceptive to 60% of the couple. Okay, do remember. This is a very common area of question. And who are eligible couple? Eligible couple must be married. Married couple with female in reproductive age group, they are eligible for contraceptive advice. So we call them eligible couple. Okay. So I hope it is clear. Yes, Himalayan will exactly give it to 60 couple only. No, you have to try to give it to 100. Then 60 will accept it. Okay. But I think you know this concept, so you answered it correctly. Now let's do some confusing question. Then your concept will be more clear. The question is total number of live birth per 1,000 female is known as. Answer this question. Total number of live birth per 1,000 female. Jessica is saying you are a great instructor, best sense of humor. Thank you. Shukriya, Jessica. Shukriya. Thank you. Thank you. So, मैं इतना भी खूबसूरत नहीं हूँ. Focus here. What is total number of live birth per 1,000 female is known as? As soon as the students see the word total, please do answer in the group. As soon as the student think total, they answer TFR. But you have to focus here. They have used the word per 1,000 female. If I am talking how many children are produced by 1,000 female, answer will be GFR, general fertility rate, not TFR. If I remove 1,000, then it will be TFR. Here it will be GFR. Yes, see, Rudraksh done the mistake also. It's GFR. Okay. Second point. Do remember it. Huh? Don't do this mistake. Huh? Total number per 1,000 is GFR. Total number per female is TFR. What is TFR? Total live birth per female. Per female. Per female is TFR. But per 1,000 is GFR. Don't do this mistake. It's very common mistake. Now let's answer this question. Total number of girl live birth per female considering current fertility trend of India is known as. What is the answer here? Girl live birth per female considering current fertility trend of India. What is the answer? Melody Fun has answered it correct. A. Himalayan is calling me cute boy. Naughty boy. Puppy le lunga. In the focus. Total number of girl live birth per female considering current fertility trend of India. What will you call it? What is the answer? See, first thing is, in the question, if they mentioned the word girl, as you saw girl, GFR, TFR is gone. Because GFR and TFR both are for total live birth. Total children, not for girl. So they are gone. Now answer is either GRR, NRR. But as I said, NRR can only be the answer if they use the word mortality or if they use the word female child, not live birth. And here mortality and female child both are not used. So the answer is GRR. Actually, what they are asking is number of girl live birth per female considering current fertility trend. What is the current fertility trend of India? Current fertility trend means 15 to 49 year female will only produce children. So they are asking total girl live birth per female of 15 to 49 year. And that is GRR, gross reproduction rate. So remember, very good, correct answer. My Chandra, Himalayan, Jessica, Rudraksh, Melody Fun, all of you have answered it correct. It is GRR. Let's answer this one more question. Birth rate is 20, death rate is 7. What is the annual growth rate? 20 and 7. What is the growth rate? What is growth rate? 20 and 7. What is the growth rate? Answer. Growth rate will be 13. No, because birth rate minus death rate by 10 is growth rate. So it will come 20 minus 7 by 10 is 1.3, not 13. If growth rate become, yes, correct, C answer. If growth rate become 2%, 2% means population explosion. बम फट जाएगा लोगों का, लोग ही लोग चारों ओर रहेंगे. So it will be population explosion if growth rate become 2%. So it can never be more than 2%. It can always be less than that. Okay, chalo, very good. B is the answer which all of you get. Now let's again do one more PYQ of FMG exam. In a family, there is एक 68 ईयर का लौंडा है, उसकी 59 ईयर ओल्ड की छमिया है, मतलब मस्त बंदी है. तो ये दोनों बुढ़ा बुड्ढी 68 और 59 के हैं. And in the dependency ratio, we write either less than 15 or more than 65. So more than 65 is this 68-year grandfather, one person. In between, we write 16 to 64. And in 16 to 64, you have one grandmother, one. Then 9-year-old kid, 9 is here. So 1 plus 1 total 2 is the numerator. And then 28-year mother, 35-year father. So 2 are the father and mother. So 3 are below, 2 are above into 100. If you do 2 by 3 into 100, it will come 66 or 67%, 66.6%. Answer is 66%. Okay, I hope you can easily do it. Statics are difficult if you are not aware of the formula. If you know dependency ratio, just 15 plus 65 we have to add. Divide by 16 to 64, you will get the answer quickly. If you find statics more fearful, there is a session only on stats question which is on my YouTube channel, free for all, of course. You can go through those questions, but those are stats question for NEET I have written. But remember, NEET and FMGE are being prepared by the same board, so they have the same level of difficulty. So go through those numericals if you want to get it more clear. And if you have any area specific of difficulty, I will definitely clear it. Let's discuss some concepts of disaster management after completing demographic cycle, dividend and all. Okay. First thing is, who is the main person who take the disaster management decision? That is Prime Minister Modi. And it comes under Home Ministry. Mota bhai, Amit, is Home Ministry is the one which look over disaster. Prime Minister is the nodal person. And at the district level, who is the head of disaster management? That is District Collector. Remember this point, that in I program as well as in disaster program, District Collector is the head at district level. Then what is the most common disaster? That is hydrological disaster, under which flood come. And what is the most common disease during flood? Most common disease is gastroenteritis, chharchari, loose motion. But if it comes to Mumbai flood or Kerala flood, there the most common was leptospirosis. Because in Mumbai, Kerala flood came 2 years. In Bihar and Assam, flood is coming for last 200,000 years. And when flood comes, the health system is also in such a poor condition that they are not able to collect sample and confirm that it is leptospirosis or cholera. And when you are unable to confirm it, you label it as gastroenteritis. So most common is gastroenteritis, but in Kerala, Mumbai, which has comparatively good health system, the result came out to be leptospirosis more common. If they ask, what are the other diseases which are common? That is cholera, rickettsial disease, mosquito-borne disease and all. These are also common. But the main question in disaster always come from either vaccination or disaster cycle. In vaccination, remember, no new vaccine is given to the population. We give typhoid, tetanus, cholera, TTC. This 3 vaccine is given to health workforce. Okay. But no new vaccine is given to general population. Okay. No new vaccine is given to general population except tetanus, typhoid, cholera, which can be given to health worker. So Why we don't give new vaccine to general population? Because whenever you give vaccine, immunity takes 3-4 months to come. सुई आज लगेगी और रोग प्रतिरोधक क्षमता आएगी 3-4 महीने बाद. तो फायदा क्या है आज लगाने का, है ना? Because what is the use of giving vaccine if the immunity will come so late? But there is one disease, measles. In case of measles vaccine, immunity come in 7-8 days and measles symptom appear 10 to 14 days. है ना? So the disease come 10 to 14 day time. Take 10 to 14 day time to develop the symptoms of measles. And immunity by measles vaccine come in 7-8 days. So at least we can give measles. Why we are not giving measles only? Because measles is not a common disease during disaster. Measles होती ही नहीं है, तो उसको देंगे क्यों? है ना? Plus at the disaster time we have very less number of doctor and nurses. If we will engage them in giving vaccine, who will save the life? So remember, to the general population, no new vaccine, only tetanus, typhoid, cholera to health workforce doctors. And measles is also not given, but remember which vaccine give immunity before symptom, that is measles. कौन सी ऐसी वैक्सीन है जो इम्यूनिटी पहले दे देती है, सिम्टम बाद में आते हैं? measles है. Measles give immunity in 7-8 days, symptom comes 10 to 14 days. So 10 to 14 days is the incubation period of measles also. Okay? Not done during disaster because it's difficult to do, the manpower is less, plus difficult to maintain the sanitation condition. More common area from which 2 questions came in NEET exam also in last 2 years only is disaster cycle. Very important area. So to remember disaster cycle, imagine yourself as a person in Bihar flood or Kerala flood affected by it. First work you will do is rescue and relief, in which you will do triage and treatment. After that, you will try to make people self-dependent by giving them some job. So, which job will you give to them? Which job? कौन सी नौकरी दोगे उनको बाढ़ में? बताओ निखिल. Which job will you give लोगों को बाढ़ में? पानी निकालने का? Which job we will give to the people? The one job which we can give is ऊपर जाके हगने का, बताएंगे, बात करेंगे. The one job which we give is we ask them to make the house. जो टूटे हुए घर हैं बाढ़ के बाद उसको बनाएंगे. तो job we give first, then they can construct house. So rehabilitation come first, reconstruction is after that. Do remember, all are from RRR. You get confused here only. That's why they ask question from here. Focus and you will not be confused. First we will rescue them. Then we will give them job. Giving job, making them dependent is rehabilitation. And through the job, we will make their house. So rehabilitation is first, then reconstruction. Remember, rehab, then reconstruction, and first is rescue relief. After that, we will try to decrease the impact of future disaster. That is known as mitigation, like planting trees, trying to make earthquake-proof house is also decreasing effect of earthquake in all those northeastern area states and all. So that is also mitigation, decreasing effect of earthquake by making earthquake-proof houses. And then final is preparedness, preparing the doctor team, nurses team, rescue team. But preparedness is never more effective than mitigation. Mitigation is much better than preparedness. And whether you are prepared or not, next impact. So this is disaster cycle. To remember it, you can use the mnemonic that triple R. And suppose after the success of their movie, they went to MP, Ujjain. And in MP, Ujjain, they gave this thandai, marijuana leaf mixed milk drink. They had it, and if you have the marijuana mixed leaf, bhang and all, you have the impact. So this is the way to remember triple R MP impact. But what is this triple R? That you have to focus. Rescue, then giving them job, rehabilitation, and through job making their house reconstruction. So that is triple R. पहले बचाएंगे, फिर job देंगे, job से उनका घर बनाएंगे. तो rehabilitation, then reconstruction, and mitigation, preparedness, and impact. I hope you will remember the cycle. I hope you remember no new vaccine is given during disaster. Now, tell me, this one question has came already in MCI exam, that relatively stable patient come to which category? Which category is relatively stable patient? Is it green, red, yellow, or black? Please do answer it in the chat box. I will be more than happy to see your response in the chat box. Which one? Okay. First of all, black, of course, I hope you know, is moribund. They don't need any attention. Moribund or dead patient. who are certain to die or died is black. Red is the one who need urgent life-saving intervention within 6 hours. So urgent life-saving is red. In as soon as possible, ASAP, less than 6 hours. So what is the answer? Who is relatively stable, yellow or green? Yellow or green? Yes, I got 4 answers in the chat box from my very good friends, and all 4 of you are wrong. Green are stable. Stable patient who can be moved from one place to another. That's why we call green as ambulatory. Relatively stable is yellow because they are more stable as compared to red. Yellow are those who need life saving in 6 to 24 hours. 6 to 24 hours. So they are relatively stable as compared to red. This was a confusing question, and it's okay to be wrong here. Now you know a new information, so you should be happy when you do mistake in the class or in the online lecture, because when you do mistake, you remember it better. So you do it correct in the exam. Okay. So it's good to do mistake here, and that's yellow. Correct. Gorisa was correct. It's yellow. Chalo. Now, if it is reverse triage, which is done during war, then we give first priority to green. Because if some soldier come with minor injury, we will first repair them and ask them to go fight. Come with major injury, go fight. So green first, then second will be yellow, not red. Then there will be red, and finally last priority is always black. Why? Because we have more soldier needed at the war. So we will first save the green and ask them to go and fight again. That's why the sequence is green, yellow, red, black. Okay? Chalo. Now, so we are done with this part of disaster management, nutrition, demographic cycle dividend. Now, I want to discuss you one very important concept of sampling technique. You know what is sampling technique now? When we choose sample, we can do mistake in choosing sample. Why we choose sample? Because we cannot do the study on the whole population. So we always choose sample. And when we choose sample by lottery method, we call it simple random sampling. Like suppose I want to take 10 people out for a party after this class. So I will ask the management to give me name of all the students who attended my lecture, and I just randomly, with the help of computer software, I will ask the software to give me 10 names randomly out of 100. So this is by lottery method, and this is best for homogeneous population. Homogeneous population means which is similar to each other. Like all of you are student homogeneous, same. So I can choose you by simple random. But if I choose you by simple random method, the problem is that I can have, let's say, out of the 10, 9 can be girl, or out of the 10, 8 or 9 can be boy. And I want that in that party, which I will give after the class, there should be 5 boy, 5 girl. Why? Because I'm a happily married, settled type of guy, but I want them to have more love in themselves. And a boy and girl should have some setting with themselves. So I want 5 boy, 5 girl. So when it comes to your sex, you are heterogeneous, you are different. And whenever the population is heterogeneous, for heterogeneous population means population which are different from each other in terms of question asked, we do stratified random sampling. So when I will do stratified random sampling, if you have to, I have to choose 5 male and 5 female, I will do stratified random sampling because here you are different from each other. So this is stratified random sampling, which is best for which type of population? Heterogeneous, when you are different from each other. The third type of sampling is systematic random sampling. Student population is in this class, suppose the population is 200, and out of 200 I have to choose 10, or out of 100 also I have to choose 10. So if you divide 200 by 10, it comes 20. I will ask you to give any random number between 1 to 20. Suppose the random number you gave was 7. So I will start selecting 1, 2, 3, 4, 5, 6, 7, and then 9, 20. Then 1, 2, 3, 4, 5, 6, 7. So I will choose every 7th number. Here I am following a system. I am choosing 7th number, nth number. And how the 7th number came? It came randomly. So it is systematic random sample. A very good question is कि मान लो आपको गांव में जाके पता लगाना है कि गांव वाले कॉन्डम यूज कर रहे हैं कि नहीं. क्या लगता है आपको, गांव वाले कॉन्डम यूज करते हैं कि नहीं? If you want to do a study to know what is the condom use in villager, how can you do? This was the question being asked. Every first and fourth house you selected for interview. So if you're selecting every first and fourth house for interview, you are doing systematic random sampling because you're choosing first and fourth. Okay. And whether villager use it or not, I don't know. I have not checked what is below their lungi, but we can do this survey by systematic random. We can know. The fourth type of sampling is not written here, but I will teach you. The fourth type of sampling is cluster random sampling. Suppose I want to know Bihar has more immunization vaccination or Uganda have more vaccination, or which have less vaccination. What do you think? Uganda have less vaccination rate or Bihar have less vaccination rate? Who have less vaccination rate, Bihar or Uganda? What do you think? If you don't know, what you have to do is you have to choose 7 children of 12 to 23 months from 30 villages, and you will ask their mother, all the 210 children mother, you will ask that had they taken vaccination or not. On based on that interview, you can compare and tell that who have less vaccination rate. Okay. And Chandra said me Uganda. You are saying me Uganda. So let's say, don't call me Uganda, okay? It's a real name. Huh? If you want to compare, actually, it's very simple. You just take the interview from the mother and you can compare. But here the point is, all the 7 children are from same village. So all these 7 children have same origin. If the origin is same, and then you are choosing cluster based on origin, this is cluster random sampling. Okay. Now let me ask you a really confusing question. And this is how WHO do the immunization study. So this is the WHO immunization study, which always done on 210 population by cluster random sampling. Okay. Now my question to all of you is, this was the real question, came in NEET exam, that out of 100 drug, okay, 100 drug, groups of plant, animal and fungal origin, 10 drugs are selected randomly. So which type of sampling is happening here? The option which I am trying to give here is mainly the two. One is stratified random sampling. Remember what we do in stratified random sampling, वही काम जो पॉलिटिशियंस करते हैं देश को बांटने का काम, जात के नाम पे, धर्म के नाम पर, जो अंग्रेजों ने भी किया था, डिवाइड एंड रूल. The same work which politicians and Englishmen done in India, divide and rule, that is stratified random sampling. Like I divided you between boy and girl, 5 boy, 5 girl. And because I need 10 people from the whole class. So first I divided into boy and girl, let's say 50-50. And then I choose 5 from boy, 5 from girl. So that is stratified, when you divide and then you choose. And second is cluster random, when they are already divided. That is cluster random sampling. So which sampling is done here? Stratified or cluster? What is your answer? Please do reply in the group. Let me give you a common example to understand it better. Suppose I went to take a class in, let's say, Kagma, Bishkek. And in that class, there are 500 students. I said, those who are from Bihar, raise your hand. Those who are from Rajasthan, raise your hand. And those who are from South India, raise your hand. So I divided them into 3 groups. Then I select 10 from Bihar, 10 from Rajasthan, 10 from South India. So first I divide, then I choose. This is stratified random sampling because they all are same. I am dividing them and choosing from them. So similarly, in this question, all 100 drugs are same. The researcher is dividing them into plant, animal, and fungal origin and then choosing from them 10, 10, 10. So this is the stratified random sampling. How it can be cluster random sampling? In the same Kagma batch, if I go and I say, no, I cannot do it cluster random in the Kagma. I can do this by going and visiting medical colleges in Rajasthan, select 10 children from there, interviewed them. Then I went, visited Bihar, selected 10 children who are studying in medical colleges of Bihar, interviewed them. And then I went to southern part of India and interviewed 10 children studying there. So if I go and interview 10 children of Bihar, Rajasthan, and South India living already separately, then that is cluster random because they are living already separated. I am not dividing them. Like in the WHO immunization study, we are not dividing those children. They are already living in the different villages. We are just visiting different village and taking the interview of their mother and concluding that who have more immunization rate. So whenever you divide population and then do the survey, that is stratified random sampling. But when you go and collect data from different origin people, that is cluster random. Okay, so whenever you divide, division is stratification. Stratification means layer. So this was stratified random sampling. Similarly, in the past, they have asked the question that a population was divided based on diet. Divided based on diet. Some are vegetarian, some are non-vegetarian. Which type of sampling you will do? Stratified random sampling. If you divide population based on diet, religion, anything, diet, religion, IQ, anything, if you are dividing sex, anything you are dividing, it is always stratified random. But if it is they are already living separate and you just go and interview them separately, that is cluster random. Is it clear to all of you or not clear? Let me know. Tricky question. Yes, it's tricky question, dear. Yes, but this has came and I hope you will be able to answer it. मैं हिंदी में भी समझा देता हूं. अगर हम जाके अलग अलग लोगों का इंटरव्यू करें अलग अलग जगह पे तो है क्लस्टर रैंडम. लेकिन जब वो साथ में आ गए, हम उनको डिवाइड करके अलग करके तब पूछेंगे तो स्ट्रैटिफाइड रैंडम है. समझ गए? जैसे मैं अगर जानना चाहूं कि केरला में लोग क्या खाते हैं, बिहार में क्या खाते हैं, केरला जाके इंटरव्यू लिया और बिहार जाके इंटरव्यू लिया, क्लस्टर रैंडम है. लेकिन अगर मैं एक मेडिकल कॉलेज में चला जाऊं और वहां जाकर के केरला वाले कितने हैं, बिहार वाले कितने हैं पूछ लूं और उनसे फिर पूछूं, तो ये मैंने डिवाइड किया उनको स्टेट के बेसिस पर, तब स्ट्रैटिफाइड हो जाएगा. Are you getting it? If we divide it, stratified. If they are already living in separate area and we go and interview, that is cluster random sampling. Okay. So I hope these all are clear. But there is one more sampling you should know. Rudraksh want it once again. It's something which we should write also. Do remember this point. If researcher divide population. If researcher divide population based on anything, that is stratified random sampling. But if we interview already different population, that is cluster random sampling. So when we call it cluster, if population live separately and we interview them separately, then that is cluster random sampling. Okay. Are you understanding it, Rudra, or not? Do let me know. If you need one more question, I can create you, but after this question, every question will be simple. Because I will be dividing them based on diet, religion, sex, you will answer stratified random. If I am not dividing them, it is cluster random. In cluster random, Population already lives separately and we go and interview them separately. That is cluster random. If not clear, you can always ask. I will give you one more example. Let's have one more example. The example is, I have already given some, but let's have one more. In a study done on organ donation, 50 Muslim and 50 Sikh and 50 Hindu family were asked family were asked from Haryana, and they all are living in the Haryana. This is actually my own study in AIMS New Delhi during my PG. I did this study on organ donation. So 50 Muslim, 50 Sikh and 50 Hindu family were asked from Haryana about what religion say on organ donation, about effect of religion on organ donation. So which type of sampling is done here? Effect of religion on organ donation. So which type of sampling is here? Answer it in the group. Is it cluster random or is it stratified random sampling? Cluster random or stratified random? We are going and asking them the question. So what should be the answer? Rudraksh understood it, but still let's have this one discussion. What is the sampling here? Cluster random or stratified random? Do reply. It can be cluster random if I go to a Muslim country, let's say Pakistan, and ask 50 people there, or I go to, let's say, Dubai and ask 50 people there. Then I went to, let's say, only Sikh population is not living anywhere, but let's say some community which has only Sikh people and go and ask there. And then I went to Nepal and asked 50 people there. So if I ask specific 50 people in their home, that is cluster random. But here they are living together in Haryana. And I am like some politician dividing them into Hindu, Muslim, Sikh and then asking question. So because I am dividing, it is stratified and all of you understood it. Very good. It is stratified. You understood it. Okay. So I hope this part you will not confuse. This is a very recent area of question for MCI exam. But one more thing I want to tell you, that is multi-stage random sampling. They will give you one big map. Suppose map of Delhi. I want to know how many children are smoking marijuana in Delhi in 11th, 12th class. So from the Delhi, I will choose 3 area. From each area, I will choose, let's say, 4 colonies. From each colony, I will choose 2 schools. From each school, I will choose 20 students. I will interview these 20 students and I will say this is the data for whole Delhi. Is it a correct thing which I am doing or a wrong thing which I am doing? Because how many children I interviewed? 20 children, 2 school, 4 colony, 3 area. So 4 into 3, 12 plus 2, 24, 24 into 20, 480. 480 student I am interviewing and I am telling it for the whole Delhi. Is it a correct thing to do or a wrong thing to do? This is the only option. Because if I interview all the children of Delhi, I need to spoke myself. I cannot interview all the children. I have to choose a sample. And this is how US, UK also collect data. So how exam question will come from this topic? They will give you a big map and then they will take a small thing from the map and they will ask which type of sampling is here. So big map, small, that is multi-stage random sampling. I hope you will remember. Okay. And these all are example of random sampling. Chalo. Now, after learning the sampling technique, let's go to learn this topic of data representation. Okay. And vaccination. Let's, which topic you want me to do first? Let's do the topic of data representation first, because then we will be finished with data representation and this part, sampling technique, data representation together. But Rudraksh has a question. What is snowball sampling? Okay. Actually, Rudraksh, you are asking the question about non-random sampling. Okay. And this non-random sampling is something which is very less asked, but anything can come and we should have the knowledge. So let me tell you about non-random sampling also. Very simple. If you want to do a random sampling, every participant has equal chance of selection. That is random sampling. But when you are doing non-random sampling, not everyone has equal chance of selection. In non-random sampling, first type of sampling is convenience sampling. कन्वीनियंस सैम्पलिंग का सीधा मतलब है जैसे मेरी मर्जी वैसे करूंगा सैम्पलिंग. आप बैठ जाओ ओपीडी में, आपको अस्थमा पे स्टडी करनी है, जो पहले 100 मरीज आएंगे उनको आप स्टडी में ले लो. तो ये आपके सुविधा के हिसाब से हुआ ना, इसलिए इसको कहते हैं कन्वीनियंस सैम्पलिंग. व्हाट आई वाज सेइंग इन हिंदी वाज, you are sitting in respiratory chest TB chest OPD and first 100 patient of asthma will be taken in your study. So this sampling is based on your easiness, your convenience. You call it convenience sampling. First 100 patient of asthma taken in study. Now you said ki oh only male patient are coming more and I want female male equal number. So if you want female male equal number, you can put a quota कि I will choose 50 male, 50 female only. So we call it quota sampling. Quota sampling means 50 male and 50 female coming to OPD will be taken for asthma study. So if you have male female divided, you have stratified convenience. You divided them, but they are still based on your convenience. So we call it quota. The last third sampling is snowball, which Chandra was asking. It's something which 2 questions can come from snowball sampling and have been asked already in the past. One question is, but not in the past 10 years, more back than that. First question is, in which type of sampling participant keep on adding in between the study? स्टडी के बीच में हम किस सैम्पलिंग में पार्टिसिपेंट को जोड़ सकते हैं? सो इन स्नोबॉल सैम्पलिंग रिमेंबर पार्टिसिपेंट एडेड इन बिटवीन स्टडी, बीच में जोड़ते हैं. ओके, इन बिटवीन स्टडी वी कैन ऐड. एंड सेकंड पॉइंट इज स्नोबॉल सैम्पलिंग इज डन फॉर हिडन डिजीज इन सोसाइटी. जो भी छुपी बीमारियां हैं उसके लिए करते हैं. फॉर एग्जाम्पल, सपोज you want to do a study on male having sex with male, MSM study. So for the MSM study, you were sitting in psychiatry OPD. First one male came who have sex with male. Then you ask about his partner, that how many of your partners are there, can you give me their address? So you now came to know about 4 people. You went to those 4 people and you asked about their partner. And they all gave you suppose 3, 2 and 4 partner like that. So now you have 10, 12 participants. Similarly, you can keep increasing participants. So what is happening here? Just like when a drop of snow fall from the top of the mountain, by the time it reaches the base, it become a big snowball. Similarly here, you started with 1 and now you are going and moving to become big number. So this is the snowball sampling done for hidden disease like male having sex with male, HIV. Male having sex with male is not a disease also, it's just a social trait, their choice. But if you want to know HIV in MSM, then you have to do this study. Similarly, HIV study, intravenous drug user study, all these studies are done by which sampling? Snowball sampling. And stratified has already came, so this time they can ask a snowball sampling question. I hope you will be able to answer it very well. Chalo. Now, let's discuss this one part, data representation. If they ask what is the simplest method of data representation, answer will be pictogram. In pictogram, we draw a picture. Suppose I am drawing this doctor. Does it look like a doctor? No. Your hand also, no. His finger also, no. Not doctor. No. Okay. Is a stethoscope is there? Not doctor. Plus sign is there. 1 MBBS doctor is here. And then I so that 1 MBBS doctor should be at 1,000 population according to WHO. But in India, the fake data by the fake government of India said we have one doctor at 3,700 Indian. Actually, we have one doctor roughly on 9,000 Indian. But when it comes to government of India, they do not look for MBBS doctor. They say just doctor, and they include all other branches also as doctor. So they say we have good number doctor, but actually we are having that's much less, and they should not take your exam. They should welcome you with gift and bouquet. We have so much doctor crisis in India. But anyway, do remember this is the pictogram, simplest method. But if they ask simplest method to represent balanced diet, if they ask simplest method to represent balanced diet, then for balanced diet, the simplest method is pie chart. I hope you know what is pie chart. Pie is a sweet dish which is in circle. So just like that, we replace the pie chart. We say that 50 to 70% should be carbohydrate, 30%, 10 to 30% should be fat, and remaining 15 to 30% should be protein. So fat, protein, and carb you represent like this in a circle. This is pie chart for balanced diet, and this is otherwise simplest diagram. So do remember, there are this type of question also they can ask. Which out of the four, if you know the answer, please reply. Which out of four we use for continuous data? What do you mean by continuous data? Continuous means quantitative. Quantitative means what we can measure. Quantitative or continuous means measurable. This is very important to understand what is this quantitative and what is qualitative. Like, can you measure my obesity? Please do reply this point. Because what we cannot measure, we call it qualitative. Qualitative is same as categorical. Because we cannot measure it, we can only divide it into category. So we call it categorical or discrete. This part is very important to understand and remember. First, forget about this question. First, focus on this part. If I ask you cholesterol, this question has been asked in MCA exam. Where will you put cholesterol? In measurable or in qualitative? We can measure cholesterol. So we can write cholesterol into quantitative, measurable, or continuous data. Now let's talk about my obesity. Where will you put my obesity? Quantitative or qualitative? Do reply. Where will you put my obesity? You cannot measure my obesity. You cannot say that, sir, you are 2.9 obese or 6.9 obese. You can only say कि sir तुम थोड़े मोटे हो, बहुत मोटे हो, फटने वाले हो, है ना? Some obesity, moderate obesity, or morbid obesity. So obesity or any disease, all disease cannot be measured. All disease are just categorical or discrete or qualitative. One of the student asked me, ki, sir, explain this chi-square paired unpaired test. So we are going to do that right now. But if you don't understand this basic difference, those questions will never be 100% correct. So try to understand this part first, and then it will help us to know the chi-square paired unpaired also. So very good. You know this thing. Gauri, Rudraksh, they all know obesity is qualitative. Let me do two more practice and then we are clear. If I ask you hemoglobin, where will you put hemoglobin? We can measure hemoglobin is here. But if I ask you anemia, anemia we cannot measure. We can only say anemia present, absent, mild, moderate, severe anemia. So anemia is like any disease will be here. So do remember, if you have obesity, anemia, any disease, it's qualitative. And when I talk in the class that how many of you have anemia, I say 5% of you have anemia. So when I use the data of disease, that is qualitative data, I will use the word percentage. I will use the word proportion. Okay. But if I want to measure hemoglobin, I will say average hemoglobin of this class is 10.6. So when we measure quantitative data, then we use the word mean or average. क्या ये बात समझ में आ रही है? जो नाप सकते हैं उसको मीन और एवरेज में लेते हैं, और बीमारी को नहीं नाप सकते हैं, बस डिवाइड कर सकते हैं, उसको हम लेते हैं मीडियन और मोड में. So median and mode is for qualitative data and mean is for quantitative data. Is this part clear to all of you or not? Yes, I hope it is clear. Anemia is qualitative. Correct. Himalayan has also answered. So now we know the classification of qualitative and quantitative data. Now the point is that in any question, if they gave any data of disease, like they talk about hypertension is a disease, diabetes disease, answer will always be chi-square test. For all this qualitative data, all disease data, answer will be chi-square. Here we apply chi-square test. If there is two or more group of participant, chi-square is the test we apply. So whenever in the question you found median, mode, you found percentage proportion, any disease name, any of these three hint you found, percentage proportion, disease name or median mode, you will directly answer chi-square. But if they have asked quantitative or measurable thing, let me write it here, then we can move ahead. If they ask about anything which is measurable, quantitative is measurable, and this quantitative can be BP, HB, weight, blood sugar, cholesterol, bilirubin, all of it will be quantitative. So in this case, if it is quantitative, we will first see that in the question, are they using the word pre-test and post-test? Or are they using the word before and after giving medicine or before and after doing the result? Or are they using the word match data? If you found any of the three words written in the question, then in all these three cases, we will apply paired t-test. Paired t-test. Suppose they said there is 100 group of, there is two group of people, obese, both have obese male, obese female, two group are there. And you are testing a new drug. You have given them the new drug, but before giving you measured their weight, and after taking the medicine for next 3 months, you again measured their weight. So you are measuring the weight before giving medicine, after giving medicine, pre-post. So which test we will apply to compare whether this medicine is useful or not? We will apply pair t-test, because this before and after data is coming from the same participant. So both of these data are paired. And this is pair t-test. We also call it dependent t-test, because this is applied when the two group of participant are matched. Matched means in one group the male you have taken is 39-year male, female is also 39-year female. So they are matched for their age. Match means similar in some perspective. So match data pre-post, before, after pair t-test we will apply. But if you found that in the question they have written two groups of participant, and in this two group of participant, they are not being taken their weight before and after. There is no matching done, no before after. Like this time, you have given anti-obesity drug to this two group, male and female, but you did not measure weight before giving medicine. You just measure it after 6 months, that how many are left obese. Okay. So here pre-post, before, after is not written. Only two groups are written. Here we apply unpaired t-test. And the other name of unpaired t-test is student t-test. One more name is independent, because now the data is not taken from the same group before and after. So now that is independent t-test. All these three are the name when there is quantitative data and two groups is there. And finally, if there is again quantitative data, but there is 3 or more groups. So for 3 or more groups, we apply ANOVA. What is ANOVA? Analysis of variance. So this is applied when there is 3 or more than 3 group. Okay. Now, I hope this classification part is clear, but still we get confused in the exam. So let me give you one very common area of common question from this part. The question is the effect of IFA, iron folic acid. Yes, no, on birth weight of newborns can be compared by which test? You will compare the effect of giving iron on 2 groups of participant. Option A, will you apply pair T test? Will you apply chi-square? Will you apply unpaired T test or student T test? Unpaired T test? Or will you apply ANOVA? What is the answer? What do you think? What we apply here? Very important. This one question can help you in understanding all the 4 things. Just think and answer. Effect of IFA, yes, no, on birth weight of newborn can be compared by which test? Do reply. I'm waiting for your reply also. Yes. Okay, unpaired, ANOVA, unpaired, paired is the answer. No one answered chi-square. I'm very happy with that thing. Because what we are comparing here? We are comparing birth weight. And birth weight is measurable. Birth weight is quantitative. Because it is quantitative, answer cannot be chi-square. Chi-square is gone. And when I say yes, no means one group is getting iron, one group is not getting iron. So yes, no is telling us 2 group is there. 2 group and quantitative data. Which test we apply? Very good. The answer is unpaired T test. This is the test we apply. Correct answer is definitely by Chandra, Himalayan. Then it is also by Rudraksh. You know? And Chandra has explained it also why unpaired. Now, in the same question, suppose I change the language and I ask this, that effect of IFA, yes, no, on percentage of low birth weight baby. This time I am comparing the percentage of low birth weight baby. Then which test I will use to compare the effect of IFA, yes, no, on percentage of low birth weight baby can be compared by which test? Which test? Which test we will use here? So first thing is, low birth weight is a category. The child can be normal or low birth weight or very low birth weight. I hope you know low birth weight is less than 2.5 kg, very low birth weight is less than 1.5 kg. So it is just a category. Second thing, percentage word is given. Whenever you find percentage word and a category, categorical data, answer will be chi-square test. Correct. So here answer will be chi-square. Himalayan has found it. Chandra, Rudraksh, Gaurisa all have said, Gauri Saha all have said correct. Now, in this same question, when I was measuring birth weight, rather than 2 group, if I say 3 group birth weight, then answer will become ANOVA. And in the 2 group, if I write the question like this, effect of IFA, yes, no, on birth weight of newborn. But here, pair T test can never be the answer. Because birth weight cannot be measured before birth. And so 3 post here cannot be there. So I can create it in a different way. The effect of iron, yes, no, on 2 groups of female who are matched for their socio-economic condition. Both are rich, group have rich female. Both group have female between 30 to 32 year only. and then we are comparing the effect of giving iron tablet on them. So here the data is matched, then the answer will be pair t-test. Okay, so I hope this part is clear to all of you. Very good. If you want more example, you can always ask, but I hope it is clear. So the question which I was discussing on this thing was that which is used for continuous data they are asking. Continuous data are all the thing which we can measure. And there is also one more group of test where we use, which we use for qualitative data. Qualitative means disease data. So remember this one mnemonic which will help you in the exam, that there are 5 diagram which is used for qualitative. Barre diagram, then fishbone diagram. What is fishbone? I will discuss also. Fishbone diagram, pie diagram, pie chart or pie diagram, then map. Which map? Spot map, and finally pictogram or picture. Pictogram. These are the 5 methods by which we express qualitative data. These 5 are for which data? These are for qualitative data. Qualitative means categorical, which are in percentage proportion. Median mode are used. So these are qualitative data representation method. And there are 8 methods of quantitative data representation also. So to remember these 5 separately, I use this mnemonic that going to bar, eating fishbone or pie in bar. Hey, does anybody eat fishbone or the sweet dish pie in bar? Unless gone after smoking, you cannot eat that. So going to bar, eating fishbone or pie in bar, then drawing map or picture in bar. Have you seen anyone drawing map or picture in a bar? If anyone is drawing map or picture in a bar, eating pie or fishbone in a bar, it means he's a very quality man or quality crack man. So these are the method of qualitative data representation. Rest all are method of quantitative data representation. But these are for qualitative data. 5 method are for qualitative. Remember these 5 and you can answer this question. If they ask which is used for continuous data, we don't know what are the 8 method of continuous, but we know that pi was qualitative. So pi can never be for continuous. We know map is qualitative. We know fishbone is qualitative. So these 3 cannot be the answer. Therefore, answer become box and whisker. Okay. And in most of the question, if you don't know the answer, just try to rule out. By ruling out, you can answer. So what is the fishbone diagram? Let's understand this fishbone. On this fishbone, they have asked this question in recent INICET exam, that the health system of a country, if you want to explain, health system functioning, best explained by. So if you want to explain the health system functioning of India, you can explain it like this. This is the health system of India. This is like a fish, and this is the bone, a straight bone. Ting, 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 like this. And then there is fin. So why our health system of India is not functioning well or can be improved? How we can improve the health system of India? One method of improving health system of India is by increasing the money given. This question has came that what is the GDP on health according to WHO? So GDP on health according to WHO is 5%. But India is roughly giving only 1.05%. So by doing that, more money we can increase. By increasing PSC, CSC, we can make our health system better. And by having more doctors who are coming from foreign country, directly employing them in our health system, we can fulfill the crisis and we can have better system. Plus, by not giving contractual job, giving permanent job, only then doctor will go to rural area. And these are all the things by which we can make health system of India better. So if I will write all those factors, this will be a fishbone diagram. And fishbone diagram is the best way to represent health system functioning. So there is one more name of fishbone diagram, Ishikawa. So it is Ishikawa or fishbone diagram, which is also used for qualitative data representation when the data is not measurable, just quality. Yeah, our quality is not good, so we can improve it like this. Okay, chalo. So this was one example of qualitative data representation, but we have to see the other example of qualitative data representation also. Let's go to those examples and discuss those questions. Okay, yes, we got it here. Let's discuss the other example of qualitative data representation. The next example of qualitative data representation is this. Okay, sorry for this. Yes, it's here. Yes. The other method of qualitative data representation is bar diagram. Suppose I am representing percentage of corona cases in Delhi, UP, Tamil Nadu. This is a bar diagram which can explain. Remember, in a bar diagram, first thing is it starts with a gap, and after each bar there is a gap. Gap. So this is a bar diagram for percentage of corona cases. But if I want to draw a component bar diagram, I will put one part above another. Like I put death hand case, one above another. That is component bar diagram. And what is the multiple bar diagram? Multiple bar diagram means we are putting 2 to 2 diagram, like cases recovered, and then giving gap again and again. So this is multiple bar. But remember always, whenever we talk about bar diagram, it always starts with a gap, and between any two similar number of bar, there is again and again gap. So this is a multiple bar diagram. Now they can ask this question, which plot is this? Which plot is this? Is it a histogram, bar diagram, component bar, multiple bar? It's definitely not component bar because nothing is above it. It cannot be bar because in bar there should be gap after each one. And it is also not multiple bar because remember, multiple bar start with a gap and there is a gap at equal number. But here there is 4 and 3, not equal number. So the answer here is histogram. This is not any kind of bar diagram. Bar always start with a gap and there is gap after fixed number. Then this is the pie diagram we already discussed. The best way to represent a balanced diet to layman is a pie chart. This diagram is a spot map and it is showing the first outbreak of cholera epidemic in London. When it occurs, most of the people die in this area, which is supplied by a different water company. So then John Snow, he went to the central area of London, the Broadway street where more people were dying, and he took out the handle of the hand pump. And not the whole hand pump like Sunny Deol, but he took out the handle. Then people cannot take water, and when people cannot take water, death in that area decreased. So then people believed, oh, John Snow was sahi kahat rahlas, he was telling the truth. And then people believed that yes, water can also kill us. So they asked it, who is the father of public health? Who is the father of public health? No, it's not John Snow. It's cholera. Due to cholera, we are learning about public health. John Snow is the father of epidemiology and modern epidemiology. And John Snow is the one who draw this spot map for the first time. So remember, my friend, winter is coming. Oh no, winter is already there. Remember, my friend, if there is an outbreak in your hostel, what is the first step of an outbreak investigation? What is the first thing you do? First thing we do is confirmation of diagnosis. You will collect the sample and take it to the lab for confirmation. Of course, not in your hand, it will leak out, but you will take it for confirmation. So remember, first step is identify the source. Identify the source and confirm the diagnosis. So what is the first step of outbreak investigation? First step of outbreak investigation is confirmation of diagnosis. We should confirm the diagnosis that yes, it is cholera. Okay, that is the first step. Remember, because if it is cholera, then we need to vacate and give different antibiotics. If it is typhoid, we need to give ciprofloxacin, need not to vacate. So it all depends on diagnosis. So first step is diagnosis. This is the third step. Fourth was pictogram and fifth was fishbone diagram. So all these 5 are for qualitative data. Then let's read what are for quantitative data. For quantitative data, there are total 8 methods, if you see. What are those 8? And we have discussed this already. So what are those 8 for quantitative? For quantitative, the first one is a histogram. We already draw an example of histogram in that question. Suppose I am writing here the number of cigarettes per day with age. So it keep on increasing till you go 30-40 year, and then it start decreasing. So this is a histogram. And in the histogram, if you draw it like this sharp line which take all the midpoint, this line is known as frequency polygon. This diagram is histogram, but this sharp line is frequency polygon. So if you have bar which are very far away, you can have sharp turn. This is frequency polygon. But suppose you have a histogram in which bar are very close to each other, very close to each other, very close to each other, very close, very close. Then you can't, very close to each other. So if they are very close to each other and you draw their midpoint, then they will look more like a curve. So you can have frequency curve or frequency polygon. Both are drawn from histogram. What is the difference? In frequency polygon, there is a sharp turn. In frequency curve, there is a smooth turn. But both come from histogram, joining midpoint of bar at histogram. Frequency polygon has sharp turn and frequency curve has a smooth turn. I have given this wrong image here because in this image, if you draw the midpoint of this image, this will look like a frequency polygon because here the bar are far apart. But in curve will come only when the bar are close to each other, that is frequency curve. Then let's learn one more thing about OGV. OGV, what is OGV? You have seen this while seeing corona worldometer. Corona worldometer was only going ahead, never coming down. Why? Because they were adding all the cases which occur earlier. So in OGV, other name of OGV is cumulative frequency curve. Cumulative means we are adding all the bar. We add 1/2, then 2/3, and then 1/3 also. So finally, from histogram, we get a histogram, cumulative histogram where all the bar are added. And if you join their midpoint, it becomes OGV. You have seen it in corona time that why corona graph was only going ahead, because we were adding all the cases who occurred earlier. We were not removing anyone. Even if they die, we are not removing them. So if you don't remove anyone, keep adding everyone, it will go above like that. Okay. So this is known as OGV. In corona worldometer, there was an OGV because it was always going ahead. So I hope this part is clear. If I draw a diagram, this frequency polygon, this frequency curve, this OGV. Okay, all the three are clear. Then the fourth one is a line diagram. Here I am representing cases of cardiovascular disease, hypertension and diabetes. In the world, it is increasing. So this is a line diagram, and line diagram represent trend of event. Always remember, line diagram, what does it represent? It represent trend of event, any trend. Like here I am saying you trend of cardiovascular disease. Similarly, I can represent with line diagram trend of Adani share, trend of Bitcoin value. All those things are line diagram which represent trend of event. Remember, trend. And this cardiovascular disease, hypertension and diabetes, they follow secular trend. Just like secular leader do not fluctuate towards any religion, remain equal to all religion. Similarly, secular trend is those disease which are constantly increasing or constantly decreasing for a long period of time. Like hypertension, diabetes, cardiovascular disease, they are constantly increasing in the world. So they are which trend? They are secular trend. Very common question. What is the example of secular trend? Cardiovascular, hypertension, diabetes. Which diagram represents secular trend? Line diagram. Okay? Do not forget this point. Now, next is that hello India, hello is coming so late. He is saying me to explain difference between NRR, GFR. I already explained it in the beginning of the session. Go through that. If still you found that you need one more discussion or it is not clear, you can message me on my WhatsApp number and I will clarify it to you. This is my number. You can also message me on 6686796675. You can also message me on Telegram group of PW Meded. But if you want to discuss that topic and you understand Hindi, then there is a English video on my YouTube channel also on the demographic cycle, dividend and indicators. You can go through that also. Okay. If you did not find it in the beginning part, always feel free to call me directly. Now, this is line diagram. not line marrow diagram, line diagram. Now, this is box and whisker plot. Box is what we draw between 25% to 75%. And whisker is the tail which go out. And what is the use of box and whisker plot? Box and whisker plot is used to identify outlier. What is outlier? Outlier means extreme value. For example, every 2 to 3 years, they do a survey in UK population that how many sexual partner you had lifelong. And usual answer which come is 2 to 7. Usual people say 2 to 7. But in the same UK population, some hunter, they have the data of 699 sexual partner, 596 sexual partner. Should we include those hunter in the normal population? Of course not. Because if you include these extreme data in the normal population average will become 30-40. And the whole population will think, ye sab kar rahe hain, hum hi nahi kar rahe hain. Everyone is doing, I am not doing. And they will be feeling depressed. And so we should not include these higher data, extreme data in normal population. We should remove them by calling them outlier. So remember, outlier are the extreme values, and box and whisker plot help us to know that. And in the box and whisker plot, each 25% is a quartile. It's a quartile. So a very good question came in INICT exam on this topic. The topic was that quartiles, percentile, and quartile, percentile represent which of the following? So what does quartile and percentile is telling us? This telling us it represent position or location of data. Suppose you got 99 percentile in NEET PG exam. So if you got 99 percentile, it means your position is almost first, almost in the top 10 or 20 people, 10 top 100 or 200 people. So location and position is represented by percentile and quartile. Quartile means at 25%, percentile means each 1%, 100 divided into 100 part is percentile. So percentile or quartile, they represent position or location of data, and box and whisker plot represent outlier. Then there is a scatter plot, छितराया हुआ plot. This scatter plot represent correlation. Correlation means whether two things are happening together or not. Like if you drink more alcohol, chance of accident is more. So there is a positive correlation between them. Similarly, if you smoke more joint, your marks will decrease. If you are smoking 5-6 joint per day, gradually your marks will start decreasing and will keep on decreasing. So that type of correlation is negative correlation. Okay. So positive, negative correlation is just telling us the direction where they are going. And remember one very important point, correlation does not imply causation. What does it mean? It means if two things are happening together, it doesn't mean one is causing the other. Correlation does not imply causation. For example, when India has a lot of vaccination of corona, cases were coming down. Government said cases came down due to vaccination. But in 5 countries of the world, even after 90% vaccination, there was second wave of corona. And US, UK, Seychelles, Israel, China also. So it proves that cases are not coming down due to vaccination. They are correlated. But high vaccination is not causing low cases. They can be due to natural mutation in the virus. And it has been found that virus generally become more infective, less lethal with evolution. So two things happening together doesn't mean one is causing the other. Okay? Do remember it. Now, last is stem and leaf plot. In stem and leaf plot, we can tell exact distribution of data. An image-based question can come. They can give you this type of image with one central stem and some number written. That is stem and leaf plot. Here, what I'm saying, suppose, let's say, in your group, there is some kind person, let's say Rudraksh or Jessica, who want to help. They both want to help the people who are wiping the floors of Gautam Nagar area and all. So Jessica took BP of all the males, and Rudraksh went to all old age females and measured their BP. So after measuring their BP, if you are writing any BP, let's say you are writing 148. Out of 148, 14 become stem, and last number 8 become the leaf. Okay, so like this, they arrange it in stem and leaf plot. What is the advantage of arranging it? By arranging it, they can say that only two male, 152, 159, they need medicine. So they find out that two males need medicine, not other just need some lifestyle modification or precaution. So they can know the exact distribution by stem and leaf plot. है ना? Now you will say कि सर ये क्या बवासीर बना दिया है, हम तो ऐसे भी देख के भी बता देते हैं 152, 159. है ना? You could have said that we can find it by seeing also. What is the need to draw it? But actually this is a data of just 7 people. If we have data of let's say 700 people, then a stem and leaf plot can help us to tell which one are having hypertension exactly. So if the data is big, then it is more useful. But you can get an image based question from here. So I hope you will remember all the 8 things. Remember scatter plot. Let's revise all the 8 things for a better memory, but I hope you can do. This histogram was there, then frequency polygon, frequency curve, OGV. This is line diagram. Line diagram represent trend. Then these are dot plot are scatter plot represent correlation. Okay. And then we have after line diagram scatter plot, we have the box and whisker plot. Box and whisker plot was representing outlier. And last was this stem and leaf plot, which tell us exact data distribution. So these are 8 methods of quantitative data representation. A lot of questions come from this topic. I hope you will remember it. Now, after this data representation part, let's move ahead and let's discuss. We have done this multiple component bar diagram already. Let's discuss the topic of international health. Usually we ignore international health, but one MCI exam 3 questions came from here, and then this topic becomes super important. It's easy to remember. Let's revise it. We have 2 things: Danida and SIDA. SIDA I have not copied, so I will write it. SIDA and Danida. They never ask the logo, they just ask the funding, that this SIDA and Danida, it fund which program. So very simple. S is for SIDA, S for sputum. SIDA is the one which fund TB program. So TB program is funded by SIDA. Then Danida is starting with Dan. Dan means donation. And which donation we do more commonly? Cornea, eye donation. So Danida fund eye program. Netradan, and it is funding eye program. You can remember it by Netradan, eye donation. And SIDA fund TB program. SIDA, Danida, clear? Then this question has actually came. What does UNDP fund? UNDP is United Nations Development Program. It fund Sustainable Development Goal. So you can see there is development in here also, Sustainable Development Goal, and here also United Nations Development Program. So UNDP, Sustainable Development Goal. It is a PYQ of MCA exam. This was the second PYQ. What does UNFPA fund? UNFPA is fund for population activity. What does it mean? Are they giving money for sex? Population activity fund. No, it is for population control activity. And UNFPA fund family planning program. Okay, but imagine it will be so fun if they started giving money for sex and earning and fun together. So it's not for population growing activity, for planning, family planning program is funded by UNFPA. But why they do not write control activity? Because most of the world is struggling with low population. So they are giving fund for having more population. Okay, so that's why they use the word population activity. Then UNICEF. Remember, UNDP development program, family program, and UNICEF all have headquarters in New York. And UNICEF is the one which fund on mother and child health. So the key strategy of UNICEF is GOBI FFF, G for growth charting. And remember, which is the best development indicator of child? Development can be best seen by growth chart. So that's why in Anganwadi, we grow the growth chart as indicator of their growth at development. Okay, best indicator for best for development, for measuring development. If you want to measure development, best is growth chart, because growth chart not just tell about present situation, it also tell the past and how the child is growing. O for, of course, ORS, B for breastfeeding, I for immunization, sui bhoka bhaki, F for fuck nahi, F for female planning, family planning. Second F is for female education, and last F is for food supplementation. So this is the key area on which UNICEF work. So you can see here that UNICEF is mainly focusing on women and child health, mother and child health. So UNICEF is for mother and child health. Second thing is, because food supplementation is a part of UNICEF, so UNICEF is the one organization which give fund for seed and manure of applied nutrition program. Seed and manure of applied nutrition program. It's a PYQ of NEET exam. Who give fund for seed and manure of applied nutrition program? That is UNICEF. They try to have fresh vegetable in Anganwadi and school through this program, which never worked, but that was the funded by UNICEF, seed and manure of applied nutrition program. Then of course, we should know some international organization. One is Colombo. They have asked it in NEET exam 2023 that who give fund for cobalt therapy unit. So CO for Colombo, CO for cobalt therapy unit, funded by Colombo plan. Second thing is AIMS New Delhi is opened under Colombo plan by taking fund from New Zealand. It was Rajkumari Amrita Kaur, our first and best health minister, who get the fund for this. That's why the AIMS OPD is RAK OPD. So remember, AIMS New Delhi and cobalt therapy unit both are under Colombo plan. Then with Colombo plan, they can ask some other thing, like they have asked in the past about they have asked one question. Colombo plan we know, cobalt therapy unit. Let me come to that question. Now, first is let's discuss some relevant thing. Care Foundation. What does Care Foundation fund? So who need most care? Children, small children. So Care Foundation is caring for their food and nutrition. It fund ICDS and Anganwadi program. And remember, now in the new update, Anganwadi is government is trying to make all Anganwadi linked with school so that there is no dropout. So Care Foundation. After Care Foundation, they can ask about Rockford. Not Rockford, sorry. Rockefeller. Rockford is a whiskey. I wrongly came out. Rockefeller Foundation. And so what this Rockefeller Foundation trying to do? It is trying to make our foundation rock solid. And when our foundation will be rock solid, if all the vaccine and drug are patent in India, then we will earn billions of rupees. So Rockefeller Foundation fund National Institute of Virology, which is in Pune. And it also fund research so that we can have some new patent. This is Rockefeller, which they can ask. Then the third is Ford Foundation. Ford Foundation. This question has already came in MCI exam some 2 years back. Ford Foundation. Ford Foundation fund sanitary latrine, and it also fund National Institute of Health Administration, which is known as NIHI, National Institute of Health Administration. So imagine कि कोई बैठा वेस्टर्न टॉयलेट पे और इतना जोर का हगा बूम ब्राम की फोड़ डाला टट्टी एकदम, तो अब नहाना तो पड़ेगा ना. Imagine someone did this big shit and the toilet is poured. Poured means busted out. So then he have to take bath. है ना? Take bath is Nihai in Hindi. So Ford Foundation, sanitary latrine and Nihai. Care for children, so ICDS Anganwadi. Rockefeller making foundation rock solid, so National Institute of Virology. This is the way to remember it. Then do remember, as I said, UNDP, UNICEF and UNFPA all are in New York. All these three UN are in New York. Only 2 UN are at other places. One is UNAIDS. UNAIDS is the same place where WHO is there. Because in 1980s, Africa used to say that also, South Africa, that WHO created AIDS. Because no one died from AIDS. Most common cause of death in HIV is TB. Then there is opportunistic fungal infection. So no one died from AIDS. So they said WHO created it. It's not a disease. So remember this weird thing. To remember, AIDS will be same place as WHO. And we all know where is WHO? Geneva. So in the Geneva, Switzerland, There is ILO, not Love Organization, Labor Organization, UNAIDS, WHO, and Red Cross. 4 things are there. Lal, red, together. WHO, UNAIDS together. All are in Geneva. Labor, red, WHO, UNAIDS. All are in Geneva. Then UNESCO, United Nations Educational Scientific Cultural Work. This is in Paris. Paris is the one which has the first democracy. And when the democracy came, they burned all the king family member alive in fire. So you can remember this. Who have the educational scientific work of democracy first? Paris. Apart from UNESCO, UNAIDS, all UN are in New York. In one class, I asked the student, what is the full form of FAO? By showing him this logo. I said, kya matlab FAO? He said, sir, fuck off. I said, why are you calling me fuck off? He said, sir, you yourself are writing flat penis. I said, bro, it's not flat penis, it's fiat panis. Let's break the bread together, not break the bed together, okay? So this Food and Agriculture Organization is in Italy, because either our favorite fruit is idli or pizza and all, so it's all related to Italy. Then, of course, where is the Red Cross headquarter? Red Cross headquarter is in Geneva. We just read Geneva will have Red Cross, ILO, and UNAIDS. All 3 are in Geneva. This is UNICEF Mother and Child blue color logo. This is, of course, in New York. Okay. Then World Bank. Where is the headquarter of World Bank? Very simple. What is the international currency? International currency is dollar, because World Bank headquarter is in capital city of America. Imagine if World Bank headquarter will be in Patna, Bihar. International currency will be rupiah and international language will be Bhojpuri. So remember, W for World Bank, W for Washington DC. This, can you identify this logo? No, this is not WHO. WHO is this with a snake-headed ladder. This is WHO in Geneva. This is UNDP, which funds Sustainable Development Goal, and it is in New York. And this is UNESCO, which is in Paris for Educational Scientific Cultural Organization. Okay, so we know the organization, headquarter, and their work, which they frequently ask. But in one of the exam, what they did was they gave you this logo in red color, of course, this logo. And they asked, what is this organization? People thought it's Red Cross. No, Red Cross is completely filled in red. This is Red Cross. This logo is of Suraksha Clinic. Suraksha Clinic and Mobile Medical Unit. Mobile Medical Unit. Both of them are example of public-private partnership. But they have asked it again and again, what is the work of Suraksha Clinic? Suraksha Clinic distributes sexually transmitted disease kit. So it treats STD patient. And this mobile clinic, Suraksha Clinic, both are public-private partnership. But the question they have asked in INICD from it is, who fund the medicine of these two? So remember, medicine for both Suraksha Clinic, Mobile Medical Unit is only from the government, because government can get the medicine at 5-10% cost also. So drug come from government. Ambulance and building can be government or private. But medicine always come from government. Okay. So this is Suraksha Clinic Mobile Medical Unit. Now, in the international death certificate, they usually ask one question, that what is the most important line of death certificate? So the most important line of death certificate is line 1C, which is telling us main underlying cause of death. So suppose I went outside after the class and a truck came and ride over my tummy. So what will you write in immediate cause of death? That is line 1A. What will you write in immediate cause of death? No. What will you write in immediate cause of death? Tell me. What is the immediate cause? It cannot be road accident. Road accident is the main underlying cause of death, is road traffic accident. Immediate cause can be, let's say, hypovolemic shock. And I have lots of blood flow. So due to hypovolemic shock, I die. Then in line 1B, we write immediate underlying cause. Why hypovolemic shock occur? Let's say hypovolemic shock occur because I had a spleen rupture. So spleen rupture will be written in immediate underlying. But what is the main category where you will classify my death? It will be under road traffic accident. And what is the other associated condition not directly leading to death? Like I have HIV, so that is the other condition. Or obesity, but it's not that due to obesity the truck get attracted towards me and hit me. So it's not directly leading to death. Okay. Now let's revise the Sustainable Development Goal. Very important. It has total 17 goal, out of which goal is for health? Third goal is for health, which say that ensure well-being and health for all at all ages. है ना, सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया, है ना, बड़ी बड़ी बातें. Then the main thing you have to remember is maternal mortality target is less than 70, being asked multiple times. MMR target is less than 70. Neonatal mortality is less than 12. And under 5 mortality is less than 25. So how to remember it? Only very simple. 3 number 70, 12, 25, 70, 12, 25. Under 5, 25. Half of 25, 12. So neonatal is 12 and 70 is the MMR. Then they say that premature cardiovascular death should be 1/3 and HIV, TB, malaria all should be eliminated by 2030. So all the plan were for 2030. Only one plan, accidental death, was for 2020. And in 2020, Corona came, so death become half. So remember, only one goal was achieved only for 1 year. Accidental death half by 2020. Nothing else was achieved, or it will not be achieved. But remember, 70 maternal, 12 neonatal, 25 under 5. Last thing under it is bioterrorism agent, where mainly they ask category C or A. C have two things, Nipah and Hanta. And for Nipah, they do give this image of date palm tree with lots of fruit bat and a pig. Does it look like a pig? I write no. So remember, if they show pig, fruit bat, or date palm tree, they all are talking about Nipah, because Nipah is transmitted from date palm sap, tadi, kal, that's like a beer, fruit beer, and the fruit bat also drink it and put some Nipah virus in it, and then man drink it and it can be transmitted through date palm sap. Okay, so Nipah and Hanta both are category C newer agent, and Hanta is transmitted by rat. But both Nipah and Hanta, they have origin fruit bat. Origin is always fruit bat. Transmitted by rat is Hanta, transmitted by pig and date palm sap is Nipah. They are category C. Category B is brucellosis, psittacosis, ricin toxin, and staphylococcal toxin. They are B, but they rarely ask A. Remember, A is for anthrax. So most is A for anthrax. Then B is for botulinum. So it's A, B, Amitabh Bachchan like. Anthrax, botulinum. After A and B, anthrax and botulinum, it's together two old disease, plague and smallpox. Those diseases which are almost gone, plague, smallpox. Then we have the two more disease which is by fruit bat origin, Ebola and Marburg. Kaun bola? Ebola and Marburg. But in Ebola and Marburg, we don't die by pneumonia. We die by internal bleeding. So that's why they are known as viral hemorrhagic fever. And last is tularemia. So these are total 7. You can remember it in 3 groups. First, anthrax, botulinum, AB. Then 2 diseases which are older, plague, smallpox. 2 which are viral hemorrhagic fever, Ebola and Marburg. And finally we have tularemia. तो कौन डिस्टर्ब कर रहा है फ्लो को? तुलारेमिया, यही भड़वा है ना. This is the one disturbing the flow, tularemia. Rest are in 3 group, A, B, anthrax, botulinum, Ebola, Marburg, plague, and of course smallpox. And last is tularemia. That 7 are category A. Do remember category A and C, Nipah, Hanta. But before moving ahead, एक चीज है जो मैं आपको बहुत ध्यान से समझाना चाह रहा हूं. मैटरनल मोर्टालिटी रेट, मैटरनल मोर्टालिटी रेशियो, वेरी इंपॉर्टेंट. अभी नीट पीजी में भी आ चुका है और इसका डिफरेंस हमें भूल जाते हैं. देखो बहुत आसान डिफरेंस. व्हेन वी टॉक अबाउट रेट एंड रेशियो, द डिनोमिनेटर इज डिफरेंट, रेस्ट ऑल आर सेम. बोथ आर मल्टीप्लाइड बाय 1 lakh, 10 to the power 5. Both are 10 to the power 5. The difference is When we see ratio, in the ratio, we write newborn, live birth as denominator. And in the rate, we write total female of reproductive age as denominator. Only the denominator differ. Numerator is same. In both, the numerator is maternal death. Okay? It's maternal death. Both maternal death. Maternal death. But what do you mean by maternal death? Based on this thing also they have asked. So I hope you know maternal death is something which occur within 42 days of delivery. If someone die within 6 weeks of delivery and the death is due to delivery related causes. If suppose I am a mother and as you can see, and I suddenly took my hand in this and I put it in and I died. Will you call it as maternal death? No. If I drown or I have accident, it's not maternal death. But suppose after delivery, everyone was just caring for the baby and I felt that they use my body for producing children and I went on the rooftop and jumped from there. Can you count it as maternal death? Yes, that's postpartum blues, postpartum depression. So when they give small numerical also on this topic, you have to remember that only those are maternal death which are due to delivery related causes like postpartum blues or PPH, most common cause of maternal death, or atonic uterus or some other reasons. Okay. So remember, in both rate and ratio, death is put above same thing. Rate have total female, ratio have live birth. But how to avoid confusion? Understand the concept and confusion will not be there. Ratio simply means numerator not a part of denominator. For example, when I gave you sex ratio, I did not give you sex, and I gave you the sex ratio. So in the sex ratio, ऊपर कौन रहता है? Who is above? Always female, है ना? And who is below? Male. Why? In one class I asked why. He said, sir, it feel better. I said, no, it's not about feeling. Female is above because only female can produce children. And male are just for time pass, remember. So female by male into 100, into 1000. Now tell me, does female has come from male? No, no. My mother did not came from me. Female has not came from male. They are just two separate things. That's why they are ratio. Similarly here, we write maternal death and live birth. Does maternal mother come from children? No, no. So that's why they are ratio. They are just two parts separate and we are comparing them like female and male. We are just comparing them. But rate means numerator is a part of denominator. Is a part of denominator. For example, here, all the mother who died, they must have come from the female who are of reproductive age group. Out of that female, only some have become mother and died. So when we write rate, it's female by female, maternal death by other mother. When we write ratio, then it's mother by live birth, and both multiplied by 1 lakh. Okay. So I hope you will remember it. Now, let's move ahead. With international health, we have discussed. We have also discussed the topic of different type of data representation. And now we are going to discuss the topic of some of the epidemiological concepts, which is very important. So the first epidemiological concepts which we are going to discuss is the Kaplan-Meier survival plot. Suppose after your MCI exam, you went to your home and a rascal relative or a harami neighbor came to your house and they said ki my father has went through stent and my father has went through heart attack and doctor has said either to go through stent or to go through bypass grafting of vein. I know, saphenous vein they usually take. So which one is better? Why this neighbor is rascal? Because he already know the answer. He has come not to know the answer, but just to check your knowledge. So you can say to your neighbor कि by looking at your face, I feel like pissing. मूत आई है तुम्हारे चेहरे को देखकर. Let me go to the washroom. Go to the washroom. Put your hand in the pocket and take out, no, not that, phone. And on the phone, type Kaplan-Meier survival plot between stent and bypass grafting. So if you will type it on Google, this type of image will come. What this image is showing on the y-axis, it is showing survival probability. What is the chance of survival? And they are comparing the survival probability of two surgery, stent and bypass. So what is the use of Kaplan-Meier curve? It gives us the big picture that which one is better, stent is better or bypass is better. And the one which is above, like stent is above, this above one is better intervention. Above one will have more survival probability. So above one have better surgery or better intervention. Okay, so this type of question has also came in INICT exam. They gave this three curve A, B, C, and they asked which one is better. So of course, this C1, which is above, is better. They use this type of discussion for cancer patient in US and UK. First one is just chemotherapy. Second one is chemo plus radio. Third one is chemo plus radio plus surgery. And of course, the third one has better survival probability. So they give the option to the patient and patient decide for themselves that, okay, C is better, so I will go for C. So this is the use of Kaplan-Meier curve. It helps the patient to decide which surgery is better, which intervention is better. Okay. And there are two type of Kaplan-Meier curve, Hall and Wellner and equal precision. When we draw Hall and Wellner, in one of the INICT exam, they ask which is not a Kaplan-Meier confidence band. So Hall and Wellner and equal precision are two names which you have to remember. These are two type of confidence band. What is confidence band? It's a very simple thing. See, when I say, let's say I am talking about survival probability of stent and bypass. At 3 years, survival probability is only, let's say, 30% by angioplasty, and it is, let's say, 70% by stent. 70% that they will survive after 3 years. But is 70% common for all of the people? If someone is doing surgery, after surgery, if someone is walking regularly and all, then their chance of survival will be, let's say, 80%. And if someone get bedridden, their chance of survival is only 60%. So survival probability always come in a range. And this range of survival probability is known as confidence band. Just remember the two names, equal precision, Hall and Wellner. When we have equal precision, the band will be equal throughout. And when we have Hall and Wellner, the band will be narrow earlier and then at the end it will become big. Okay. So Hall and Wellner and equal precision are two different confidence band. Remember the name. They will ask which is not a confidence band. They will give the option Hall and Wellner, equal precision, unequal precision. Unequal precision is not a band. Equal precision is a band. Okay. And this is Kaplan-Meier curve. Help us in comparing which surgery, which intervention is better. And it always have a step ladder pattern. Whenever there is a death, then it go down. So it always is like a step. So they can give image based question also from here. Very likely question because other concept they have asked. This is the only one concept left to be asked. It can come Kaplan-Meier curve. Now, this is tracking phenomena. Suppose I am comparing BP with age. So if you have low BP at early age, you have low BP at old age also. If you have high BP at early age, you have high BP at old age also. It look like BP is tracking you. BP पीछा कर रही है. BP is following you. So based on this, a question has came in both MCI and NEET exam that if you have taken a group of people BP and the people who have low BP at the beginning also have low BP at the end, which phenomena is this? That is tracking phenomena. Low BP at the beginning, low BP at the end. This is tracking. Okay, do remember. So very common tracking phenomena come. I hope you can do. Then from the rule of half, they have asked one question, that what does the innermost circle represent? Rule of half simply says that if half of the adult population have NCD, only half know about it. And the people who know, only half go through checkups and take treatment. And those who take treatment, even them don't have adequate control. Only half of the people who are on treatment have adequate control. So the last circle is saying half of treated patient having adequate control. So this was the question already asked in MCI exam, that what is the innermost circle represent? Innermost circle represent half of treated patient having adequate control, who have better control. That is the innermost circle. Then they have asked this question in NEET exam, that I hope you know, this is the iceberg phenomena, where the tip are those patients who are coming to hospital. Tip are hospital cases. But a real number of, high number of people are those who recover without going to hospital. They are known as subclinical case. They are the base. So, which disease? This was the question in NEET exam. Which of the following show maximum submerged portion of iceberg? In which of the following, if this is the iceberg, if one case go to hospital, 999 recover without symptom. If you recover without symptom, you are known as subclinical case. So if one case go to clinic, 999 recover without symptom, or recover without symptom, or recover without going to hospital. They recover without going to hospital. So they are known as subclinical. Subclinical का सीधा मतलब है जो क्लिनिक नहीं गए वो सबक्लिनिकल है. क्लिनिक में गए कम है, असली केस वो हैं जो क्लिनिक नहीं गए, सबक्लिनिकल है. So out of influenza, chickenpox, rabies, tetanus, which one has more people who recover without going to hospital? So I hope you know, in rabies and tetanus, no one can recover without going to hospital. Everyone will have symptom at some time. But in influenza, many people they recover without going to symptom. In chickenpox also, some can recover, but influenza has better hidden part. So hidden part is maximum in influenza. And remember, this hidden part is visible to epidemiologist, upper part is visible to clinician. Actually, this phenomena is made to glorify PSM people, that all you surgery medicine people, you see the tip. We PSM people see the base. But actually, it is also not true, because to see the base, we have to go door to door and do a screening test on those people who don't have symptom. And most of the PSM people like me also, we are not doing that work. So actually, no one see the base. But do remember this point, that there are 5 diseases where no one recover without symptom. These 5 diseases do not show iceberg phenomena, because in these 5 diseases, no one recover without symptom. Like rabies, I can remain hidden for 2-3 months without symptom, but ultimately I will develop symptom. And whenever I will develop symptom, my case will be reported in the hospital. So no one can recover without symptom in rabies, without symptom in tetanus, without symptom in measles. Mostly question come from this. Remember, these 3 diseases don't have subclinical case. Then other than these 3, you can have neonatal rubella, because Park has clearly written that rubella have subclinical case, but not if it is coming from mother to child. And the last is pertussis, because Park has written pertussis also do not have subclinical cases. So these 5 diseases don't show iceberg phenomena, because no one recover without showing symptom here. Okay. Chalo. Next is secular trend of disease. We just discussed. Secular trend is the one which is constant. And example of secular trend is represented by which diagram? It is represented by line diagram. Example of secular trend they ask again and again. It is cardiovascular disease, hypertension, diabetes. They all show secular trend. Then let's discuss the 3 types of outbreak. Remember one very important point. They will give you a real picture of outbreak, and they will ask which type of outbreak is it. So if it is point source epidemic, we call it common source single exposure. All cases occur in one incubation period. Almost all cases in one incubation period. Suddenly case rise, suddenly they fall. Example of point source epidemic or common source epidemic is Mostly food poisoning in hostel. But that food poisoning in hostel which is occurring in one incubation period will be the example of point source. देखो इंक्यूबेशन पीरियड आप शायद जानते ही होंगे, कीड़ा घुसा और पहली खांसी आई, उसके बीच का गैप बिटवीन एंट्री एंड फर्स्ट सिम्टम इज इंक्यूबेशन पीरियड. सो incubation period, let's say we are talking about hepatitis A. For hepatitis A is 10 to 50 day. Incubation period for cholera is 5 day. Incubation period for chicken pox is 10 to 21 day. And incubation period for measles is 10 to 14 day. ये चार आप जान जाओ तो आपके मोस्ट ऑफ द क्वेश्चन बन जाएंगे. 10 to 14 day. तो समझो, if there is a outbreak of cholera and all cases occur within 5 day, here it's 1 day and here it's 5 day, within 5 day or case, we call it point source common source single exposure or point source epidemic. But if the time taking in occurrence of cases is more than 5 day in cholera, suppose the cases keep occurring in 10-20 day, then we don't call it common source single exposure or point source, then we call it common source continuous exposure. So remember, continuous in exposure means time within which case occur is more than one incubation period. अगर समय एक इंक्यूबेशन पीरियड से ज्यादा लग रहा है, कॉलरा में 5 दिन की जगह 10 दिन लग रहा है, तब वो है कॉमन सोर्स कंटिन्यूअस. अगर 5 दिन के अंदर हो गया तो कॉमन सोर्स सिंगल एक्सपोजर पॉइंट सोर्स. 5 दिन से ज्यादा लगा, इंक्यूबेशन पीरियड से ज्यादा लगा, तो कॉमन सोर्स कंटिन्यूअस. If the time period of occurrence of cases is more than one incubation period, only then you will answer common source continuous exposure. And there is a very common example of common source continuous which they ask: milkman distributing contaminated milk to villager. देखो milkman क्या कर रहा है? He is using one tap with contaminated water, and with the same water he give milk to all the villager again and again. So what is happening? Source is common, but infection is occurring again and again over a month or more than one incubation period. So if cases occurring more than one incubation period, that is continuous exposure. Other example of continuous exposure is contaminated batch of polio vaccine. The whole batch is contaminated, so infection keep on occurring for longer period of time. One more example is sex worker like me transmitting gonorrhea and HIV to other client. So same common source, but exposure occur again and again. One more example is typhoid Mary, and she was a chronic carrier. And where do chronic carrier of typhoid store the bacteria? They store it in gallbladder. So from gallbladder it go to food, and from food out from intestine. And she was a cook, and she was giving delicious full flavored food, yellow sandwich, yellow burger, and people were dying. But it was just because she was a chronic carrier and she was not washing her hand. Okay, so remember this 4 example of continuous exposure. The last type of epidemic is propagated. Propagated epidemic, we call it only when there is a secondary wave of case. Secondary wave से कुछ याद आया? Corona? Yes. So whenever there is a secondary wave of case which is bigger than the primary wave, then it is propagated. And propagated epidemics are like, of course, COVID, SARS, MERS, all these respiratory infections can be under it. And SARS, MERS, all of these are example of disease which origin is fruit bat. Okay, SARS, of course, I hope you know, SARS occur in cat from fruit bat, and then from cat, civet cat, it go to human. Then MERS is something which occur in camel, but origin is here also fruit bat. And then Middle East respiratory syndrome from camel to human. Okay, like that. So remember, if it is secondary wave propagated, more than one incubation period continuous, less than one incubation period point source. Example of point source can also be Bhopal gas tragedy and all. Okay. Now let's come to this very confusing topic, level of prevention, which we think we know, but we still do mistake. My question to all of you is, if I talk about refractive error glasses, this refractive error glasses, will it be example of primordial, primary, secondary or tertiary level of prevention. Which level of prevention? So do remember this point. Primordial, primary is before disease. And someone is wearing glasses, it means some refractive error is already there. So it can be either secondary or tertiary. Now secondary is early diagnosis and treatment. And tell me, is refractive error glass doing the treatment? No. Treatment is LASIK surgery. So if it is LASIK surgery, that will be example of secondary prevention. But when we wear refractive error glass is something which will make us self-dependent. Rehabilitation means making us self-dependent. And it is limiting our disability. So remember, refractive error glass is tertiary level of prevention. Similarly, if I say hearing aid, Kanthappi, all old age people, whatever you say, they reply by one word. So this hearing aid is definitely tertiary. But at the same time, if I say cochlear implant is the treatment. So that will be secondary. Okay. So if I say anything like physiotherapy, wheelchair and all, that will be tertiary. But there is a very good question on this topic of disability limitation also. Cleaning foot of filariasis patient. They will give an image also of cleaning foot of filariasis patient. And they ask which level of prevention is this? So that is limiting the disability of that patient. They all are tertiary level. Secondary level is all kind of treatment and all screening tests. To remember, no matter on which people we are doing that. But if we are doing a screening test is always done for early diagnosis. And therefore, all screening tests are secondary. All screening tests are secondary. So if I write BP of a child, which level of prevention is it? People answer primordial, primary. No. In a child also, BP can be raised due to nephrotic syndrome, or let's say he is on steroid treatment for asthma or nephrotic syndrome, or horseshoe kidney, and any malformation is there. So if I am taking BP of a child, purpose is always to find early diagnosis of hidden hypertension. So no matter whose BP I am taking, it is always secondary level. Okay. If I took a hemiparesis father for checkup, do tell me, which level of prevention will it be? Hemiparesis father for checkup. Reply, please, in the group. Hemiparesis father for checkup. Which level of prevention? For checkup, I took hemiparesis father. Which level of prevention? If I say hemiparesis father for physiotherapy, now what will you answer? Physiotherapy is tertiary. But when I am taking hemiparesis father for checkup has only one purpose: to make an early diagnosis of second attack of hemiparesis, or to know whether the treatment of hypertension is adequate or not, BP is under control or not. So checkup, wherever they write, this means they are doing some early diagnosis. This is secondary. If I write physiotherapy, it will be tertiary. But if I write checkup, it will be secondary. Okay, yes, very good. Chandra, you are correct here in answering. Gauri Saha is still with me, and C is also correct, secondary. Now, primordial, primary is very simple to understand. If you are preparing for MCI exam from your second year of MBBS, third year of MBBS, you are primordial, because you are doing the preparation without any risk of failure. Fail you will occur when you will give it after clearing MBBS. So if you are preparing from second, third year, you are preparing when the risk of failure was absent. Risk is in future, but you are preparing. So that is primordial. And if you are preparing in your final year internship, that is primary, because here the risk of failure is present and then you are preparing, it is primary. So under primordial, you have example like all the example of health education, Muft ka Gyan, and then other than health education, all this meditation, yoga, Indian diet, all of it is primordial. Okay. And what is primary? I need not to tell. Primary can be a lot of things, like isolation is primary, quarantine is primary, primary has a lot of things, but do remember all example of primary are better written as specific prevention. Why it's better written as specific prevention? Because they all primary are for specific disease, but there is one exception, except hand wash. Because hand wash we do when the risk is there, and hand wash is not specific. It can be done for many reasons. So hand wash is something which is not specific, but all primary are specific. Example can be, let's say I am talking about helmet. From helmet I remembered condom, है ना? है क्या कोई क्लास में ऐसा जो कॉन्डम पहन के मेरी क्लास सुन रहा है? Anyone in the class listening with a condom ready? No, na. You cannot wear a condom and listen to PSM class because there is no risk of having sex in the class listening PSM. But you can wear condom just before sex because then the risk is there. So do remember, condom, helmet, all of these are done when the risk is present. No one sit in the class wearing helmet. You sit in bike wearing helmet. So helmet, condom, they all are done when risk present. Risk present means primary. But very good common example they ask is anemia mukt Bharat. Then minus desk in school program which prevent from backache. That is also specific. Then they say isolation and quarantine. That is also secondary. Okay. So all of these are secondary. Isolation, quarantine. Now, if you see, do remember this point, very important, because I took out the topic of isolation, quarantine. It's very important to differentiate. Quarantine is done on healthy people. And till which time we do quarantine? We do quarantine done till maximum incubation period. इसको समझो, बहुत आसान है समझना. जैसे मान लो me and my friend Nikhil, we are in Uzbekistan, we were living together in a room. And suppose I develop chicken pox. So I am a person with disease. Isolation is done in the person who will be diseased. You will isolate me, person with disease. Till which time you will isolate me? Till I can infect other. So what is the timing of doing isolation? It is done till period of infectivity. Till there is period of infectivity, till I can infect other, we will do isolation. And in case of, suppose I developed chicken pox. So in case of chicken pox, isolation period is 6 days. For 6 days, you will keep me separate. But Nikhil, who is living with me, he look healthy, but he can be carrying a hidden chicken pox virus. So he will be quarantined healthy people. Until what time Nikhil will be quarantined? Till the time appearance of symptom, maximum time for appearance of symptom go away. And in case of chicken pox, the maximum time of appearance of symptom is 21 days. So 21 day, 10 to 21 day is the incubation period, and maximum incubation period is 21 day. So for how long you will be quarantined? Nikhil will be quarantined 21 days. This was NEET 2024 question. Quarantine is done till which period? Till maximum incubation period. Okay. So this is the thing between isolation and quarantine. I hope you understood, and all of them are primary, because the purpose of isolating me is to help those who are at risk of getting infected. So here also isolation is done to help other, not to help the patient. And it is helping those who are at risk. So when we do prevention for at-risk population, this is known as isolation. Okay. So I hope this part is clear: primordial, primary, secondary, tertiary. But there is what is specific protection? This is not a level of prevention. This is a method of prevention. And there are two methods of prevention actually: health promotion, specific protection. Specific protection, I already tell that all example of primary prevention better written as specific prevention. What is health promotion? Health promotion example is breastfeeding. One more example can be mother and child attachment. This question has come, that mother and child attach linkage. is example of which thing? This is example of health promotion. What is health promotion? Basically, health promotion means primordial, primary, both. So imagine me as a lactating mother. Okay, done it? Very good. Now I am breastfeeding my kid. Oh, ale. So this breastfeeding is protecting my kid from future risk of diabetes. Future risk means primordial. Now suppose I am again breastfeeding, but of course every 2 hours we have to change and breastfeed for minimum 20 minutes one side. So I'm again breastfeeding. Ale. Why I'm hitting? Because he's biting my nipple. So this time my breastfeeding protect my child from present risk of malnutrition. If I did not breastfeed, my child will be malnourished today. This is primary. When the risk is present today, this is primary. When the risk is in future, primordial. And when I mix both, primordial, primary, both, it become health promotion. So remember, breastfeeding is both primordial and primary. That's why breastfeeding is example of health promotion. Okay. I still remember the kid of my younger sister, Riddhi. Her birthday is today. And whenever I used to take her in my lap, she used to turn my t-shirt down. कि मामा रखे तो तुम भी वो पिला नहीं रहे हो ना कि mother's brother, you also have the milk, but you are not giving it to me. क्या बताऊं, only hair will come, nothing will come. But she used to think that something will come up. She torn 2 of my t-shirt because of that. But I hope you'll remember. Health promotion is breastfeeding, mother-child linkage. Specific prevention, all example of primary are written as specific. Then there is one concept of DIDH, stages of disease. Disease, impairment, handicap, disease, impairment, disability, handicap, DIDH. What do we mean by that? See, hemiparesis is an example of impairment or disability. Hemiparesis is where? Impairment, disability. Please answer. Where will you put hemiparesis? Impairment or disability? Always remember, handicap means person has become financially dependent on other, that is lost job. So lost job is always handicap. Disease is hypertension. Due to hypertension, patient cannot move half of the body. So there is loss of body part or loss of body power. That is impairment. Hemiparesis is an impairment. And disability means loss of function. Due to hemiparesis, patient can't walk properly or can't do some other work. These are disability. So always remember, impairment means loss of body part or power. Disability means loss of function. Like for example, let's take one more example. If I'm talking about, let's say, leprosy. In leprosy, you can amputate leg, cut leg, or diabetes also, you can amputate leg. So amputating leg is impairment. Due to amputing that leg, patient can't walk. So can't walk is the disability, and patient lost job, that is the handicap. So I hope you will remember disease, impairment, disability, handicap. Disability when you can't do something, and impairment when there is loss of body part or power. Okay. Thank you, Rudraksh, for replying. I hope you will remember DIDH. If you may need more example, I can tell you with more example also. Last concept which we should definitely discuss here is PQLI and HDI. Two question in NEET PG 2024 from the same topic, PQLI, HDI. And see, such simple thing it is actually. It's very simple actually. PQLI, you can see it's 4 letter, bigger. And HDI is 3 letter, smaller. So because PQLI is bigger, the range is bigger, 0 to 100. And because PQLI is bigger, so we have life expectancy at 1 year, big child life expectancy. But HDI is smaller, so range is also small, 0 to 1. And life expectancy is also small at birth. So this is one point, but see how simple it is actually. Very simple. When I write PQLI, can I write it as L1? So in PQLI, we have life expectancy at 1 year. L1, L1, Li. Second, when I write PQ LI, here L is for literacy rate and I is for infant mortality rate. So with the full form of PQLI, you can remember what are there. First thing, it is big, so range 0 to 100. LI, L1, L for literacy rate, I for infant mortality rate. Done. Okay, all the three things done. Now, when it comes to HDI, HDI is something which we measure for highly developed country. That's why HD. And PQLI for poor country. So, in highly developed, we will not measure literacy rate, we will measure mean year of schooling. In UK, बच्चा इंग्लिश बोल रहा है ना, in UK when the child is speaking English, so we will not measure literacy rate, we will measure mean year of schooling. Second point, in Russia and all, measuring per capita income matter, but per capita income do not matter for India, poor country. Why? Because you must be knowing the Oxfam report, global financial report, that 90% of India wealth is in 2% of population, and remaining all of us 98% Indian are living in that 10% remaining money. 2% Indian have 90% wealth. So if you include that 2% Indian, per capita income is good. But if you remove that 2% income, 2% population which has 90% of India income, then our per capita income will go down. So when Modi says ki Gujarat per capita income is increasing, it's actually not Gujarat per capita income, it's Adani Ambani income which is increasing. And if you take average, it will look like whole Gujarat people are getting the money, but it's actually not the case. You understand the point? If you remove that 2%, per capita income is something which is very bad for India. If you remove that 2%. So per capita do not matter for poor country. We use it for highly developed. For poor country, we measure infant mortality rate. Why? Because infant mortality rate is the best indicator of effectiveness and quality of health system. This was the question being asked in NEET exam 2023, that which is the best indicator of accessibility and affordability of health system. देखो, अगर गांव में अस्पताल दूर दूर होंगे, या आदिवासी इलाकों में आपने देखा होगा कई बार उनको कंबल में करके ले जा रहे हैं, खटिए पे करके ले जा रहे हैं, तो मां बीच रास्ते में मर जाएगी. तो अगर अस्पताल एक्सेसिबल नहीं होगा, आसपास नहीं होगा, तो इन्फेंट मोर्टालिटी रेट हाई होगा. अगर सरकारी अस्पताल मुफ्त नहीं होंगे तो लोग घर में डिलीवरी कराएंगे तो ज्यादा मौत हो जाएगी, तो अफोर्डेबल भी नहीं होगा तो हाई इन्फेंट मोर्टालिटी रेट होगा. What I was saying is, if the hospital is not nearby, not accessible, mother can die or children can die, IMR will be high. If the government hospital is not there, then delivery will occur at home and more infant death will be there. So accessibility and affordability, if they are there, IMR will be less. If there is more accessibility, more affordability, then IMR will be less. If accessibility, affordability will be less, IMR will be high. So IMR tell effectiveness of health system, accessibility, affordability. IMR also tell impact of ASA work. And it also indicate female condition in the country. But best indicator of female condition in the country, female condition best indicated by perinatal mortality. Because when we write perinatal mortality rate for a country like India, then formula is different as the formula for USA. When we write perinatal mortality, always remember, in all this mortality rate, perinatal, neonatal, infant and everything, two things are common. We always multiply by 1000. This is common for all of them. And we always write total live birth as denominator. Only thing that differ is the numerator. Numerator is the duration. And perinatal, peri का मतलब होता है चारों तरफ. Natal means birth. Perinatal means around the birth, around delivery. So when we write perinatal, it includes two parts. One is those who die stillbirth, plus those who die in first 7 days, death in 7 days, first 7 days. If you add both of it, then it becomes perinatal mortality. So perinatal is best for female condition because it tells both the thing, early neonatal death as well as still death. Why are we not using maternal death as an indicator? Because mother don't die so easily. If hospital are good, by referral we can save. But if mother is not healthy, she will unable to put the baby in her uterus for 37 weeks. And if delivery occur before 37 weeks, we call it premature delivery, and premature delivery is the most common reason of infant death, low birth weight or premature delivery, which occur before 37 week. So if delivery is occurring before 37 week, it is indicating that female condition is not so good. Okay, so do remember, perinatal mortality rate is the one thing which tell best about female condition, and which tell best about health system of India, infant mortality, which tell best whether ASA is doing work or not, infant mortality rate. So IMR is the one which we get in PQLI. PQLI, remember PQLI has what thing? PQLI, literacy rate, infant mortality rate. L for literacy, I for infant mortality. And then L1 is life expectancy at 1 year. So which is the best socio-economic indicator? PQLI. Why PQLI is better? Because it has IMR. And what is the best indicator of quality of life? Quality of life is best by HDI, because HDI tell per capita income. So quality of life is best by HDI, but best socio-economic indicator of a country is PQLI, because it tell whether the people have good social equality or not. Like they have, Park has given the example that all the Gulf country, their HDI is high, but because in those country infant death is still high, so their PQLI is low. That's why PQLI is better to use if we want to know whether country is socio-economically developed or not. Okay, chalo. The next two concept is mortality and morbidity indicator. So there is one thing, potential year of life lost. What does that mean? It means life lost due to premature death. This is PYLL, potential year of life lost. And there's a very simple example. Indian life expectancy is 70 years. So if any Indian died at 62 years, he lost 8 years of healthy life. So that is potential year of life lost will be 8 years. Simple thing. Then what is DALY? Very frequently asked question. DALY has two factors. One is how many life you lost due to early death, plus how many life you lived with problem. There is two things in DALY. How many early you died, how many year you have lived with problem. And let's take an example. Indian lived till 62 years. What was the expectation? How much year he was expected to live? 70. But he died at 62 years. And last 10 years he had hemiparesis. So what is the DALY? Remember, DALY has two components. Year of life lost due to early death, plus year of life lived with disability. So this is the two component. How many year of life you lost, how many year you lived with disability. So how many year he lost? 70 minus 62, 8 year is the time which this man lost. And how many he lived with problem? He lived 10 year with problem. So what is the total DALY? Total DALY will be 18 year. Remember, DALY has two components: life lived with problem, and life lost due to early death. Okay, two problem, combine DALY. Then the third thing is Sullivan index. What is Sullivan index? Sullivan index means life expectancy minus DALY. Like very simple thing is, the previous example was actually the example of my own father. When I was in second year of MBBS, he had hemiparesis. Then for next 10 years, he suffered and then he died. So in case of my father, how many times he was healthy, that is what Sullivan index tell. What does Sullivan index tell? Sullivan index tell life lived without problem, without disability. How many year was without problem? So my father died at 62, 10 year of hemiparesis, and he had attack at 52 year. So till 52 year, he was healthy without problem. So what is the Sullivan index for my father? 52 year, because till 52 year, he was without problem. How you found the 52 year? Simple thing. What is the life expectancy of Indian? 70 year. What was the DALY for my father, which we calculated in the last example? 18 year. So 70 minus 18, it will come 52 year. So Sullivan index is just the opposite of DALY. DALY tell how many time you suffered. Sullivan index tell how many time you were without problem. Okay. And even by remembering my father death, I'm not so sad. Why? Because being a father myself, I know that all the parents, they just want our happiness. They are forcing you for the exam because they think after clearing exam, you will be happy. And so don't go by their word. Their word can be wrong. Try to see what is in their heart. In their heart, they just want your happiness. So be happy, and you are fulfilling their main wish. So what is quali? Quali is quality life added due to an intervention. Like Park has written that dialysis add 0.5 quali in life of patient. So what is the use of quali? Suppose you want to get some fund for opening dialysis center in your city. You can say that, sir, in our city, 1 lakh patient have dialysis need. And if we open a dialysis center, 1 lakh into 0.5, that means we can gift them with 50,000 quality year. So quali tell us that due to some intervention, how much we can help the people. Okay. Now let's do this very interesting question on this. Japanese government, and whenever Japan came, do not answer directly the answer which I am giving. Japan has a lot of questions from Japan word. So don't just mug up, try to understand what is in the topic. Japanese government are doing many intervention to have healthy aging and increasing life expectancy. It is example of which thing? It is example of two things. First, it is example of quali. Whenever you do some intervention to improve people life, this is quali. And it is also example of longevity dividend. समझो बिडू लोग, क्या है longevity dividend? देखो, ये नीट का क्वेश्चन आया हुआ. अगर बुढ़ाऊ लोगों को हम लोग अच्छा हेल्थ फैसिलिटी दें शुरू से, तो बुढ़ापे में बीमार कम पड़ेंगे, देश पे बोझ कम पड़ेंगे. दूसरा, वो बुढ़ापे में भी कमाई कर सकते हैं, तो देश को एक्स्ट्रा बोनस मिल जाएगा. उनके जिंदा रहने से हेल्दी तरीके से देश को फायदा है, बोनस है. इसी को कहते हैं लॉन्गिविटी बोनस. बोनस मतलब डिविडेंड. What I was saying in Hindi was that in old age, if we give them good health facility, first, they will not have more illness. Second, they can earn some money also for the country. So they will be like a bonus for the country, and we call it longevity dividend. So what is longevity dividend? Longevity dividend means giving old age people healthy aging and increasing their life expectancy will act as a bonus for the country. We call it longevity dividend. Okay. And whenever you do some intervention to help their life prolongation, it is quali. So I hope this concept of morbidity means when they suffer, those indicators are clear. Now let's talk about mortality, death. So first thing is death is crude death rate. I already discussed this topic, that in crude death rate, we multiply total death by mid-year population into 1000, not by 100. We multiply by 1000. And when does we measure it? We measure it in the mid-year population is measured on 1st of July. तो आपके 1000 दोस्तों में से इस साल कितने मर जाएंगे? Out of your 1000 friends, how many will die in this year? That how many will die this year? When I ask this question, generally student answers, sir, one, this one. They have targeted someone. But for an Indian population, it is 7.2 per 1000. But your age is a young age. ये जो 7.2 आया है ना, ये पूरे बूढ़े जवान सबका एवरेज लेकर आया है. और ज्यादातर लोग बुढ़ापे में मरते हैं या जिंदगी के पहले दिन मर जाते हैं. तो पूरे इंडियन का एवरेज 7.2 है. लेकिन आपके उम्र जो कि 20 से 25 साल, 25 से 30 साल, 30 से 35 साल हो सकती है, इस 20 से लेके 35 साल के हर 5-5 साल में 1000 में से सिर्फ 2 लोग मरते हैं. तो जो आपकी उम्र का डेथ रेट है, उसको हम लोग कहते हैं एज स्पेसिफिक मोर्टालिटी रेट. आई एम रिपीटिंग इट अगेन. Crude death rate is measured for all Indian, and in all Indian we have many young first day people who die and many old age die. So then the crude average comes 7.2. But if I ask how many people will die in your age being either 20 to 25 year or 25 to 30 year or 30 to 35 year, in all this 5 year age group, only 2 deaths occur out of 1000. 2 deaths per 1,000 population. And this is known as age-specific death rate. What is age-specific death rate? Total death in your 5-year population by total 5-year population of your age. In this, only 2 people will die out of 1,000. So age-specific death rate is 2 for your age. And we know it for India. In India, in any 5-year age group, how many people die, we know. So that is why India population is standardized. India or country population is standardized. बात समझ रहे हो स्टैंडर्डाइज्ड का मतलब? स्टैंडर्डाइज्ड मींस एज स्पेसिफिक मोर्टालिटी रेट इज नोन. अगर हमें पता हो कि किसी भी 5 साल के एज ग्रुप में कितने लोग मरेंगे, तो ऐसी पॉपुलेशन को स्टैंडर्ड पॉपुलेशन कहते हैं. हम लोग बात भी करते हैं ना, किसी बंदी को जाते देख के कि ये बंदी बड़ी स्टैंडर्ड है या ये बंदा बड़ा स्टैंडर्ड है. क्या मतलब वो स्टैंडर्ड बंदे बंदी का? स्टैंडर्ड बंदी बंदा वो है जिसके बारे में हम कुछ बता सकते हैं, है ना, कि ये अच्छा सलीके से रहेगा, रहेगी, बीच बीच में हक दिया, पात दिया, मुद दिया, ऐसे नहीं बोलेगा. तो स्टैंडर्ड मींस हमें कुछ पता है. तो भारत की जनता के बारे में हमें पता है कि हर 5 साल में कितने लोग मरेंगे. हमें पता है एज स्पेसिफिक मोर्टेलिटी रेट भारत का क्या है. इसलिए भारत की जनता स्टैंडर्डाइज्ड पॉपुलेशन है. कोई भी देश की जनता स्टैंडर्डाइज्ड है क्योंकि उसके बारे में पता है कि हर 5 साल में कितने लोग मरेंगे. व्हाट आई वाज सेइंग इन हिंदी वाज कि when we say some girl or some boy is standard, it means he is educated and we know something about him. Similarly, when we say the country population is standardized, it means we know that in that country, in any 5-year age group, how many people will die. So that population becomes standard because we know something about it. And like for India country, it is standard because we know in India how many people will die in any 5-year age group. Similarly, Japanese government population is also, Japan country is also standardized because we know in any country what is the age specific mortality rate. So that is standardized. Okay. Now, the last thing is 2 type of standardization, direct and indirect standardization. So first thing, suppose go back in time, you are in class 2. Let's say I'm talking about my friend Gauri Saha. Gauri, you are in class 2. Half pant, full pant. If it will be Chandra, it will be much better example, hai na? Because then I will ask half pant or no pant. So let's say it is Gauri who is in class 2 wearing half pant, or Chandra and Gauri both were in class 2. They were together also dating from that time. And they both are in class 2. And they saw one boy and girl of 12th class going together. They said, oh, what a nice brother-sister couple. And the boy of 12th class, he got angry. He said, meet me outside. I will make your mother sister one. Come. So Gauri and Chandra, you tell me, will you go alone and fight with this 12th class person, or will you take help of your friend and fight indirectly? Of course, if you are intelligent, you will take help of your friend and throw a stone from backside. You will fight indirectly because you are 2 class and he's 12th class. So you will fight indirectly. Small with large indirectly. But now suppose Gauri and Chandra, you are in class 12th, and suppose Chandra had fight with a class 12th boy. The reason you know, na? Same reason. So now Chandra, will you take help of your friend or will you hit directly? Of course, now Chandra can hit directly only, because 12th and 12th can fight directly. So similar thing you have to remember for direct and indirect standardization. When we do direct standardization, we are comparing 12th class with 12th class. One country like India population with Japan population. So they both are standardized. We know about them. We can compare them. So let's say we are comparing India and Japan in terms of crude death rate. Crude death rate of India is 7.2, but crude death rate of Japan is 11.1. So if you compare the crude death rate, it feels like that Japan should learn from India. Where our country only 7 are dying, their country 11 are dying. Their health is poor. Japan is very poor. But is it the real picture? Of course not. Why Japan has more death? Because there is more old age population, more than 25%. And in India, only 8% are old age. So if we compare crude death rate, we get wrong data. How we can compare India and Japan? we can calculate the age specific death rate of 0 to 5 year Indian, 5 to 10 year, 10 to 15 year, each 5 year we can count till 60 year. And we will find that age specific death rate for 0 to 60 year Indian is 5 per 1000. Similarly, for Japan, we will calculate age specific death rate for 0 to 5, 5 to 10 like that till 60. And there we will find only 2 death occur out of 1000. So then we will get the correct interpretation that India should learn from Japan. Okay, so what is direct standardization? In direct standardization, we compare age specific mortality or death rate of two large standardized population. We are comparing age specific death rate of India with Japan. This is direct standardization. Comparing age specific death rate of 12th class with 12th class, two large standardized country. Okay. Now suppose, let's learn what is indirect standardization. Suppose uh, okay. Chandra is saying we will fight direct. Very powerful. Gauri is saying I will be with her, sir. Okay. Okay. Gauri Saha is also, I'm anyway. So Chandra is saying girl power. Okay. My point is that uh, let's talk about one more example. Suppose this time let's talk about Jessica. Suppose Dr. Jessica, I don't know where are you from. Suppose you are from Kerala, let's say. And she thought, no, in Kerala there are very less street children asking for money, but she found some children who are working in firecracker factories in Kerala. So she thought all these children who are working in firecracker factory, if any firecracker burn, the whole country, the whole factory will burn and they will also die. So the death is very high for those children who are working in firecracker factory. Why not help them? Why not make government pass a law which will stop it? Plus, in every hospital there should be ward for single children who come for hospital treatment. So now she need fund to help the children who are working in street and making firecracker factories. So what she can do, Dr. Jessica can do is, she can call all the hospital of Kerala and she can ask how many children of 10 to 15 years died in your hospital. So what she is doing is, she is calling all the hospitals, she is observing the death. Pata laga rahi hain Dr. Jessica. She is detecting it, she is observing it. So observed death, what is observed death? It is something which you collect the data. So what observed death do you think will occur in street children and firecracker factory? Out of 1000, 10 to 15 year street children, what do you think? How many will die in a year? How many will die in a year? Any number, Dr. Jessica, or anyone can answer? How many will die in a year? This is observed death because you have found it. Then you can compare it with the expected death. Compare it with the expected death. Expected death means national data. And we know that out of 1000, 10 to 15 year normal Indian who are living at home, not working in firecracker factory and all, in them 3 death occur. Normal children 3 die per 1000. So what is the expected death? 3. What is the observed death which you observe after calling all the hospital? Chandra is from Kerala. Okay. So Chandra, you can give me the data. How much you observed after calling? After calling, he found that, let's say, out of street children, 30 die in a year out of 1000. Who are between 10 to 15 years, out of them, 30 die out of 1000. So observed death is 30 per 1000. Expected death is 3 per 1000. And we multiplied by 100. This gives us standardized mortality rate. They ask the formula again and again. What is the formula of standardized mortality rate? Observed death by expected death into 100. Observed by expected into 100. So when you will compare it, you can see it. Observed death was 30, expected death was 3 into 100. So it will come 10 into 100 or 1000. So with this data, Dr. Chandra or Dr. Jessica can go to the health minister and can ask, sir, give us some fund to help street children, because in them the standardized mortality rate is 1000 as compared to the expected death of Indian children. So what is the use of indirect standardization? Indirect standardization is like 2 class fighting with 12th class. Unequal, indirect. 2 class are all the street children, very less population. And 12th class are all the national data, very big population. So we know a lot of thing about the national data. We know the expected death. We have to collect the data of observed death. And when we compare them, we can get fund for such population who are oppressed, who are having high death rate. So what is indirect standardization? It is used to compare observed death of a small non-standardized population like a street children population with expected death of a large standardized population like national data. And by comparing them, we get the data, and thus we can convince the government in giving us more fund to help them. Okay. So this is indirect standardization, and that was direct standardization. I hope both is clear. And this is the concepts which I was willing to discuss from epidemiological concept part. Now let's discuss some top question of vaccination also before ending this session. 15-minute more, then I will end this session. So in the vaccine, one part is with the diluent. The diluent with BCG, they ask again and again, is normal saline. The diluent with MR is sterile water. And the diluent with J is phosphate buffer solution. Now the question is, how will you remember it under exam pressure? कैसे याद करोगे? बहुत आसान है. BCG, we give BCG at birth. And what is the dose of BCG which we give? 0.05 ml intradermal left side. तो ऐसे याद करो कि जैसे ही बच्चा पैदा होता है, हम उसकी जिंदगी थोड़ी नमकीन बनाने की कोशिश करते हैं, इसलिए उसको नॉर्मल सलाइन दे देते हैं, ना, नमक, जिंदगी में नमक लाना चाहते हैं, ना, नमकीन बनाना चाहते हैं. As soon as the child is born, we try to make the life of child a bit salty. So we give normal saline with BCG at birth. Okay, clear? BCG normal saline. 2 times asked. Then M is for MR. M is also for mother. And which type of love is mother love? Mother love is like sterile distilled water. No matter how much your mother is angry, just press her leg for 10 minutes. She will melt like ice cream. So mother love is sterile water. Simple. And if you write JE, the full form of JE have Japanese. So it itself has right P for phosphate buffer solution in JE. Okay. So this is one thing, very simple to remember. Second thing is, they ask the question from the root of MR and JE. Both MR and JE, the vaccine type which we give is live. Both are live vaccine. The JE which we use in India for Japanese encephalitis, the strain is SA1414 2 bar. SA1414-2 live strain we use in India. Killed one is in Canada, UK and all, not in India. In India, live JE virus vaccine we give. And both live vaccine MR-JE given by subcutaneous route. Okay. So now the question is, which one is given? Both are given 0.5 ml. Which one is given on right side, which one on left side? Again, we will use the same trick. M for MR, and remember, mother love is always right. So when we give MR, we give right side subcutaneously. And when we give JE, Japanese encephalitis, JE given left side subcutaneously. So remember this, 2 vaccine given subcutaneously. MR, mother love, right side, diluent distilled water. JE, Japanese for encephalitis, left side, diluent phosphate buffer solution. Okay, simple. Chalo, next question. So this we have already shown the image of international health. SIDA is for sputum. S for SIDA, S for sputum. So fund TB program. Derrida was DAN, eye program. We discussed this data representation already. Oh, so we have discussed this part already. This vaccination part is something which I wanted to discuss, but I don't know where the slides have been gone. I think I have mixed it, but I will come back. Yes, this is the vaccination part. See, I found it. Yes, this is the part. So, first we know the diluent, and now let's talk about the routes also. Let's discuss all the routes of various vaccine first, because we have discussed this the subcutaneous route. That in the subcutaneous route you have MR on the right side and JE on the left side. Now, intradermal we give two vaccine, BCG and FIPV, not FUCT IPV, fractioned IPV. FIPV 0.1 ml, BCG as I said at birth we give 0.05 ml, 0.05 ml at birth. So which one is left, which one is right? We all know BCG is left. And when we give BCG left side intradermally, then it develop abscess in 2 weeks, then ulcer in 4 and scar in 6. 2, 4, 6 abscess, ulcer, scar. So left side is busy. Therefore, we use the right side to give FIPV. FIPV is right side, BCG left side. Oral route, of course, we give rotavirus oral, then we give OPV oral, then we give typho oral also as oral. And remember, all oral route vaccine are live because they have to go to the intestine and multiply. So they all are live. And when we give typho oral, we give it on 1, 3, 5th day. Day 1, 3 and 5 we use for giving typho oral vaccine. Intramuscular route is remaining all vaccine are intramuscular. So we need not remember intramuscular. Just focus intradermal, subcutaneous, oral. One last thing is, which vaccine is given by nasal drop? Can you answer? Can anybody answer? Nasal route or nasal drop is used for which vaccine? Anyone? Nasal drop, which vaccine? Nasal drop is influenza live vaccine. Only this is by nasal drop, influenza live vaccine. Okay, so we know all the route. Now, let's talk about tetanus also, because this is one question which they keep asking, and the tetanus part is something which we read, but then we forget also. So let's talk about tetanus first. First thing in tetanus, you have to ask the question कि last DT or TT कब लिया था, last DT or DT taken. So answer can be 4-way. First is last DT TT taken less than 5 years. Second is 5 to 10 years. If any of these two is the answer, less than 5 years, 5 to 10 years, it doesn't matter which type of wound is there. Dirty, clean, doesn't matter. There is one difference. There is one difference. If it is less than 5 years, we always just do one thing, wash. Only wash, no tetanus give. If it is 5 to 10 years, then we give one TT preferably, or DT also we can give, but better is DT. This remains same, whether it's a clean wound, dirty wound, does not matter. Okay, but remember, whatever they teach in surgery, that if it is a dirty wound, give tetanus, they are teaching you the practical point and they are correct. But do not write it in the exam. In exam, if tetanus has taken in last 5 years, we only wash, don't give tetanus, because this immunity is already there from the last dose. So why to repeat it? Now, after this two answer, the third answer can be last DTTT taken more than 10 years back. More should be there. If they say just 10 years, answer will be 1 DTTT. But if they use the word more than, only then you will go to the third thing. More than 10 years. Or they can say the last word, forgotten. Bhoola. So if more than 10 year or forgotten, then the treatment differ for clean wound and dirty wound. If it is clean, less than 6 hour patient came to you, non-lacerated, non-penetrating, not dirty, then we give TT, 1 TT, that's all, 1 TT. More than 10 year, TT, simple. Clean wound, nothing to worry, 1 TT. But if it is more than 10 year and it's not clean, it's dirty. Dirty, we do not write, we just write other category. So if it is any other category, along with TT, we give tetanus immunoglobulin. So remember, tetanus immunoglobulin is only for dirty category of wound, not for clean ever. Now let's talk about forgotten. Bhoola. If it is forgotten, this time we will इतना घोपेंगे कि भूल जाएगा कि पादे कहाँ से और सांस ले कहाँ से, है ना? If it is forgotten, we will give him so much vaccine that this time he will not forget for sure, and he will get confused where to emit gas and which hole is for vaccine. So forgotten again can be either clean, less than 6 hour, or dirty. Other wound, not dirty. We write other. If it is clean, F for forgotten, F for full course. We give full course. So whenever it is forgotten, we give full course. Full course means 5 tetanus. Full course of TT we give. And dirty also we give full course TT, but along with full course TT, we add tetanus immunoglobulin. So again, remember, till 10 year, it doesn't matter clean or dirty. Less than 5, always wash. 5 to 10, DTT. After 10 year only, if it is dirty, we add TIG. And forgotten also, if it is dirty, we add TIG. Tetanus immunoglobulin. But we don't need to add tetanus immunoglobulin if it is clean, less than 6 hour, and non-penetrating. Okay. So with this concept in your mind, let's do this question. Last TT taken 10 year back. Ball boundary pe tappa le li. 10 year back, patient came with dirty wound. What is the correct management? 10 year back. What is the answer? Do you add TIG or not? Remember, we add TIG if there is one of the two cases. If more than 10 years or forgotten, and both of it should be for dirty wound. So dirty is there, but it's not more than 10 years, it's just 10 years. So just 10 years, better is wash plus DT. Unless you see the word more than 10 years, only then you will use TIG, otherwise you will not use TIG. Okay. And the real question which actually came in NEET exam was not having the dirty word, came with clean wound tha. Suppose I replace dirty word and I made it clean. So if it is clean, again the answer will be wash plus TT. If it is dirty also, answer is same. And in one of the NEET exam, they gave that last vaccine was in 2015. Now patient came in 2022 with dirty wound. What you will do? 2015 you took the TT, and 2022 he came with dirty wound. So how many year gap? 7 year gap. And remember, 5 to 10 year, what we do in 5 to 10 year? Any case we give 1 TT. So if it came in 7 year, still the answer will be B, wash plus DTTT. Okay, so I hope this tetanus treatment will not be an issue and you will answer it very well. Okay, still if it is confusing, feel free to ask. Chandra, is it clear or not? Do let me know. Chandra is crying, I don't know why. Sterile love, he's saying, and then he cry. Don't cry, bro. Do let me know. Chalo. So we are done with this part of vaccination, tetanus, and the route and diluent. Route, diluent, done. Open vial policy we have discussed in our first session, that for remembering the vaccine who follow open vial policy, just say it with me, Hep B, PCV, all tetanus, all polio. So open vial policy is followed by Hep B, PCV, all tetanus, all polio. They are the vaccine which we store between 2 to 8 degrees Celsius For next 4 weeks, we can use them. And all tetanus, of course, means pentavalent, means DPT, means tetanus, and it also means DT, diphtheria tetanus. All polio means OPV, IPV. So this vaccine we will keep. These are the vaccine which we will keep. Rest vaccine we will throw. So this vaccine we keep till next 1 month if they are stored adequately between 2 to 8 degrees Celsius. Okay. So next is vaccine vial monitor. We think we know it well, but still they ask it again and again, and under exam pressure student get confused. Remember, if it is same color, do not use it, discard it. If the center is dark, do not use it. Because the image is taken from white background to black, so it is wrong. Let me draw it completely. If I am drawing it in such a way that the center part is completely okay, and the peripheral part is having the darkness. So can you use it? Answer is yes. Because the peripheral part is dark, not the central, use it. If we have it like this, that central part have one line, but majority of darkness is outside, then also we can use it. But if it become the same color, center and outside is same color, never use it. And if the inner one is dark, inner square is dark, then also don't use it. And we all know that. Don't do mistake here. Cold chain, of course, start with cold room, which is at district and state level. Then people take the vaccine to ice line refrigerator, which is at PHC level. From ice line refrigerator, it go to vaccine carrier or day carrier. Day carrier has 2 ice pack. So when you see from above, it look rectangular. But vaccine carrier has 4 ice pack. So when you see from outside, it look square shaped. Remember, maximum ampule which can be carried for vaccine carrier is 20 ampule. देखो, वैक्सीन कैरियर में 4 आइस पैक होते हैं, हर आइस पैक मैक्सिमम 5 ले जा सकता है और एवरेज 3 से 4 ले जा सकता है. So because vaccine carrier has 4 ice pack, maximum it can carry is 5 per ice pack. So 5 into 4 become 20. 20 ampule is the maximum carrying capacity of vaccine carrier. Okay. Now, one more question they ask in the NEET exam from here is that in the ice lined refrigerator, which has a special type of thermometer, dial thermometer, which thing we keep at the base? That is the question. This is an ILR. ILR is just like any ice cream keeping thing which is on the ration shop also. It's just some differences there, not big thing. Like the one under which we keep ice cream. So the question which they ask from here is, what you will keep in the ILR base and what you will keep at the top. So remember, base is the one which has stable temperature. And we need a stable temperature for live vaccine. Because live attenuated vaccine, if you will don't give them good temperature, they will become useless. So which vaccine will be at the base? At the base, we will have the live vaccine at the base. This will be at the base. Now, what are the live vaccine? I hope you know. First, I said all the vaccine which are given oral is live. So OPV is live. Rotavirus is live. Typho oral is live. Very simple 3. Then I hope you know BCG and MMR, they are live. MR or MMR is live. Then after BCG, MMR, OPV, Rota, Typho oral, one more is yellow fever vaccine, which is also live. Okay. Then other than yellow fever, one is varicella, whose strain is Okka strain. Savila vila, Savila vila. It's time to Africa. That is also live. Okka strain. Varicella. So these are live. How to remember the live vaccine? Remember it in a group. Yellow varicella together. BCG, MMR together. And oral vaccine are all live. So it's not need to remember also. So BCG, MMR, yellow and varicella. Can you remember these 4 names? Yes, you can. BCG, MMR, yellow and varicella. I can create a mnemonic, but the problem with mnemonic is first you write the mnemonic, then you decode it, then you take out the meaning. So it can be confusing and time taking. We remember the mnemonic, we forget what is inside it. So just make it simple. BCG, MMR, yellow fever, varicella. These are the live vaccine. Of course, JE live we use in India, but JE can be killed also. And then on the top, we will have FIPV, which is killed. Then we have the rabies vaccine, which is killed. Then all tetanus vaccine we can keep in the top. Okay. So do remember, it's not the very top. Very top are the diluents. We keep these things in between. In the center, we have FIPV, rabies and all. More top are the diluents also. Diluents we can keep here. Okay. So do remember that base will have the live. So they will ask which of the following vaccine will be at the base of ILR. You have just to tick the live vaccine. Second thing about it is, these are the live vaccines which are contraindicated in all the people who have immunocompromised condition, like contraindicated in nephrotic syndrome child with steroid and all those things. Let's come there. Yes, this is the point which I am saying. There is a child, question is a child with nephrotic syndrome on steroid, or the child is HIV, or in pregnancy. All live vaccines are contraindicated. Except there is one exception, that pregnancy yellow fever vaccine can be given if there is emergency. Then we can give yellow fever vaccine in pregnancy only in emergency. Usually we don't give it. So usually in pregnancy and HIV and immunocompromised condition, live vaccine are not given. So they will ask that which of the following live we will not give. So that is the reason why we should remember all the live vaccines separately, because they will create this question that which vaccine will not be given and live vaccine are not given. And there are total 11 live vaccine. We just remembered this MMR BCG together, varicella yellow together, and rota typhoral together. We have remembered the remaining this part, 6 part. From 6 to 11, this 6 vaccine we remember. The upper part 5 vaccine can be remembered by the mnemonic CP IJO. Come to CP. CP is Connaught Place in Delhi and center point was in Aligarh. And whenever we, in our time, we have to date, we used to call the boy or girl, come at CP. It means we will have good time together. So CP IJO is the mnemonic. Why? Because these 5 vaccine, cholera, plague, polio, influenza, JE, these are live also, killed also. So usually when they ask question from live, they will not ask from these 5 because they can be live or killed both. They will ask from the remaining 6, MMR, BCG, yellow fever, varicella, and then oral, that is typhoral, rotavirus. Okay. So if they ask what are killed vaccine, again so simple. You just have to remember 2 things: hepatitis A, rabies, because remaining can be remembered by CPP IJO. Come to CP IJ. Cholera, plague, polio, influenza, JE, they are both live and killed. Then they can ask what is protein vaccine. Very simple. P for protein, P for pertussis. Pertussis, protein. What is toxoid? Toxoid is DT. Remember, DT is given at 10 and 16 year. Which vaccine we give at 10 and 16 year? DT, not TT. 10 and 16 year DT we give, which is together toxoid. Cell wall vaccine can be pneumococcal, meningococcal, and VI polysaccharide for typhoid. Last thing is recombinant vaccine. Example is hepatitis B vaccine. The question they ask is which part of hepatitis vaccine they used. HB, surface antigen they use. Because if you have surface antigen, then antibody will recognize the hepatitis virus from the surface and it will not be able to enter inside human also. And that is why for corona also, all the vaccine was against the spike protein, because you have to identify the surface, the initial part, so that the virus will not enter in the body. Okay. So always remember S component, surface antigen and DNA will be there, and it will be recombinant vaccine of corona, recombinant vaccine of hepatitis. Sorry. So now cold chain we have already discussed. All the category we have discussed, live, killed. Let's read about vitamin A dosing also. And rabies vaccine we can read. Rabies, vitamin A, we will discuss. And one last, this line we will discuss. Rest all vaccination part will also be covered. And then we can end the session. So when we say pentavalent vaccine, this was an ICT question. What are the things in pentavalent? Three things is DPT. Of course, one is hepatitis B. But one thing is Haemophilus influenza type B. So these are the 5 things in pentavalent. This is a common question that if a patient has sickle cell anemia, DPT, sickle cell anemia, old age, HIV or post-splectomy, which vaccine do we give here? So we give pneumococcal conjugate vaccine. Because in old age, what is the most common infection which kill them? Pneumonia. So we have to give pneumococcal conjugate vaccine to protect them from old age, HIV, post-splectomy, immunodeficiency condition. We give pneumococcal conjugate vaccine. And remember this thing, that pneumococcal vaccine and FIPV, these are giving at 6, 14 and directly at 9 months. So 6 week we give, 14 week we give, and directly at 9 months we give PCV and FIPV together. And if anyone is immunocompromised, we give PCV, pneumococcal conjugate vaccine. We give 2 doses of DT at a gap of 4 weeks anytime during pregnancy. So if they create a clinical question that woman is coming in labor, will you give DT? Yes, we can give it there also. Anytime means anytime. We can give it in first trimester also. And if the mother is already pregnant in last 3 years and had taken 2 DT at that time, then we don't give 2 DT, we just give 1 booster TT. Are you understanding it? Suppose I am the mother, pregnant mother who came to you and you ask कि when were you pregnant last time? कब माँ बनी थी? मैं बोला कि पिछले साल ही माँ बनी थी डॉक्टर साहब, क्या करूं, मेरा मुंह खसम छोड़ता ही नहीं है, हर साल माँ बना देता है ना, my husband make me pregnant each year. So then you will ask, have you taken 2 DT in last pregnancy? If I say yes, पिछले बार ली थी क्या 2 टेटनस? मैंने बोला हाँ, then you will give me only 1 booster. But suppose you ask when was you pregnant last time and I said 4 years back, डॉक्टर साहब क्या करूं, मेरा मुंह खसम कुछ करता ही नहीं है ना, my husband don't do anything, so I was pregnant 4 years back and now only I am pregnant. So if I was pregnant 4 years back, definitely the gap is more than 3 years, you will give me 2 DT. But if the gap is less than 3 years and 2 TT is taken, then only 1 booster is given. I hope it is clear. Do let me know if it is not clear. Then let's also talk about the immunization schedule. I'm trying to skip that part, but why to skip? In the immunization schedule, you just have to keep doing 3-5, 3-5, 3-5 and you will remember it. 3-5 करना है आपको. 3-5, 3-5 you will do and you will remember it. First thing is at birth. At birth, what are the 3 that we give? OPV, Rota and Penta. No. OPV, Hep B and BCG. And for these 3 vaccine, no payment to ASA. Because in these 3, mother and mother-in-law are in the hospital, so ASA cannot motivate them. And whom ASA will motivate? Sasurji, father-in-law. There is no one to motivate, so ASA do not get the payment. OPV, Hep B, BCG. Now, when it comes to 5, at 6 week, we give 5 vaccine. Very simple to remember. OPV, Rota, Penta. The good thing is, the same OPV, Rota, Penta is repeated at 10 week also, 14 week also. So OPV, Rota, Penta, 3 vaccine goes at 10, 14 also. OPV, Rota, Penta, 6, 10, 14. OPV, Rota, Penta, 6, 10, 14. Okay. After 6, 10, 14, as I said right now, that when you have FIPV, PCV, this FIPV, PCV, you give 6, then you directly jump at 14, 2. So that's why at 14, 5, but at 10 week only 3 vaccine. And 6, 14, फिर 9 महीना आपको भी पता है. 6, 14 and then 9 month. So at 9 month, we repeat this to FIPV, PCV. So the secret to remember the immunization schedule is remember this half separately. Can you remember up to this part? Yes, you can. Birth, you already know OPV, Hep B, PCV. This part is so simple. OPV, Rota, Penta, 6, 10, 14. FIPV, PCV, 6, 14, 9 month. That's all. I hope you remember this much. Yes, you have to say yes, okay? Now, let's focus on the 9 month part. We give vitamin A 1 lakh, MR and J. The good news is the same vitamin A, MR and J also get repeated at 16 to 24. So the same three are here. So easy to remember. And at the 16 to 24 month, we add to vaccine DPT and OPV booster. And the same two booster which we give at 18 also goes at 5 year. So we start with 3, mother, child and father. And at 5 year again 3. What are the 3? Vitamin A, 2 lakh, DPT and OPV, 3 things. Okay. And last thing is 10 year, 16 year, we give DT and 2 DT at 4-week gap in pregnancy. So this is the complete immunization schedule. Remember it into this half before 9 months and then after half, and you can do it. After the class, write it yourself. It will be much better. Let's talk about rabies. In rabies, if you are giving vaccine to veterinary doctors or dog catcher, you will give 70721. Because one very risky work which veterinary doctor is doing is they are making the dog to have sex. And if any dog do not like the partner, whom they will bite? Veterinary doctor. So they are ready before it. So they will take on 3 days 0721. Now suppose someone has, like me, has taken the vaccine full, but the dog is yet not satisfied and bite me again second time. So then I need to take it on day 0 and 3. So 0 and 3, 2 dose only post vaccination, but pre-vaccination 3 dose 0721. Do not forget it. Now let's talk about these two regime, intradermal and intramuscular. They ask which one is better. Remember, intradermal is better. That's why in all the government hospital we have intradermal. Why? Because intradermal we give on day 03728 each day 0.1 ml on each deltoid. So total dose is only 0.8. But when we give IM, the 0.5 ml we give 5 days. So total dose is 2.5. There is a lot of wastage in intramuscular. And schedule, I hope you know, 037 1428. But remember, if dog alive, it means dog was not having rabies. So if dog alive, after 10 days, no need to take the vaccine of 28 day. And that 28-day vaccine can be missed. Because dog is alive, so he is not rabid. If dog is not rabid, then why to worry? Now let me ask you one question. You might have seen many Instagram video and reel कि कुत्ता आया और लपलपा के किस दे गया, smooch कर गया, lip to lip. So if there is a lip to lip smooch between a girl or a dog and a girl, or a boy and a dog, will you give immunoglobulin or not? Answer is yes, because it is mucosal saliva on mucosa. You have to give immunoglobulin. Very serious, category 3. Now suppose my neighbor dog, which is very rascal and naughty, he came and scratched on my bum. I don't know how, but did. And I had just 1 drop coming out. Will you give me immunoglobulin or not? Answer is again yes. Even if 1 drop of blood is there, category 3, immunoglobulin. Mucosal lick, immunoglobulin. Third point, if dog came and scratch on my face, no blood, but scratch on my face, again category 3. And last, if there is chamgadad kata, bat bite, that is category 3. So if you remember category 3 separately, it's very easy. Category 3 have 4 things: bite with bleeding, any 1 drop also, licking on mucosa, scratch on face, or fruit bat bite. All is from a Park textbook, please trust it. In these 4 cases, we always give immunoglobulin. If there is a scratch on my bum without bleeding, only wash and rabies vaccine. And if there is licking or nibbling on intact skin, not on mucosa, then we only wash. That is category 1. And when we give immunoglobulin, in the immunoglobulin, if someone came and bite my bum, will you give me horse immunoglobulin or human? Hey, give me human or I will die like a dog. With anaphylactic reaction can occur with horse. So they ask, what is the dose of human immunoglobulin? 20 international unit per kg. If my weight is 100, you will give me 2000. 1000 near the butt, 1000 IM. But if you cannot give near the wound, then you will give full dose IM. But remember the dose 20 international unit per kg. Okay. Then Total dose of vitamin A which we give is 17 lakh. And total number of visit for this is 9 visit. This is a common area of question, so let's understand it. Why 17 lakh while 9 visit? In the first year, mother bring the child only once at 9 months and she get 1 lakh. Then in the second year, she bring the child 2 times 2 lakh. Third year also 2 times 2 lakh. Fourth year also 2 times 2 lakh. Fifth year also 2 times 2 lakh. So you can count the visit. 2, 4, 6, 8, 1, 9. 9 visit is there. And you can count the dose. The dose is 1 plus 4 plus 4 plus 4 plus 4, 17 lakh. Okay. So this is how we do in national immunization schedule. That was one question being asked in MCA already. In national immunization schedule, 1 lakh in 1 year and then 2 lakh every 6 months till 5 years. Okay. Now, this is the regime for prevention. But suppose some child have vitamin A deficiency. If there is gerophthalmia, already there is a dry eye or vitamin A deficiency. Then in case of gerophthalmia, we give day 0, 1, 14, 3 doses, 0, 1, 14. And it depends on the weight. Weight less than 8 kg, 1 lakh. Weight more than 8 kg, 2 lakh. Let's learn about 3 more things. Aluminum hydroxide is used as a adjuvant in DPT vaccine. So adjuvant in DPT is aluminum. So simple to remember. A for aluminum, A for adjuvant. Adjuvant increase the surface area of action and make vaccine more efficacious, more effective. Then thiomersal is also used in DPT but as a preservative. So thiomersal is preservative in DPT, again same thing. MgCl2, magnesium chloride, is used as a stabilizer. This is used as a stabilizer in OPV. So now how will you remember these 3 under exam pressure? Very easy. We all know that chlorination is done in swimming pool and other place to kill the bacteria. So chlorine is the one which will keep the live virus of OPV in stable condition. Chlorine stabilizes live virus of OPV. So because chlorine is stabilizing live virus, and out of DPT and OPV, live one is only OPV. So MgCl2 is only used in OPV because it is chlorine work is to stabilize the live virus of OPV. Okay, rest 2 are in DPT, and we already read A for adjuvant, A for aluminum hydroxide. And if you write the full form of DPT, of course, the real full form is diphtheria, pertussis, tetanus. But there is one more full form. DPT preservative thiomersal. So like that also you can remember that in the DPT, the preservative is thiomersal. DPT preservative thiomersal. So you can remember all of it. And that's how we finished all this vaccination, disaster management, all these topics which I was targeting for today. I hope you had a good session, very informative and useful. Tomorrow from 2 to 5, we have a discussion of 100 expected question. But this discussion is going to be in Hindi mostly. English discussion they have written, but mostly Hindi will be there. 100 expected question we will discuss. 2 to 5 tomorrow, that means 13th. 2 to 5 we will have this discussion of 100 expected question. So I wish that will be also useful to you. And one doubt of Himalayan is, sir, one doubt. IFA tablet 400 or 500, how to choose? 400 or 500, how to choose? Very simple actually. Very simple for me because I have to teach only one subject. Not so simple for you because you have to learn a lot of subjects. So let me get a blank page or just, yes, add it. Yes, the point is very simple actually. when we are talking about 5 to 9-year children, you can see the age difference is 4. So in 5 to 9-year children, we give 400 microgram folic acid and 45 milligram iron once a week, pink tablet. So only for this age group, we need 400 microgram folic acid. 500 microgram folic acid plus 60 milligram iron. This is the dose which we give once a week for adolescent. With which color? Blue color, because this is the time 10 to 19 year when you watch blue film for the first time. So that is the time when you get blue tablet once a week. Then this is once a week also for, achha, let me write it in yellow only, for adult female. Okay, but those adult female whose hemoglobin is more than 12. So they are not anemic. This is for those adolescent whose hemoglobin is more than 12. I'm talking about female only. If it is male, for male the hemoglobin should be more than 13 to be normal. For female, hemoglobin more than 12, and for pregnant female, hemoglobin should be more than 11. Then we call them non-anemic. So this adult female, they get red tablet, and they both, adolescent and adult, they get the same dose once a week, but once a day for 180 day before and after delivery. This is for pregnant and lactating mother, and of course this color is also red. Okay, but we also have one last thing. Sometime we give twice a day if HB less than 11 in pregnancy, or HB less than 12 in adult female. If you are treating anemia, then you give twice a day tablet. If you are preventing anemia, then you give once a day in pregnancy and lactation. And in adult female and adolescent, we give it once a week, but in pregnancy lactation, we give it once a day. So this dose 560 milligram is for all of them, but this dose 445 is only for pink colored children. Okay, if you just remember one last dose, it will be complete revision of Anemia Mukt Bharat. 20 milligram iron and 100 microgram folic acid is given twice a week. For which children? For 6 months to 5 years. So if you see, it is 5 years, and if you multiply 20 with 5, this is also 100. So 20 and 100 is given twice a week. Only one dose of less than 5 years twice a week. Rest all are either once a week or once a day. But in treatment, we give it twice a day. Okay, so very good question, dear Chandra. Because of your question, we discussed it all. Okay. Chandra is asking one more question, and Vaibhav is saying, love you, sir. Love you, dear. Love you. Hello. Now, Chandra is asking question about trench method, trench thing. I don't know the trench method, but I know the question which they ask from shallow trench and deep trench. See, this is the two type of toilet which we dig, and deep trench is the best latrine if we are talking about soldiers who are going in camp, because if there are many soldiers, we cannot have pit hole or bore hole for them, otherwise they will stand in line, and imagine the pressure in the last person standing in line. And so what we do, we dig a big area and we let them sit and do it together, and facing each other bum. But if it is shallow trench, We cannot cover it with mud and it can pollute the surrounding. If it is a deep trench, we can cover it with mud and it will not pollute the surrounding. So deep trench is the best latrine for soldiers in camp when they go. For trench, I only know this much. If you want to know some other thing about trench, you can always let me know. Himalaya is also saying, love you, sir. Love you, dear. Thank you, Jessica. Thank you, Vaibhav. Thank you, Himalaya. Thank you, Gauri Saha. Thank you, Nitesh Kumar. Thank you, Chandra bro. Thank you, Rudraksh. And thank you all of my other friends whose name I am not taking, but who are so actively participating in the group. May we meet tomorrow again at 2 p.m. to discuss 100 expected question. Love you all. Keep rocking. Keep enjoying the journey. Bye-bye. Thank you so much. Hasta la vista. Das vidania. Thank you. Bye-bye. Baka baka. Thank you.